So we can start this session. It's a session on best bifurcation PCI tricks. You have, I am one of the chairmen, and together with Mila Kovacevic, Nigel Jepson from Australia, and the panel there is Sarita Rao from India, Farah Fulavan from Italy. Excuse me for the pronunciation, Hamid Reza Sanati from Iran, Merzan Sagatelian from Armenia, and Von Voyaches from Czech Republic. So each case have, each presenter of the cases, there are 5 cases, has 14 minutes in total. So we have some discussion at the end if the presenter will have maybe 10 minutes, and for discussion 2 or 3, 4 minutes, depends on the type of presentation. So we can, I think that we can start with the first presenter is Josica Civic, and the title is New Tools and Leave Less Behind.
All right, so ladies and gentlemen, dear colleagues, it is my pleasure to be again here with you, and also it is my honor to open this EBC 2024. So my talk will be about some new tools and how about to leave as less as possible behind. So this is a story about a male. He is 1949 born. He came to the CCU due to STMI of inferior segment, and he had also heavy block of 2nd and 3rd degrees due to benzodiazepine chemical reaction. And we transferred him immediately to the cath lab. So he had also myocardial infarction previously, and it was 2008, and at that time he received the BMS on RIM, and he suffered from hypertension, hyperlipidemia, atherosclerosis, he had a PAD, and he is unfortunately a smoker. So this is one very simple occlusion of RCA with a simple solution with 1 stent, nothing special. But what we found on the left, there is some trifurcation lesion. As you can see, there is a long lesion on the LAD and also on the ostial part. There is quite a nice stenosis of proximal part of rim, just in front of the stent. That means that is in segment lesion, because stent is just 2 millimeters from the ostium, and there is some narrowing on the ACX as well. And on that right side, you can see that there is a bifurcation lesion with diagonal branch, that there is a lot of calcification as well. And you can see that we have a dominant septal branch and subocclusion with the calcification of LAD. So this patient had low ejection fraction. It was about 35%. He had a MR moderate and a little bit bigger left ventricle. So we decided to put IVAC, not just for him, but also for our convenient, because we thought that we will feel safer and better if he had IVAC. So we implanted IVAC, and you can see here that the situation what we have on the left branches. So I took a Grand Slam. It was a little bit problem with the ostial part due to calcification. Grand Slam is, the reason from Grand Slam is rota. So I made rota ablation with Rota Pro 1.1025 because it's a really heavy calcification. You can see here there is some trouble in that diagonal, not the diagonal, but on the bifurcation with the diagonal branch, and also in bifurcation with the septal branch. You can see this work how is going, but finally I passed with 1.5. And after that I had this result. I lost the LAD and the septal branch as well. I think that it was because of the dust of calcification, but also maybe I have some ruptured plaque. So I took a Wolverine cutting balloon and I cutting that stenosis, and this was the reason. So I thought, okay, it's good enough and I can treat this vessel with DCB. Then I move further and treat the LAD with scoring balloon because this calcification was not so heavy, and then I took another DCB. This is a result which is not, I think, optimal, but is acceptable, and both balloons are paclitaxel balloons, so I was counting of late lumen enlargement. So I moved further to the proximal part, and as you can see here, I treated LID, but I had, unfortunately, dissection because my idea was at the beginning to treat the LID with the DCB as well. So I treated the rim with the balloon and then with the DCB, and I checked this ACX because this narrowing on the ostium looks worse than on the previous picture, but it was still insignificant. So I implanted two DCB, one on the proximal part and one on the distal part. If you remember, there is a problem on the distal part of rim as well. So after implantation of this of LAD and left main and the pot, this was the result. This patient had a cardiorenal syndrome, and at that point I didn't use OCT, so I let him go. What happened? Something happened. He didn't die. He felt good. I checked the presentation just a few minutes before and everything was fine. Can you go back? Yes. Static again, okay. I will show you. So what I perform is...
Sorry, the computer freeze, just we restart it
Okay.
and we will be able to put the presentation. Sorry for that.
Okay. Discuss. Yeah, of course, we can discuss so far.
Yeah, what was the idea and reason to use... maybe it's... Sorry?
So, okay.
Okay, good.
This was a rotacut, you saw it. This was a bifurcation. This was a left main and LAD. And, okay, so I just took a stent boost. And you can see here that is quite a good position of stent in left main and LAD. And it's a good expansion. But maybe you can see here. Stop. There is a loss of calcification, but it's calcification out of the stents and of the lumen. It looks like that on this picture. So I occluded the puncture place with the two prostyles. I performed DSA and I let him go. So maybe we can talk about it now, or I can maybe finish. Okay, so a few months later he came again. He had all the therapy for heart failure, and now his ejection fraction was about 45. His MR wasn't so moderate anymore, it was mild to moderate, and his left ventricle diameter was even better. So his EGFR is also going better, so I perform angio, and it looks good. And you see also this wire, and that wire is because of the OCT, so I took OCT. we spoke a lot about the saline, especially my friend from Lucerne, he enjoyed saline so much. So I tried to use the saline and the contrast, and so this is the result with the saline. There is lots of blood, but it is readable. And this is a result with contrast. It's much better picture. But on the both picture, you can see that there is some problem with the stent expansion, and that was on the point of that high calcified plaque in the proximal part of LID. So I treated with balloon, and I thought the result was good. So what is the case learnings? That IVAC is good. It gives us no more than 2 liters, maybe 1.8. I think that is optimum what IVAC can give us. It needs about 70 Frenches, 17, which means that is quite robust tools, but it is cheaper, much cheaper than Impella. And it's a good, and we have some good results from the studies in high-risk patients, and also help us to feel better. I think that the DCB option is very good for DCB only treatment, but sometimes is for DCB as a hybrid option, because we will have a less stent burden, and maybe we can reduce the MACE. Last year in Warsaw, we were talking about OCT, and we said the OCT must to do in the bifurcation lesion, so I did it. And I think also that OCT give us lots of information, and it is proud also with this case, because you saw that on the stent bust that the stent expansion was excellent, but there is also huge geographical miss. And also in the case of low EGFR, we can use heparinized saline instead of contrast to save the rains. So that's all. Thank you.
Thank you, Jos. It's a really great presentation. A lot of tools that you showed us used in one patient. And I wanted to ask, what was the reason for IVAC? Because the patient in primary PCI, during the primary PCI, he had occluded RCA and left coronary system, which was severely diseased, and he survived this primary PCI. However, I understand, like cheap patient, low ejection fraction, and a lot of things to do in the setting of left system of the left coronary artery. That's why I probably use to be more secure during the procedure. And what was the reason? I like really to use DCB when it's possible, feasible. And so you use rotablation, cutting balloon, and the DCB, and the result is good. And really, this is one of the examples that it can be done also in severely diseased and calcified lesion DCB. So just maybe, this was just a comment. I don't know what to add, but really nice example.
About the IVAC, I was thinking about to do or not to do, because often I perform such kind of lesions without anything. But this patient had a 2nd and 3rd degrees AV block. As I said, it's because RCA and also that basohyaris chemical reaction. But I was afraid because there is a lot of calcification, and it was a heavy calcification, and a long part of the LAD was calcified. And I was afraid what will happen when I will pass with the burr. Will I lose just LAD, just the diagonal branch of both? So, I lost LAD, as you saw. So, and that moment when I lost LAD, in that moment I really need that IVAC, because I had a hemodynamically disturbance with that patient, and also I had again AV block of 3rd degrees, and his blood pressure drops down. So I was really more comfortable with the IVAC. And as I said, it's not good as Impella is, but it's supportive.
No, it's a really good example. I really liked this occlusion of LAD, and which is solved with the cutting balloon and the DCB. For me, this is the major point. Like a lot of tools in one artery, and with the final good result.
I had one explanation. So you stented the LAD, but you stented also where you did the middle LAD.
No,
the stent, there was already a stent there?
No.
Because I see a long stent from left main to middle LAD. So you stented up to after the diagonal.
No, that was one stent. So that was a calcification. I put the stent from left main to the LAD. That was one stent.
Where? The middle AD or
no,
proximal?
The mid LAD was calcified, so it looked like a stent. It's not a stent. And this bifurcation between diagonal branch and the LAD was treated with only with the DCB.
Only with DCB?
Yes.
Because at the end, the images, it looked like there was a stent also across the diagonal.
No, it's just one big stent.
So you had low flow post rota. So issue was, would you have first taken a cutting balloon straight away? Because the calcium, though it looked adventitious, because it's an acute MI PCI, it's an inflammatory state. So we would not prefer to use the rota straight away. That's number one. Number two, the angle at the ramus and the LAD was very narrow. So whether you really want to put a stent there or you just put a kissing balloon for the circ, if you do a circ and ramus imaging, if you feel there is, just do a kissing balloon and DCB and just leave it alone. Because if you see your angle is, in narrow angles it is, especially in this setting, it is advisable not to put a second stent there.
No, this is the first stent from 2008. This is the first one. You know, he had acute MI 2008, and that was the first BMS stent at that time. So he had only that one stent before this procedure, and that was that stent of a rim, what you saw, and that was a BMS, and it was 2 millimeters from the ostial part of the rim. So this was in segment restenosis because this new restenosis also impact this ostial part. So I treated that only with DCB.
Okay, no, I think in the interest of time we'll move on. So thank you very much for that excellent presentation, the complex high-risk patient. Thank you. So
thank you.
The next speaker, good friend Yoshi Murasato from Japan, and he's going to present a case, stentless coronary intervention for left main and multi-vessel disease. Thank you.
Thank you, Chairperson. My topic is left main traffication region and multiple CTO. The case is of a 51-year-old male was severe for angina. In his 30s, the patient battled the obesity, body weight more than 100 kilograms, and heavy smoking, 80 cigarettes per day. A decade prior to the presentation, he successfully quit smoking and adopted a healthy lifestyle, including regular bike cycling 40 kilometers per day, resulting in a significant weight reduction to 75 kilograms. The patient experienced chest oppression and dyspnea during bike cycling over the past 6 months, promoting consultation at a local hospital. Coronary CT angiography revealed severe calcification and tight stenosis involving all 3 major coronary arteries. Given the complexity of the cases, the patient was referred to our hospital for further evaluation and optimal treatment. Despite comprehensive discussion regarding the risk associated with his condition and the potential limitation of coronary intervention, the patient emphatically declined CABG. His risk factor is dyslipidemia and ex-smoker. This is a baseline coronary angiography. Here you can see the left coronary artery, proximal LAD, and proximal LCX has a severe stenosis, tight stenosis. And distal left main also had a moderate region. Therefore, left main 1110 trifurcation region. And middle LAD has been totally occluded. And terminal LCX also totally occluded. This is a right coronary angiography. Here you can see distal RCA also totally occluded. Proximal part of the RCA also has a significant stenosis. And well-developed collateral from RV branch to LAD, and some collateral was found in the PD branch. Syntax score accounted for 46 points. Therefore, we persuade him to undertake the CBG. However, he declines the CBG. He eager to undergo the PCI. So we decided to treat the patient with PCI. First session, we planned the RCA CTO PCI. The coronary angiography revealed the microchannel in the CTO region. Fortunately, tapered wire XTR crossed the region, and we treat the RCA with the proximal part Zion's 3.5 by 48 stent, and the middle to distal part 3.0 by 48 drug editing stent. Some collateral was found from PD branch to septal branch. So we expected the development of the collateral, and 3 weeks later, we waiting for 3 weeks, and we tried to fix the LCS system. Firstly, we performed the LAD CTO PCI. Here you can see the simultaneous coronary angiogram from both RCA and LCA. Some microchannel can be found. So we approach with a Gradius slippery CT wire, and then change to the XTR wire, tapered wire. Fortunately, the guide wire progress into the distal side, and we treated with this CTO region with 2.5 by 48 millimeter stent distal LAD, and the middle part 3.5 by 34 millimeter stent. And then we move to the left main trifurcation region. Here you can see there is a tight region in the proximal LAD and SX, and the region location is a contralateral side of both branch. So up to this procedure, we spent 4 stents for the 2 CTO PCI. So we decided to treat this region with stent-free strategy. So we use directional coronary atherectomy. Directional coronary atherectomy with a special catheter, atherocat catheter. This catheter has a window, and the window faces to the atheroma, and the contralateral side of the balloon inflated, and face to the atheroma, and put the catheter for the resection of the atheroma. And deflate the balloon and rotate the catheter, and another direction we rejected the atheroma again. Rejected tissue stored in the nose cone. And we rejected the atheroma, firstly left me to LAD 30 cut. And then we remove the catheter and advance to the SX, and we add the 20 cut for the SX ostium. And then we treat this region with a drug-coated balloon with a agent 3.5 by 50 millimeter for SX, and left main to LAD with an agent 4.0 to 20 millimeter drug-coated balloon. And this is the IVAS images. Before this is a pullback from the LAD to left main. Before the DCA, significant plaque was found in the proximal LAD and distal left main. After DCA, here you can see the significant plaque was rejected. And this is a pullback from the LSX to the left main. LSX ostium has also significant plaque. After DCA, this plaque has been rejected. Finally, the minimal lumen area is enlarged from the 7.3 millimeter square to the 10.4 millimeter square in the left main. In the LED, 3.8 to 7.3 millimeter square, and LCX 1.5 to 7.4 millimeter square, and the percent plaque area reduced to less than 60%. It is like the stent-like finding. This is the final CAG. Here you can see sufficient lumen gain was obtained in the left main trifurcation region, and the complete revascularization was achieved except for the terminal L6-CTO, which relieves the anginal symptom. Ladies and gentlemen, this is my take-home messages. A physically active young male with complex element trifurcation region with 3 vessel CTO regions underwent PCI, which had required 4 drug-edited stents for 2 CTO PCIs. In order to complex 2 stenting element trifurcation region, sufficient plaque debarking with directional coronary atherectomy was followed by subsequent treatment with DCB. The application of the DCA plus DCB in the complex element region reduced the potential risk of stent thrombosis in the elevated state of the coagulation associated with multiple stent placement. Thank you for your attention.
Thank you, Yoshi. Fantastic case, very complex disease and combination of stent and DCB. Given that the location of your DCB was left main bifurcation, are you concerned, given that prognostic territory, of a lack of scaffold leading to significant TLR and TLF beyond drug-coated balloons in smaller vessels and more distal vessels? Do you want to comment on in the absence of data, DCB in native vessels, prognostic vessels without a scaffold?
Especially such kind of topic problem, we use directional coronary atherectomy. So reduction of the plaque, that is very important. So we set the cutoff value for the DCB treatment. Percent plaque area less than 60%. That is the cutoff value for the treat DCB or treat or drug-edited stent. So reduction plaque to the less than 60%. So we can achieve. We treat this left main trifurcation region with a stent-free strategy.
Really excellent case. I congratulate you. I have one question regarding the use of atherectomy device, because I didn't have any chance to see it. And there are different sizes of this atherectomy device or not, and whether are you going to prepare the lesion after this atherectomy with some NC or cutting balloon before applying DCB balloon? How do you know whether if you don't use imaging, can you be sure that you did properly atherectomy?
And as you can see, as I presented it in the IBUS, the plaque burden is very severe. Especially L6 plaque burden is more than 80%. In such case, cutting balloon or squatting balloon is not effective. Especially in such case, severe dissection occurred. So we treat that region with coronary atherectomy. So coronary atherectomy does not cause such kind of serious dissection. So the pretreatment with atherectomy is important, we think.
But after the atherectomy, do you perform NC predilatation again to prepare the lesion for DCB to deploy the drug? Because it's recommendation to do 1-to-1 predilatation with either NC balloon or scoring cutting balloon before.
It is not necessary.
It's not necessary.
Because of the atherectomy, the inchma and the atheroma is rejected. So the drug infiltration is perfect.
Can I ask you, the left main was not critically diseased. It was ostial LAD and ostial circ.
Yeah.
because usually the indication for atherectomy is a focal ostial LED, because if you put a stent, then you have the carina shift, and so this is the typical, and IVUS or OCT guided, and said. But you decided to do both, and you check with the imaging, and then because the left main was not involved significantly, you decided to leave like this without stenting.
This site has involved more than 50%.
Yeah, but it was ostial LED and ostial sphere.
No. Yeah.
It's important to underline this, because if there is some maybe left main, it's better at least to stand from left main to the LED.
Usually when there is ostial LED, ostial circumflex, for sure it's like there is also distal left main disease, like in 80% probably, or even more, according to the IVUS studies. Probably that was your reason to do this procedure. I don't know. Thank you.
Compliments for the case, really fantastic, particularly for us from Europe, because I really, congratulations to leaving left main bifurcation after atherectomy, which is a good case, without stent audio. It's a really amazing case. I mean, you put 4 stents, 2 more stents, I think will change the future of this patient. Anyway, compliments, yeah. Great.
Yeah, especially for some doctors, the DK crash or some complex to stenting perform this complex left main trifurcation lesion. However, it will cause some thrombotic event in the left main.
Final question. When you do DCA on LED, the wire in the circuit, you remove the wire from the circle, or you stay with the wire in the circle? You stay with the wire in the circle. The wire in the circle was not removed during DCA of the LED, and opposite the same, because the wire are, you don't touch the wire with the DCA device.
When I perform the DCA, the only one, like a rotablator, the one guide wire to the LED, and remove, and then advance to the LCX.
So there was the risk to occlude one of the 2 vessels because you removed the wire.
However, the resection of the atherectomy is completely, so it is not, it does not have the risk of the occlusion of the LED.
Maybe allow one question from the audience. Just.
Fantastic case, wonderfully done, and the objective of having a good human preparation for the data which has come from South Korea now about using DB. Using DB in proximal LED and larger vessels is not very encouraging as far as the DCB is concerned. So your comments, and particularly you are dealing with the left main with the bifurcation, and if the patient comes back with problems, it's going to be a difficult issue to tackle that. And this is coming, Jack, the latest one, last. Yes.
Also, is the risk of 2 stents in left main. There is also another risk. So.
However, reduction of the atheroma, plaque, plaque volume is very important. So the only DCA is a device for the atheroma plaque reduction.
So thank you very much for your. No, sorry, for the sake of time. I will introduce Mattia Lunardi with the topic: Is spot side pot enough? A keys to optimize. Let's hear.
Hello, everybody. Good afternoon. Thank you very much for your kind introduction. Well, this is a very illustrative case of the difference between these 2 ballooning techniques after provisional stenting. Well, we are talking about an 81-year-old gentleman, quite fit with few comorbidities, that was referred for CCTA because of effort chest pain, which revealed a distal left main significant stenosis involved with the bifurcation, followed by a fibrocalcific diffuse disease of the LAD. Reason why he was referred to our cath lab. So this is the angiogram on the right system. You can see that the coronary is quite healthy, while on the left system we can appreciate the distal left main stenosis followed by a quite regular lesion of the proximal middle LAD involving the bifurcation with the left main, but also the bifurcation with the diagonal. So the patient was referred to our heart team because we discuss usually all the patients having a left main disease or 3-vessel disease, and the discussion led to PCI. Since we are running a clinical trial in our center, that is the CRABIS trial, comparing the pot-side pot versus the kissing pot technique, we decided to enroll the patient in this trial. And this is basically a technical study where the primary endpoint is the OCT assessment after the ballooning with either the pot-side pot or the kissing balloon. So the patient, since we had to use the OCT for the trial, we decided to use that also for the pre-procedural planning. This is the first pullback before the PCI, where you can appreciate the distal left main stenosis and the long lesion at the proximal and middle AD, but also a patent ostium of the circumflex at the level of the bifurcation and a minimum lumen area at the middle AD of 2.2 millimeters square. So according to OCT, we got some measurement for our stent selection and balloon selection. As you can see, we got eccentric left main with the 4.2 by 3 millimeter, an indirect measurement of the ostium of the circumflex. This is very important to get, even if we don't pull back the OCT from the side branch. That was 2.70 millimeter, and a healthy reference distal diameter at the middle AD. It was more or less 3 millimeter. So we started our procedure with a provisional strategy. The trial provided for a provisional stenting of large bifurcation lesions, ballooning with a good predilation with NC balloons up to 3.5 millimeter at the middle AD and at the proximal LAD and left main, and then we place a first stent at the middle AD, 3.0 by 18 millimeter, followed by stent back to the left main, overlapped with the previous one across the circumflex and the D1 that was 3.5 by 34 millimeter. After that, of course, we proceeded with our POT with a 4.0 balloon. And then a very important step that I want to focus on a little bit, that is the distal rewiring, because either using the pot-side pot or the kissing balloon, this is a very key step of the procedure to get, of course, the best achievable result. And you can check that both through the angiogram using markers such as the marker of the previous wire, the jail wire, or also imaging. In this case, the patient didn't have any problem with kidneys, so we decided to perform an additional OCT run during this step, and you can appreciate from the 3D reconstruction how nicely goes the wire into the last cell of the strut of the stent. So we were happy of this result, and we proceeded with the randomization that was pot-side pot. Accordingly, we dilated the ostium of the circumflex with a 275 millimeter balloon according to the OCT measurement, the first OCT run, and then we did another POT with the same balloon of the initial pot. So the result was this one. That was actually not really satisfactory because we got some malposition that was significant at the level of the ostium and the proximal part of the LAD, up to 450 microns, and also a severe underexpansion of the stent that was 67%. In these cases, we can cross over to the other arm because, of course, this study. The primary endpoint of the study is image-based, but we want to get the best result for the patient. So we cross over to kissing balloon, and we performed a kissing balloon with a 3.5 NC and 2.75 millimeter NC balloons in the LAD and circumflex respectively, followed by another POT. This was the final angiographic result, but let's see the OCT. On the left, you can see the pullback that show a well-opposed stent all over the vessel, and the bifurcation showing a very patent ostium, and also in particular at the level of the proximal LAD where we got earlier huge malapposition and significant under-expansion, you can see now that the stent is well opposed, some minimal malapposition of a couple of strata, but nothing significant. So this is a very nice image that I would like to show you, because the 3D reconstruction, the fly-through mode of the OCT allows you to appreciate a lot the effort that you put in performing a good distal rewiring, because this is very important to avoid any metallic carina, and in case of a pot-side-pot technique, the shift of the metallic carina towards the mid, the lumen of the main vessel. So this is very important. Concluding, I can say that the PSP technique, the pot-side-pot technique, is a good technique, but we can have some, it is limited by some steps that don't allow to get a good position of the stent, in particular, of course, at the level of the distal main vessel, just after the bifurcation core, and some under-expansion. That are two key factors of adverse events at the follow-up. In this particular case, the kissing balloon was able to correct these imperfections, but also because of a good rewiring that was, of course, relevant for to get the result obtained. Thank you very much.
Mattia, excellent case, and I think it's a really important discussion. Pot-side-pot versus the traditional kissing, and congratulations on the study. So the first question: imaging is mandatory with your protocol in this study?
Yes.
Yeah, with OCT.
With OCT, just one run after the performance of pot-side-pot or kissing, but we have the primary endpoint is based on imaging and OCT in particular. Yep. So we
I mean, there's a lot of discussion, despite the bench data, pot-side-pot versus KISS, and we also know from the clinical data with studies, routine kissing versus no routine kissing, there's just mixed results. It can favour routine kissing, it can actually favour keeping it simple. Often if routine kissing is adverse, the penalty is the main vessel. And I think one of the reasons is it's incredibly elegant what you show is using the imaging, particularly to know that you're rewiring in the correct cell, and also obviously not going abluminal. And Niels is not here, I think he's in the other session, but October showed there's the incidence of inadvertent deformation with bifurcations. So I think you've taught us two things, the pot-side-pot and then transitioning to a KISS, but also the value of imaging to know that we're in the correct cell, as well as the final result.
Yeah, of course, angiographically speaking, I don't think we can appreciate these differences, but OCT and in particular this study let us understand which is the differences in terms of geometry of the stents. In these cases, we don't know the clinical outcomes with what will be, but of course, doing it at the best, it's...
Do you, just a question, do you include just left main bifurcation patients or any bifurcation? Because
so
it can...
Large bifurcation, meaning left main bifurcation, or other bifurcation having at least a main vessel 3.5 millimeter diameter,
and
the side branch 2.75 millimeter.
2.75. Okay, because I wanted to just maybe to stress that it's not, it is different. There is a difference when you, in regarding the left main bifurcation and with pot-side-pot and any other bifurcation.
Yeah.
Because the side branch is usually smaller than the circumflex, usually, and then the deformation or the malposition probably is going to be smaller in other non-left main bifurcation lesions. So maybe this pot-side-pot, as you already mentioned, is not so applicable to left main bifurcation lesion. Either pot, like crossover stenting and pot, or crossover stenting with pot-kiss-pot, because of the, as you already mentioned, because of the size of the side branch, which is usually more than 275. This is just my remark.
I completely agree. I think that if you perform a good rewiring even in the smaller vessels, this is true. But if you don't do that, you can have some troubles with the shift of the metallic arena, also in the smaller vessel, and it might be even more dangerous if the lumen is small.
Thank you. About the pod side pod, you used a semi-compliant balloon for the circumflex.
Yes.
You regularly use the semi-compliant, or you can use the NC balloon?
It depends on the case.
Because
in this case, we didn't see any disease, any calcium at the level, the ostium of the circumflex, so we use that semi-compliant balloon just to open the cells and without forcing too much at the level of the bifurcation.
Yeah, we had this case that we did a few days ago. We did a kissing stenting, bifurcation stenting with a semi-compliant balloon. And after the OCT, there was no good stent alignment on the side branch. So after using these two NC balloons of the side branch and the main branch, the stents was quite alignment was good, quite alignment good on the side. That was maybe the pot. If you do it with the probably, I'm not using the pot side pot technique yet, but if you did it with this non-compliant, and maybe if you use it 4-0 on the left main LAD stent, you will finish with the pot side pot, I think.
Yeah, this is a good call. Thank you.
Thank you very much for presentation. Do you use imaging during the study in each case to confirm the distal strut passage, or just for malaposition?
No. It's mandatory at the end of the procedure in this study.
Okay.
But
just to fix distal malaposition or distal deformation
the result.
To decide to do kissing or not.
Yeah, then if the result is not satisfactory to the operator can decide to cross over to the other arm. Yeah.
So one question, Dr. Murasato. Yeah.
I would like to ask where the malabsorption side after the side branch dilation. Usually, side branch dilation is likely to occur the malabsorption is the opposite side of the side branch. Is that right?
Sorry, could you repeat?
When you perform the side branch dilation, malabsorption occurs the LAD. Where is the malabsorption side? Opposite side of the SX?
I can show you maybe the... No.
Yes, it was the attraction because it was not corrected by the pot balloon because the balloon can't reach that malaposition at the ostium. This is the...
So when you use a long balloon, such kind of the malaposition is likely to occur because of the straightening of the ballooning causes the retraction of the strut to the direction to the left main. So the LAD ostium malabsorption is likely to occur at the opposite side of the SX. So we recommend the short balloon for the side branch dilation or proximal balloon edge dilation for the pot side technique. So in Japan, we have already the study, randomized study, pot plus side branch dilation with short balloon and kissing balloon inflation. In this trial, that kind of the malabsorption is likely to occur less frequently. So I recommend if you use a pot side pot technique, use a short balloon or proximal balloon edge only dilation in the side branch ostium is better. For the long balloon dilation from the left main to the LSX, long protrusion in the left main is not recommended.
Thank you very much for your
the final comment. So one alternative to pot side pot is pot side main pot, okay, which is safer. And the other is the kissing because you don't know if you're angio-guided if you did the proximal cross. If you do a proximal cross, you have the neocarina in the middle. So in any way, you have this carina which is toward the main vessel or the side branch if you go with the pot to distal. So it's better probably at the end of this discussion to do pot, side, or kissing is better, and then pot, but perform proximal to the carina. So if you have a neocarina floating, it's in the middle.
Thank you.
Okay, in the interest of time, we'll move on. Thank you very much, Mattia. So the next presentation is Stepan Giris, PCI of left main bifurcation in-stent restenosis with bailout IVL and impeller support. Thank you.
Dear Chairman, thank you very much for the invitation to this event. The topic of my presentation will be the case with long name, but it will be short, don't worry. PCI of left main bifurcation in stent restenosis with bailout usage of IVL and Impella CP support. My name is Štěpán Jirouš and I am from University Hospital in Pilsen in Czech Republic. Let's start with the clinical presentation. When he saw him for the first time, it was 84 years old man with arterial hypertension, diabetes, and chronic kidney disease. And he suffered acute MI without ST elevations sometimes in 2021 during the night. We are going to see the NGO in next slide, but there was provided PCI of proximal LAD and PCI of severely calcified 111 left main bifurcation with provisional stenting, only with one stent implantation, but with Impella support because of his acute heart failure. The result wasn't optimal, you are going to see, but it's necessary to say that in 2021, in our cath lab, we had no debulking method, including IVL. The right coronary artery was quite okay. Here are the pictures from 2021, just the beginning of the case and the suboptimal result after provisional stenting with one stent leading from left main to LAD, but it was maximum what was possible during the night shift. The angiographical result wasn't perfect, but his clinical result was tested a few months later because he got severe COVID-19 disease and he was 2 months hospitalized in do not resuscitate regime in our infectious department, and you can see his CT, and he survived it. 2 years later, 2023, he got another myocardial infarction without ST elevation. The echo showed even worse systolic dysfunction with ejection fraction reduced to 20, severe pulmonary hypertension, and some mild mitral and tricuspid regurgitation. Here are the pictures. There is a severe calcified in-stent restenosis after provisional stenting in left main bifurcation and new lesions in proximal, middle, and distal right coronary artery. We have discussed it in our team, and we decided again to do PCI, and again with Impella CP support. Because we had some time, he wasn't in acute heart failure at this time. We had time to do photon CT imaging of his femoral arteries, and we checked if it's still possible to insert Impella, and if there will be some ischemia of his leg after Impella implantation, if it will be necessary to let it there for a few days. Then we use ultrasound-guided transfemoral approach, administered Impella CP without complication, and started with simple PCI of middle part of LAD with one drug-eluting stent, and then we moved to critical left main bifurcation. I have tried really long time, my colleague as well, but we weren't able to cross through the calcium and old stent to the circ. We tried different wires, and after long minutes, we have decided to do non-compliant predilatation from left main to LAD, but as a little bit expected, it resulted to occlusion of the circ. And this is the point of my presentation. We took as a bailout method IVL shockwave 4.0 from left main to LAD, and after usage of 50 pulses, suddenly disrupted calcium made possible the wire to cross to the circ, and it was surprisingly easy. Then we continued with PCI. We applied reverse tap technique, started with one stent implantation to the side branch, to the circ with minimal protrusion to left main, and then kissing non-compliant balloon dilatation. And then the stent in left main and LAD was implanted rewiring and another kissing non-compliant balloon dilatation. Here is the final result. Thanks to clear stent, it again isn't perfect, but it's better than in the first procedure. So, what's the message of my presentation? In case when the side branch is occluded and you have no wire in it, or you have a wire but you aren't able to get there during PCI of calcified bifurcation, you can try to use this bailout technique, which is well known from CTO cases described by El Basha 2 years ago. You can use shockwave inserted to the main branch, and it can allow you to cross the wire to the side branch thanks to disrupted calcium. Thank you.
Thank you very much. Yeah, very interesting case, complex restenosis. Any questions from or comments from the audience?
Just sharing what we would have done, we would probably have rotad in the beginning, might have created a little path. And sometimes the balloon doesn't go into the circumflex because the ostial circumflex also looked like it had significant calcium. You can put in another non-compliant balloon and then do the IVL to the bifurcation. Sometimes it loosens up the ostial circumflex a little bit.
Thank you.
Sorry, continue. Yeah.
Yeah, thank you very much for this point.
You did have a stent, though, going from left main into LAD from the original 2021 procedure, correct?
I wasn't the operator of the first procedure. It was my colleague during the night shift.
Yeah.
But
yeah. So would that influence you rotablating into the circumflex or not?
No, rotablated to the LAD.
Into the LAD, yeah,
so
yeah.
it would have made easier crossing.
Sorry, I
into
thought you
the
meant circumflex switch, yeah.
It would have made it easier to cross.
Yeah.
I'm sorry, but in that year, we had no debulking method in our cut lab available. So.
I have also a comment. Sometimes when you add this stuff and you see this eccentric calcium at the roof of the left main, it's a nodule. It's a nodule. And nodule is very difficult to treat. Even with rotablator, yeah. It's not directional orbital atherectomy. It's not perfect, but there are some case report of using the IVL in calcify. You can crack these, and then you allow us to. So one strategy in this case could be a rotablator at the beginning, just to create some space, IVUS or imaging anyway to see and. Try to go in the circ and then go directly to IVL without trying to open it. So prepare with the, if there is a nodule calcium, probably IVL is the only way because it's bigger than a small rotablator burr, bigger than an orbital atherectomy, and can crack something, and then go with the procedure, predilation, etc., etc.
I have one question regarding the second procedure, and you said that you put 2 stents in the second procedure, like inverted tap, as I understood, because there was already one stent, crossover stenting from left main to LAD, and you didn't decide to go just to proceed with tap to put additional stent, just one stent, and to finish like so. Now there are 3 layers of stent in left main. Do you?
It was like a nano crash. You didn't protrude too much the stent in the circ. You did so it re-entered in the true lumen of the stent. In the
from the first
the difference with the classical crash that you re-enter in the circ through the side branch of the stent, the side strut of the stent. But in this case, you protrude because the angle was favorable. You put the stent just exactly like a T, and.
Yes, but he put additional stent. That's why I was like thinking if there is already one stent for left main LAD.
2 layers, only 2, because in the circuit it was not crashed.
Yeah, but there was just one stent, and you put 2 additional stents. Yes, like left main LAD. So there are 2 layers in left main.
Yes,
and
yes, but this is like stenosis.
Yeah,
normal stenosis.
There are 2 layers in left main and LAD, proximal part of.
Maybe the result
of LAD, but the result just after balloon was terrible.
Okay, that's why. Because sometimes you can finish with just additional one stent to convert to like to tap TAP or to culotte or to like. in such a cases. But okay, you said the result wasn't satisfactory, and that's why you put an additional stent. Okay, yeah. I understand. Thanks.
Yeah, but even because as you said, this eccentric calcificate burden.
And it was a nodule, so you have to do something.
So the extra stent actually gives bigger support. Yes.
Yeah, yeah. Well, particularly compliments for the case because you have one stent from 3 years ago, calcified, restenosis, the patient is at 20% fractional ejection fraction. You do the procedure, obviously put 2 stents, don't care about that, whether you have 3 layers or 2 layers, and mostly you use the lithotripsy, and you don't know what is the situation with the first stent, so it's better to cover it and don't think about 2 layers or 3 layers. It's a perfect procedure. Yeah. Compliments.
I think the same, and another point is that he was 86 years in the second procedure, so we decided this way.
Another key point is to use imaging in these cases.
Yeah, yeah.
This is really the case that we have to apply imaging technique before we decide what to do.
To be absolutely honest,
especially that you have Impella CP support in this case, so it's like
it was second very expensive case for our quite small cath lab. We used 2 Impellas, we used shockwave in quite old man, and to take another expensive method like OCT, we considered it. And then we decided not to use it, and it was one of the reasons. The second was his chronic kidney disease, and we tried to make it with low contrast as possible.
Excellent. Well, thank you very much. Excellent case. Really appreciated you presenting it in the discussion. So we'll move on to the final presentation.
We have the last case, which is by Giuseppe Marchese from Italy. It's an OCT-guided calcific distal left main PCI after ostial circ CTO recanalization and IVL-mediated lesion preparation.
So good afternoon. This is the first time for me at this very special meeting, so I'm very pleasant and honored, and we will move on to my cases. I'm Giuseppe Marchese from Italy, and I did this case with my head, that is Gianluca Rigatelli, that maybe someone of you knows. So it's a 60-year-old gentleman with a recent history of inferior ST elevation MI, treated with primary PCI and single stenting to the right coronary artery. The left system presented with distal left main critical stenosis, ostial 6 total occlusion, and distal descending artery diffuse disease apart from critical stenosis of the first diagonal that I didn't cite it here. With a quite standard therapy, especially about the depth with the prasugrel, and with an echocardiography with moderate LV dysfunction, with infraposterolateral akinesia, and for the rest a normal exam. And we calculate the Sinta score. It was 34. As per guidelines, we want to discuss this case with the cardio surgeon, but the patient categorically refused any surgical option, so we plan and we aim to the complete percutaneous revascularization. I skipped the angio of the RCA. We focus on the left system that present, as just said, critical stenosis of the left main, but especially a signal of minus of the distal left main with the occlusion of the circumflex. So we stabilized the distal LID very quickly just to have a runoff with the DCB, paclitaxel DCB, with the acceptable results, not a big vessel. And then we approach the ostial 6 CTO. There was a bad angle, so we decided for a supercross 90-degree angulated microcatheter, and we started their anterograde wire escalation, starting with Fielder XTA, that, as you can see, maybe has a good direction and maybe is intraplaque. Then we pass over with the Gaia second with no big progression, and then with the Conquest Pro 12, we progress a little bit, but clearly in the subintimal space. So we went back. As you can see from this last video, the support is really bad, not really a good support. So we decided to upgrade the microcatheter passing on Corsair Pro XS, and de-escalate to Gaia second wire, and with this strategy we were able to reach the distal true lumen. This is the imaging angio feeling, but it was a good feeling also from the tactile. So at this point we have a technical complication. We have something like a fusion between the wire and the microcatheter. So this entrapment was impossible for us to keep out one of the two devices, so we need to take both like a unit out from the patient. So we were in this situation after the wire microcatheter removal. Even if it is small, you can see that there is some anterograde filling of the circumflex artery. So we decided to go with the Gaia third free wire, and we were successful in this. And we started to dilate with low entry profile, 1.0, 2.0, with some expansion. But when we performed the first kissing balloon, we were not satisfied with the balloon shape in the point of the distal left main where before you just saw the signal of minus at the angiography and something like a radiolucent mass. So this was the angio after this preparation of the CTO. So at this point we decided that we need to crack something, and we opted for the IVOL treatment with a 2.5 shockwave balloon. We always do the dilatation, but we deliver the impulses in different position just to have different angles of delivering the energy and the shock waves to the plaques. And this is exactly what we did, and especially we were able to put the balloon more distal, and then this was a signal of efficacy of the treatment. Apart from that, there is not image of this, but after this treatment we always do a dilatation with a non-compliant balloon. In this case was a 2.5 non-compliant at high pressure, 18 or 20, and then we decided to stent this left main. We opt for a dual stenting technique. So we, as I told you before, I work with Gianluca Rigatelli, so we perform the technique that is invented from him and studied. So the non-inverted stenting that start with the ostial cheek stenting. We use a thin strut stent like Corsair, and the key point of the technique is the accurate ostial cheeks placement of the stent with the distal ring of the stent protruding in the left main, more or less one strut, less than 1 millimeter if it is possible. So then after the placement of the stent, we crush it with a non-compliant 3.5 in the left main LAD at high pressure, and then it was quite easy to put a stent in the left main LAD 3.5-23. Then we pot it with a non-compliant 4.5 per Finet low at 18 atmosphere initially. Then the cheeks are wiring also in the distal cell, and the kissing balloon with the non-compliant 3.5 in the LAD and with the 2.5 in the circumflex. So this is the angio result, quite satisfactory for us. And as you can see from the third video, we also perform OCT to check the expansion. I have only the still frames because we were quite satisfied with the expansion and the sizing of the stent in the body of the left main. There was some mild malapposition, but the other detail is the still frame of the CX ostium that is quite good, but as you can see there is some protruding calcific mass in the ostium of the circumflex. But we decided to finalize the procedure with the last optimization with the same balloon, so we didn't upgrade the size, we upgrade only the atmosphere, we went to 22, and then this is the final result, just angio. We had some follow-up, some clinical follow-up, because we planned stress echography at 6 months. That was negative for ischemia. At 10 months, the patient is free from angina and non-cardiovascular events occurred. So my conclusion are that when it's technically feasible and with good risk-benefit ratio, the indication has to be always to complete revascularization if possible. Here we use a CTO technique that is called scratch and go, and is a good way to modify the proximal cap of tough CTO like this. In this case was effective. Contemporary data and the latest CCS guidelines highlight the need to use intracoronary imaging, especially in treating a subset like the left main. Intravascular lithotripsy in this case and in a lot of other cases for us is very user-friendly debulking technique. And here you have a practical demonstration of the NIT, the non-inverted T, as an effective and rapid technique. So that's it. Thank you for your attention.
Excellent case. Just a question. You obviously showed the post-imaging. Did you imaging at any stage pre-stent implantation, the circumflex to help decide using IVL maybe versus rota? And did you image pre-stent in the left main LAD?
No, we just did the final imaging because we practical thought that we didn't have so many other options apart from IVL, because we don't believe in this subset, in this kind of focal lesion, especially. I'm not an expert of OCT, but this sounds like a calcific nodule protruding into at least the circumflex, and we don't believe that the rotablator is the way to treat this kind of lesion. And we didn't have orbital atherectomy in that. So we were practical, we cracked the much possible. We had good result with the non-compliant at 2.5 at atmosphere, and the circumflex was not so big. So this is what we can reach with our tools.
Sure. Thank you.
Thank you for excellent case presentation. You had a very good result in left circumflex after pre-dilatation without any obvious big dissection. Didn't you consider provisional approach or maybe just DCB in left circumflex? As you said, it was not very big vessel. And
yes. We strongly believe in DCB. As you see, we use it also even if it is in a small distal vessel, so the whole indication. We always think about it, but in this case, I invite you to take a look on the first image. There was a ostial CTO with a calcific minus, with a radiolucent image, angiographic image. So we didn't believe that the balloon was enough after so much work.
A question from the floor. Yeah.
Yeah, it's more comment. You know, you can't argue with success, and you had a good result. So congratulations on that. My only concern was, you know, you were dealing with a CTO, and unless it didn't project well on the pictures, you didn't really know where you were going, because you know you didn't do a dual injection to see the retrograde filling.
Yeah,
and
you're
I
right.
understand you say that you know it felt good, but you know I do a lot of CTOs, and a Pro 12 and a Gaia 3 will go anywhere, and it feels good wherever it goes because it's like a needle. It cuts through anything. So my only criticism is you got a good result, but I think we can't take shortcuts when we're doing cases. You have to do the retrograde injection. You have to know where you're going, because it ended up well, but it could have been a disaster as well. You have to see where you're going.
Thank you very much for your comment. You're absolutely right, and we are methodical in respect the hybrid CTO approach. But in this case, I didn't show you, there was really a poor collateralization from the right, so that's why we didn't take another catheter. That was very easy. It could be a 5 diagnostic, but it was not useful. The things we learned from our CTO ITER was that it's very important also the feeling, tactile and angiographically, what you see, how is moving the guide wire. Of course, I didn't report this image or this angio video, but always then nobody is calm and quiet in working with the guy at third. So we, of course, exchange the wire, we perform a small injection, and this was done, so we were safely fine that we were in the true lumen distally.
Thank you very much for your presentation. And yes, we can close this session. And I want to summarize a little. So we have the first case we have 5 cases. And the summary is that DCA is useful sometimes when you want to reduce the stent that you want to implant, especially in very complex patients. In Japanese country, there is this DCA device, which is not available in Europe, that can be useful in very eccentric LED ostial or circ, and can be followed by drug-coating balloon, because this is the tip and tricks, or stenting if the result is not optimal. The weakness of POT-SI-POT has been shown in the case by Mattia Lunardi, and this is, in my opinion, a reason waiting for the result of the stent to use a kissing balloon instead of POT-SI-POT as suggested in the past. IVL is another option that we have, and IVL can favor opening of occluded vessel, crack the ostial occlusion, calcified occlusion, and help to also we have 2 cases of nodule, crack some calcified nodule, and allows it's not good, expansion. From imaging, that is useful, you can see that this nodule protrudes inside the vessel, and there are cases reported TCT, etc., of regrowth of this nodule inside the stent. So what I suggest is to follow up the patient, especially with the nodule in the distal left main, a 6-month follow-up, because there is not a low percentage of restenosis and a nodule growing inside inside the stent. That's all. I think that we have some tips and tricks from this, and do you have other comments? So thank you for your attention, and we leave the room for another session.
Okay, hope everybody's made it into the most important session of the meeting. Okay, so DCB for bifurcations should be all the rage. I'm expecting all the seats to be taken. So we have a pretty stellar panel, apart from me, who all know a lot about DCBs. We've got quite a few talks to get through, and hopefully quite a lot of audience discussion as well. So let's first up invite Yoon-Suk Shin to come and talk about angiographic change in side branch ostia. Thanks.
Okay. Thank you for the invitation to present at the EBC 2024 meeting. Okay, so unlike metal stenting, DCB does not produce carina shift. Instead, after drug-coated balloon treatment in the main vessel, an increase in side branch ostium occurred. So this patient has a true bifurcation lesion in the RAD. This treatment was performed only on the main vessel. However, the side branch ostium slightly enlarged. So when observed with OCT, it is evident that although DCB treatment was performed only on the main vessel, the side branch ostium area also increased. On the contrary, this region was confined to the side branch ostium 001 type. DCB treatment was performed from the RAD to the diagonal branch. The follow-up was good. So when confirmed by IBUS, the lumen of the side branch was enlarged. The lower limb of the confluence in the main vessel, which is prone to compromise if we put a stent. However, it showed increased lumen area. It measured 6.7 square millimeter at baseline and 8.2 square millimeter after the procedure, and 9.0 square millimeter at follow-up. So to confirm this phenomenon, we measured the side branch OCR area in bifurcation regions using OCT. All regions were increased with the DCB exclusively for the main vessel. Lumen area of the main vessel generally increased, and the side branch ostium also, the area significantly increased with expanding by 76%. So at follow-up in this case, the dissection flap in the main vessel completely healed, and the side branch ostium enlarged. So this also be verified in 3D reconstructed images. With this background, we aim to evaluate using angiography to determine whether this phenomenon is unique to DCB treatment. Among patients in the DCB registry, 132 patients with de novo bifurcation regions and follow coronary angiograph data were enrolled. Bifurcation regions with the main vessel 3 millimeter or over and the side branch 2.0 or over were selected. However, cases with the severe side branch stenosis requiring a procedure and PCI were all excluded. According to the DCB consensus guideline, the main vessel was treated with either DCB or DS. All DCBs used was paclitaxel with eopromide. For analysis, the bifurcation region was divided into 7 points as follows. The endpoint is side branch OCR, minimal lumen diameter and diameter stenosis. And we also analyzed the upper limb and lower limb of confluence in the main vessel. And the other parameters is for all main vessel. The delta value of minimal lumen diameter and diameter stenosis were defined as subtracting follow-up from the pre-procedure. So the minus value indicates an increased diameter. So there was no significant difference among the three groups, including bifurcation type is also incomparable. Here is the result of the study. The diameral stenosis of the side branch ostium was around 30%. The largest increase of side branch ostium was observed in the DCB group, with an increase of 0.16 millimeter. In contrast, the DES group showed a decrease of 0.5 millimeter, and the untreated group, medication group, is decrease of 0.08 millimeter. The minimal lumen diameter in the main vessel showed an increase in both the DCB and DES groups. So there was no change in the minimal lumen diameter and diameter stenosis in the untreated medication group. However, in the DES group, side branch OCR minimal lumen diameter decreased and the diameter stenosis increased. However, in contrast, in the DCB group, side branch ostium did not compromise. Late lumen loss of the side branch ostium was similar in the DCB and medication group, but it was higher in the DES group. This is a 61-year-old man and stable angina. He had a positive treadmill test. The ST segment is sustained, the depression is sustained until recovery phase. It is a high risk. Left main was a true bifurcation lesion, like this. Lesion preparation was performed with a pre-dilation balloon sized to match the reference vessel using 3.5 millimeter up to 14 atmosphere. The results were satisfactory. The flow was normal in both the complex and RAD. And left main to proximal RAD was treated with a paclitaxel coated balloon, the same size as the pre-dilation balloon, 3.5 millimeter. It was also successful with normal flow in both RAD and circumflex artery. We didn't touch it for the circumflex ostium. This is a follow-up coronary angiogram. We performed 6 months later. As per the study protocol, the symptom is free. The left main bifurcation remained well patent, like this. So compared to the baseline, the MLD of main vessel increased by 2 millimeter and circumflex ostium increased by approximately 0.1 millimeter. This patient has been asymptomatic for the past 6 years. So in summary, the side branch ostium enlarged only in the group where the main vessel was treated with a drug-coated balloon. In the DS group, it becomes smaller, and there was no change in the untreated group. So we found that treating the main vessel with DCB can reduce the risk of side branch OCR compromise. So in conclusion, paclitaxel-coated balloon treatment applied exclusively to the main vessel in the de novo bifurcation region has demonstrated a superior angiographic outcome in the side branch ostium compared to the drug-eluting stent implantation. Thank you for your attention.
And I think this is a very, very important information. You know, about 10 years ago, our group, together with Bruno's group, published the positive remodeling. And we have been often discussing, is this a vessel size increase or is this a plaque regression? It's probably both, but you showed definitely with the side branch ostium increasing that the whole vessel gets larger. And this has also been shown by pericardial application even of paclitaxel. So I think it's very important to go into the mechanism of this treatment. Thank you very much.
Okay, thank you.
Yes. Yeah, just a question. In the first case you showed there was an obvious dissection there. What criteria do you use to say it's a stable dissection and I don't need to do anything? So in other words, do you look at sort of the circumference where the dissection is, the flow? What do you look at to say, I'm happy to leave it?
Yes, and you know, and to increase the lumen area, that means increase the flow, we need to make dissection. No dissection, no luminal gain. However, in the flow limit dissection is we have to fix the dissection like that. So we need a metal scaffold. However, in non-flow limiting dissection, that's okay. In CTO lesion, it's just if the residual diameter stenosis is over 90%, the flow is good, it's okay. However, in the non-CTO lesion, for the future outcome, we need follow the consensus guideline. The residual diameter stenosis is less than 30% and flow is good. That's okay, even though the dissection is type D or E.
I have just one comment according to the dissection that we are trying before to stent it maybe. But if it's not flow limited dissection, we had a patient 3 years ago, we did it in a fraction. We make a PCI left main to LAD with a circular dissection to all LAD without the branches, but it was flowless to the apex of the heart. After 3 years, we did it a new angio 1 week ago, and it was perfectly healed dissection without DCB. Without DCB. So not leaving nothing behind is the best solution, even without DCB in some cases if there is no flow limited dissection.
I mean, even Andreas Grünzig's group showed that if you have dissection, you have a better lumen and a better outcome.
Okay, great. Thank you ever so much. Really great presentation, actually. Over to Bruno.
Yeah, thank you very much for the invitation. It's a great pleasure that we as the DCB guys are allowed to be part of EBC. Really great, thank you. I'm not sure who gave me this talk about 001 bifurcations. We know from all the stent trials that 001 bifurcation lesions have the worst outcome. Many of those patients are treated with 2 stent techniques, despite the fact that the main vessel is not affected. This seems to have some change over the years, but there's still need for treating also the main vessel in some of the cases. Shortly, what are the different scenarios for DCB in bifurcations? We have this blended or hybrid approach with stenting the main branch, treatment of the side branch with DCB. Then we have the puristic approach, where we try to avoid any stenting in the bifurcations using DCB in both branches. And the simplest one is what Professor Shin showed, using the DCB only in the main branch if there's only ostial disease of the side branch. This is again the data you have seen before, and this is really an easy application. However, I think it's more for the smaller side branch and not for the bigger side branches. These are examples for the special case of ostial circ lesions from our colleagues from Japan again, doing orbital atherectomy first and then using DCB, which is really unique and not available in our countries here. But I think this is an interesting approach, and here you see some follow-up pictures. Unfortunately, we do not have lots of data for 001 bifurcations. This is a trial more than 10 years ago published by Herrador and colleagues from Spain. And they randomized the side branch to DCB or uncoated balloon angioplasty, and what they found was that the late lumen loss in the DCB group was significantly lower than in the uncoated balloon group. However, this was not a trial only focused on the side branch. It was only included stenting in the main branch. What we did under the guidance of Franz was the PEPCAT-BIF trial. In this study, we focused on the side branch and randomized to DCB or uncoated balloon angioplasty, 32 patients in each group. And the primary finding was that late lumen loss in the side branch was significantly lower with DCB compared to uncoated balloon angioplasty, and also the binary restenosis rate was significantly lower. However, this trial was not powered for clinical endpoints, so this is also a mechanistic description that we can reduce the restenosis rate in the side branch with DCB. This is a meta-analysis from Simon's group of the data available for the side branch treatment, and here you can see that there's an angiographic benefit when using a DCB instead of an uncoated balloon in the side branch. The question is, does this have any clinical relevance? This is a paper from a group in China published a few years ago. They report a reduction in MACE when using DCB for the treatment of the side branch. However, this is not a randomized study. There's also a meta-analysis looking from different trials, non-randomized trials included, on the impact of drug-coated balloons on the treatment of side branches, and also they report a benefit in clinical events. But to be honest, I'm not really convinced that we can see this big difference in clinical events when we are focusing on the side branch. Another important investigation, in my opinion, here comes from Japan again. They looked at the impact of late lumen loss on the clinical outcomes if the side branch is treated by a drug-coated balloon, always, depending if there's lumen enlargement or not. And that's very interesting. If you look, for example, at the binary restenosis rate in the last line, then you can see that if there is lumen enlargement over time, then there is no restenosis. If you have not this effect of late lumen enlargement, then you have to deal with restenosis and possibly TLRs. And this comes to this concept which we discussed before. We have to be aggressive when treating lesions with DCB. We see with paclitaxel-coated balloons that the more aggressive you are, the more dissection you create, the lower the late lumen loss is. And I think that's very important, that we need an adequate sizing with a 1-to-1 ratio when treating also bifurcations with DCB. This is an example from this PEPCAT-BIF trial we published. This was 0-1-0 bifurcation. And unfortunately, also with DCB treatment or with lesion preparation, you can have carina shift. This was the case here. So we needed a 2 DCB strategy for both branches. And you can see that the final result is not really good. There's haziness in this lesion. This means dissection. The lumen is not perfect. But we see the healing of the dissections at 6 months and an improvement of the lumen. And interestingly, in this case, we looked with IVUS at the plaque volume. And in this treated area, the plaque volume was more than 50% lower than in the angiographic healthy areas before and after it. And this is one of the findings we have. We have an increase in total vessel area, what has been discussed, but we see also some kind of plaque regression by this local treatment. So, and this is already my conclusion. We know from several smaller trials that DCB reduce late lumen loss and restenosis and possibly TLR in the side branch. However, it is unclear whether this can actually lead to reduction in hard clinical endpoints. The advantage of DCB in bifurcation is the simplification of the procedure, for sure. But I think an effect on hard clinical endpoints will only be seen if we also apply this concept in the main branch. Thank you very much.
Okay, let's open that up for questions. Bruno, perhaps you could explain to us what do you think is the mechanism then of the plaque regression when you use DCBs? What's actually happening that influences that?
So we know from experimental data that paclitaxel has some anti-inflammatory effect in the plaque, and this may contribute to some change in the structure and maybe some, at the end of the day, a reduction in volume. This is one mechanism, but the more important mechanism is the improvement of the total vessel when looking at this lumen enlargement. So plaque regression is a nice to have, but not the most important factor, I think.
Bruno, it's a great talk. Is this working? Yeah. It's a practical question. If you have to do a 001 bifurcation, presumably you've already tried to manage them optimally medically, but if you're forced into doing that angioplasty where you don't want to jeopardize the main branch, any particular tips and tricks on how to do the PCI so you're not ending up in a 1 or 2 stent situation?
So I meanwhile prefer starting with specialty balloons, cutting or scoring balloon. Why? Because at least at low calcification level, you have a better initial lumen gain. With scoring balloons, you have less dissection. You have dissection, but you have more controlled dissection. And I think that's key, and it's a one-to-one sizing. I know we discussed this several times, if we should go for smaller sizes or not, but meanwhile I think it's important to go one-to-one.
Thank you for your presentation. So practical question, when you have restenosis, bifurcation lesion like a Quilot technique, and then you have the main vessel is restenosed as well as the side branch, then you need 2 drug balloons for both. How can you do that? Is it one by one, or they can do kissing with both of them? What is the, I know it is not published yet, but what do you think?
You mean for instant restenosis?
But the main vessel and its side branch both are having restenosis, and then you need balloon for each one.
Instant?
Instant.
Instant, yes. So for DCB, the basic rule is don't do kissing DCB. This makes no sense because you lose track with the first one when positioning the second one. And you have not full contact to the vessel wall with the balloons because they kiss each other, so that this makes no sense. This means this is a sequential approach. I usually start, independent if it's ISR or it's de novo, prepping the main branch, then doing lesion preparation of the side branch, applying the truck in the side branch, applying the truck in the main branch. So that's the typical way. And if you then have carina shift or whatever, then you can do kissing with conventional balloons to have the mechanical optimization.
Congratulations for your presentation. Do you think that the drug coating balloon is the choice treatment for 001 lesion? Do you think it's better than inverted provisional with the stent? Oh.
I mean, if I have only this problem with the proximal or the ostium of the side branch, I think it makes sense not to implant a stent to avoid the carina shift and go with the balloon after lesion preparation. Yes.
Do you think that this two type of treatment deserve a randomized trial?
Yes, I think we will hear about...
No, for 001.
001. I mean, we did this PEPCAD BIF trial, which was a mechanistic trial, and we see that this makes angiographically against PROBA, it's better. I think if you look against drug-eluting stent, there will be no big difference in angiographic outcomes, and it's hard to show a clinical benefit if you treat small side branches. I think that's really difficult to show.
Okay, Shostakovich is growing louder, so last question.
Just one question about the treatment with the antiplatelet therapy after the DCB. Do you prefer only antiplatelet, or you can add anticoagulant like rivaroxaban 2.5 milligrams if it's needed? This is my question actually.
So if the patient has an indication for anticoagulation, then...
No, without the indication for anticoagulation, only for after the DCB ballooning?
I don't think it's necessary. I mean, what you mean, I think it's that we are talking about small thrombus formations within the dissections, which is typical. But what we know from newer imaging trials and from the clinical data we have is that the DAPT is enough to control this problem.
Great. Thank you very much. Great talk. Thanks, Bruno. So we're now going to move to Bernardo Cortesi, who can't be with us, but is with us in spirit, if not in body, in the form of Zoom, I think. So,
yeah. Thanks, Doug. Can you hear me?
We can.
All right. Thank you. Thank you again, guys, for the invitation. Yeah. Also this year, I can make it, but hopefully the next one I will be more lucky to be there. Yeah, you're asking me about this sub-analysis of the Eastbourne. Actually, I have to say that since we are at EBC, which is a quite non-formal meeting, I decided to change it a little bit. It's not very fascinating to discuss about sub-analysis of a big registry. So my main goal today is to give you my take on the current status of bifurcation managed by DCB, and which is the future, in my opinion. And I have to say that I'm pretty much on the same page of what Bruno just told us. First of all, we have a need, and the need is coming from, many studies and several meta-analyses. I just picked up one managed by my good friend Fernando Alfonso, which is the last author of this meta-analysis, which is showing that still with bifurcation on a mid to long-term follow-up at 3 years, we have a clinical need. Because either we use 2 stents or just 1 stent with a provisional approach to the side branch, we have quite a lot of MACE. And here, from these studies, the complex bifurcations that we have to manage were excluded. On the other hand, we have a lot of data also with intravascular imaging, which are showing how the management of the side branch with a drug-coated balloon, and we have a lot of data with paclitaxel, is very good. Is very good. The effect of paclitaxel on the side branch is showing how it is protected, and late lumen loss is often negative if we go and analyze angiographic data. We have meta-analysis also for this. We know that the late lumen loss is negative, and it is much better as compared to a POBA for the side branch. And we know that, again, for the side branch, the TLR rate is lower. Okay. So we have the Eastbourne study. Eastbourne study is a prospective study, a large one, more than 2,000 patients enrolled prospectively in Europe and in Asia, with a magic touch sirolimus coated balloon. Primary endpoint is TLR at 1 year. We have published last year the 1 year follow-up, and this year in Eurointervention, the 2 year follow-up. I'm not going to go deeper into this study. We have a pre-specified bifurcation study within the Eastbourne, where all Medina lesions were allowed according to the preferences of the physicians. All the events have been CEC adjudicated. We have 1 year follow-up available for this sub-analysis, but these are really exploratory, not definitive findings. So about the population that we have enrolled, we have 212 lesions treated with a sirolimus coated balloon, with most of them with a side branch, but there is a good representation of almost all of the types of Medina classification. I have to say that these patients have been treated between 2016 and 2019, so there is a quite conservative approach. With 92% of the cases of the bifurcation, there was a stent implanted in the main branch, and a DCB only in the side branch, with a full DCB revascularization only in 8% of the cases. So this is the population. We did a comparison between de novo and bifurcation. No specific mentions about important differences. Also technically, there is more predilatation accuracy for the bifurcation subgroup, and also the diameter of the balloon used for predilatation is larger than the de novo which is representing mostly small vessel disease setting, I have to say. So this is the outcome, which has been published this year of this bifurcation, 212 lesions, 194 patients, and there is a comparison to the de novo lesion setting with no significant differences for the primary endpoint of TLR, 4.2% at 1 year, and a MACE 8.8%, no significantly different to the de novo lesion population. We have several limitations. These are only exploratory findings, no protocol mandated. It's just a registry. We have no information specifically on the technical data for how main vessel or side branch were treated, how DCB were applied. Some of them, unfortunately, were applied with a kissing balloon, which is something that now, today, we discourage, and I agree with Bruno on that. And we have few information about the technique, and we don't have core lab. So several limitations for this study with exploratory findings. But as I said, I would like to put this into a context of the current management of bifurcation, and which can be the future lines of research for this. So far we have small studies, mechanistic studies with a good TLR, quite different according to the studies. We go from 15.4% on a study, a Babylon study, which did not go well, talking about the side branch now, to 2% of the depth side. So there is a quite big range of variability for the TLR for the side branch. So which are the main limitations of the current studies for TCB in the bifurcation? We have few patients enrolled so far with debatable designs. We can see everything in these studies. If you go and pick all of them, you can see everything. Also because there is a lot of heterogeneity for bifurcation management. Results are a little bit controversial. We have good results for sure for the side branch, but we don't have many results for hard clinical endpoint. Luckily, we have good studies on the go. These are the studies that I picked yesterday from clinicaltrials.gov. This was my download of randomized clinical trials ongoing or, hopefully about to start enrolling patients. We have this DCB-B for China, Piccoletto 5 from our group, BJ DCB-B for China, Stent-Free Romania, Magic Touch. It's a study mainly enrolling patients in the Netherlands. And then we have the EBC study that David will present you later. So which are my takes for the future trials on DCB? First of all, we should provide randomized clinical trial comparing provisional stenting and dual stenting with hard endpoint, but with an adequate sample size, which should be studied very well and long-term follow-up. This is one area. The other big area that we need to address are randomized clinical trials again with a provisional or dual stenting versus full DCB. Okay, we want to see how the full DCB in the main vessel, DCB in the side branch, two separate inflations are going with long-term follow-up versus standard of care. I'm presenting you a couple of slides of Piccoletto 5 study that is on a startup phases. Wojciech is the PI for this study. We are enrolling patients, non-left main, with 111, 101, 011, 001 Medina classification, big vessels. After region preparation, we are randomizing patients 1:1:1 to EBC-like, so provisional stenting, hopefully, to full sirolimus coated balloon with a sequential inflation, to full paclitaxel coated balloon with sequential inflation. And we will analyze the 9-month follow-up at a CT scan, a functional assessment, if there is differences in the main vessel and in the side branch. That's it, and thank you for your attention. I'm here for you to reply to any criticism or question.
Great presentation. Any questions for Bernardo? Everyone's gone quiet. That was such a good presentation.
Yeah. No. Please, ask me something.
So what stage are you at with the Piccoletto 5, Bernardo? I mean, we've discussed this a little bit, but...
Yeah. So we have selected the centers. We have selected the countries. It will be a European study. We have some findings. I have to admit that it's quite difficult to run a good quality study with core lab assessment, CEC, DSMB, with funding. We are an independent foundation, so that is not that easy. So we are still collecting fundings, but we have a very motivated group of physicians and PIs led by Wojciech. So this is our current status. Hopefully, we can enroll the first patients in Q1 25.
Great, thank you. So, question for you from the floor.
Hello, Bernardo. This is Chema de la Torre, your friend.
Hi, my friend.
This is we are talking continuously about DCB versus DES based on a geographic appearance or whatever. But what about intravascular imaging providing insights to finally make a selection of when DCB could be better than DES? Because we are relying on in the lumens and the angio and the angulation, but maybe mechanistic studies using imaging, OCT or IVUS, I don't know, could be better to make a proper selection of this type of bifurcation is better served with DES or better served with DCB or combination, because we are just treating all of them as the same, but we know for intravascular imaging that a 001 can be just a plaque in the osteum, or it could be a plaque extending into the main vessel. And because positive remodeling, you don't see the stenosis in the main vessel, but there is a lot of plaque, and then the outcomes are quite different. What do you think about this, Bernardo?
Yeah, I want to be very honest, and maybe I can be a little bit too direct. I fully agree with you. In a complex or, I wouldn't say that we should use imaging in 100% of bifurcations, but I would say 80% of them should be used. I think that you are depicting what we should do now and what we are currently doing now, because we believe that DCB should be used in the vast majority of bifurcation. So intravascular imaging, decide according to your results, according to how is the result after predilatation, when to use a stent, if to use a stent. We are designing clinical trials just to convince the other people to use DCB for the bifurcation. So this is why we are designing this study. I'm not designing these studies for us. We are already convinced about DCB.
Okay, super. That's great. Thanks ever so much, Bernardo. We're going to move on now to the next talk, which is Xiaoliang Chen. Now, I haven't seen Xiaoliang here, so I'm going to guess that he's also on. Oh, you don't have him? Oh, no. Okay, well, we've made up some time then. What happened to Xiaoliang? Okay, never mind. You don't have him? He hasn't made contact? Okay. Okay, never mind. Never mind. We will hear more, no doubt, about his study, later in the meeting. Okay, well, let's move on then. Yanis Chatzisis is here. Is Yanis here? No, that's good. That's bad now. That makes it difficult to chair this session. Where's Yanis? He must be in the other session. He's here. I've seen him. Yeah, somebody go and get him. Somebody go and tell Yanis he's on. Meanwhile, whilst we're waiting for Yanis, any further comments? I mean, Bernardo's gone now, but I mean, any more comments? Anything of insight from the Eastbourne Registry or from the plans for his upcoming studies?
I mean, one thing we can discuss, I realized that the difference between the Picoletter 5 design and the EBC design is that randomization occurs in the Picoletter 5 after lesion preparation. And I think we are planning more a strategy trial defining. So Bernardo, what do you think, what are the pros and cons to randomize before or after lesion preparation?
Yeah, this is also the big difference between the solution study and the Transform 2. I still believe that we don't have to be too much, to have decided which is the best treatment for our patients up front. So my final decision if to use a DCB in any lesion setting, also for ISR, is taken after lesion preparation. So I think that this type of trials are reflecting more what we should do to provide the best treatment to our patients. So they are more, real-world studies. On the other hand, if we randomize patients up front, the risk is that there is a slightly higher bailout stenting rate. So this is another fact. That the solution study, Simon presented very interesting data, I don't remember at which meeting, showing that according to the experience of the physician, at the beginning of the experience of the physician, bailout stenting was quite high, and after few months of experience with DCB, it came down. So yeah, this is my comment on if to predilate before or after randomization.
Hi, Bernardo. It's Simon. So I think it's actually quite important that we have both types of studies, because there are some people out there that want to know the difference between whether to use a DCB or a stent when they're finishing their angioplasty, whereas there are other people that want to know whether the whole strategy up front is the right thing to do or not. And I think both are important, and for different groups of people you will be able to answer the question. So hopefully between the two different types of trials we'll get as much coverage as possible. So I think both is a good idea, personally.
I agree. Okay. I agree with you.
Perfect.
Yeah.
That's an excellent answer. Thank you so much. So now Yanis is here. Yanis is going to talk to us about a new paradigm for the treatment of in-stent restenosis.
Hello, everybody. Very, very thrilled to be here and among friends. Drug-coated balloon, a little bit more sophistication, if you want, with simulations on how we can plan these procedures. These are my disclosures. Background, we know very well that 10% of our PCIs, more or less, are intended for in-stent stenosis. Everything starts with a mechanical stimulus that triggers a biological response, neotherosclerosis or NIH, and imaging is very, very important to understand what's going on. It's classified as 2A in the US and American and European guidelines for imaging of ISR. Treatment options, traditionally another second or third DS, brachytherapy, not very popular nowadays, bypass, bailout, but in Europe and now in the US as well, we have this option of drug-coated balloons. That's the algorithm. First, we identify the mechanism, then plaque modification, then again imaging to confirm that we are ready to receive the therapy with the balloon, the DCB, and then final angio assessment. I'm going to show you two cases which illustrate our approach. Actually, these were among the first commercial cases in the US. First case, 73-year-old woman with symptoms. She has exhausted the surgical and interventional approaches. She has been having bypass, both grafts failed, and multiple PCIs to the RCA. SPECT shows that she has ischemia in the inferior wall, the RCA territory. She has exhausted all the medical therapy. She keeps having pain. That's the baseline RCA. You see here there's significant ISR within 2 layers of stents, proximal and distal, as you see there. So what we do at this point, we 3D reconstruct this using angiography and OCT. That's the digital twin. You take the artery from the body into the computer. Then you see the whole mapping of the area. Black line is the old stent, double stents, and the red is the lumen area. And you see here all the gray zone is the NIH with these two sites which have significant restenosis, 1.44 and 1.27 MLA on both sides. That's the stiffness mapping. So you see here whatever is essentially green is the stiffness tissue. So I'm sorry, the NIH tissue, which is quite stiff, fibrotic material. And using this wall, simulating the pre-dilatation computationally with a 3030 NC balloon in a patient-specific environment, inflated high atmospheres. And what you see here, that unfortunately this balloon doesn't expand well on those two restenotic sites. So what we do next here, this informs that we need to do something more before we go there and prepare the lesion. with some debulking, pre-dilate, possibly with a cutting balloon, to which the simulation helps us to size it to the right size. Of course, NC balloon, then confirm the result, the lesion preparation with IVUS or OCT, and then apply the DCB therapy. So that's the planning, informed, guided by the simulation. And that's what we achieved, the lumen gain after the simulation-guided informed lesion preparation. That's now after the cutting balloon and, of course, the laser. And you see here now the lumen gain. As you can see, this is the old lumen. And now this is the lumen gain. We gained some lumen, which restored the area from 1.4 to 3.4 proximally, and then from 1.27 to 2.5 distally. And that's hemodynamic assessment by FFR and CFD. You see on the top, pressure drop across the proximal stenosis. 0.75 is the angiographic FFR, which is restored to 0.93 after the lesion preparation. And of course, CFD showing the flow acceleration on two sides, proximally and distally, which is restored homogeneously after the lesion preparation, adequate preparation. Now, after this approach, we're ready to go ahead and deliver the therapy with DCB, as we did here, a 3030 balloon, well expanded nicely to cover both proximal and distal stenosis. That's the final angiogram. All good. Patient goes home. 3 months later, she's pain-free, resumed her clinical activity. She's happy. But now we have some wrist stenosis, a little bit more distal to the proximal stenosis. And you see here, that's a very interesting situation. That's the angiogram. That's the 3D reconstruction, again, based on the OCT at 3 months. And now what we see here, we see that we have a new standard stenosis, just distally to the proximal stenosis. The proximal stenosis has essentially positive remodeling, looks better now, and distal stenosis looks slightly worse. So you see all kinds of responses here. We battle with biology. It's not like black or white, and that's the new standard stenosis. However, the patient is feeling fine. She's doing well. With DCB, we bought some time, and maybe we'll have open therapies for the future or repeat another DCB. Case 2, a man now, 74, with active refractory chest pain to medical therapy, maximal medical therapy, all kinds of risk factors. He has instant stenosis of an LAD and circumflex stent. We fixed the LAD already, and now we focus on the circumflex. You see here the proximal side, which is a de novo fibrocalcific stenosis, and also distally we have an instant stenosis, fibrotic calcific material, neoatherosclerosis within 1 layer of stent. So both types, both phenotypes of atherosclerosis here, stent stenosis distally, de novo lesion proximally. We do a 3D reconstruction, again using here IVUS and OC and angio, digital twin essentially, generation. You see the proximal and distal stenosis, proximal stenosis, distal stenosis, replicate in the computer very faithfully. And you see the mapping of the areas, and you get to see here the NIH area, the neoatherosclerosis area between in the distal part. And of course, you see by IVUS, proximal fibrocalcific plaque, 30 MLA, and then distal wrist stenosis, stent stenosis with an MLA of 1.52. What we do now, we use this information, first of all, to assess the hemodynamics. You see the flow acceleration with red in the proximal stenosis, de novo stenosis, and also distally in the long instant stenosis. And also, we assign patient-specific materials. You see proximally, it is based on this spectrum here. It's on the red side, pretty calcified, pretty stiff, if you want. And then distally in the instant stenosis, it's quite stiff as well because it's full of fibrotic material within the stent. And now we see how the vessel would respond using a computational simulation of an NC balloon distally and a stent proximally. Again, it's all simulation plan to see what we would expect if we go in the real case. So you see distally, the balloon in high pressures, the NC balloon expands but not adequately, which means that the lesion is quite stiff, needs some more preparation before we go ahead and do the DCB. And then proximally, you see how the stent would respond. You see we expand the stent here. It's a patient-specific stent, and it expands pretty well the lesion. So with that, we now have an informed planning of the distal stenosis with DCB approach, with a debulking with a laser, pre-dilatation on high atmospheres with cutting NC balloon, and then confirmation with imaging. Again, the sizing of the balloons is guided by the simulation, and of course, a 30 dCB balloon at 6 atmospheres for 3 minutes to let the drug go there should be okay. And then proximally, we'll go ahead with the de novo stenosis with a DES, and that's the sizing of the pre-dilatation balloons and the stent. So with this approach, essentially, we ended up using simulations informed, powered by imaging, to help us understand the nature of the problem and size and plan our approach appropriately. DCB PCI is durable, superior to angioplasty, avoids several layers of metal, keeps the future treatment options open, and then, of course, short adapt. And the imaging-powered stent simulations can identify the mechanism of ISR, can help us predict the need for advanced lesion preparation, like laser or rotational atherectomy or whatever. And, of course, it helps immensely with precise sizing and positioning of the therapy, whether this is DCB or a stent. A big thank you to the funding resources from federal industry and philanthropy areas, and, of course, to my group, the engineers, the medical doctors, and thank you all for your attention.
Great, lovely computations. I'm not sure I quite understood how you do it though. Presumably this isn't available sort of to you as you do the procedure. This must be something that you take the images, you then take them for computational analysis, work out what you think the artery will respond to, and then the patient comes back for the treatment. Is that
what I showed you today is 2 sessions. One is the baseline acquisition of the IVUS or OCT angiography, and then simulation, digital twin, simulation planning, and then the second session is the actual delivery of therapy. The good news is that we have at this point the computer power to implement this concept at the point of care in real time. I think getting there.
So that would be amazing. So
Yes.
you think you're getting to the point where you could take the angiographic images and, as it were, online
in real time at the point of care to make the decision right away, because we are all interventional cardiologists, or most of us, and nobody is pleased with the idea of taking the patient off the table and go back. So we want to deliver impactful care at the point of care in a very precise and very patient-specific way.
Questions for Yannis? Yes. At the back there.
Thank you very much for your presentation. I have one question. It's on the technical side. How do you predict the result of the angioplasties based on previous data from interventions with IVUS and OCT, or is it tables on the bench side tests? How is it done?
Yeah, that's a very good point. We have built the computational simulation platform and validated this against real clinical data. And now that we have the computational model which is faithful against the reality, we can use it prospectively to see the response of each individual coronary artery to any stent, any balloon, any therapy.
Yannis, fantastic presentation. Congratulations again. Yeah, and I was going to dovetail onto that, because really the secret sauce of this is creating the database to then predict it, right? So do you use any biomechanics there? Do you use, whether you use plaque analysis of the plaque morphology, or is it all kind of AI-based based on, outcomes?
Yeah, so both happen, but what happens primarily is that all the material properties, the tissue stiffness, individualized, is embedded in the model, and then you let AI, you let the computer essentially tailor the right therapy, the right sizing, the right length, the right approach for each individual. And it can run, because of the computer power, multiple scenarios very quickly and recommend what would fit best for this particular wall stiffness, this particular material, this particular anatomy.
So you use a combination of the biomechanics, but
And the AI that runs
also
scenarios.
a lot of data where you have pre and post, and you see what variables, what sort of lesion prep results in the optimal. So it's a combination of biomechanics and AI.
Yeah,
Congratulations.
exactly.
Yeah, very exciting.
Great. Thank you very much indeed. So next speaker will be Eric Raffenbuhl. Welcome.
Thank you for having me. Welcome to Frankfurt, to Germany. I'm from Hamburg. My name is Eric Raffenbuhl. I'm an intervention cardiologist. So it's a pleasure to sum it up before you hear the data on EBC, DCB, on how advancing bifurcation PCI with integrating physiology assessment with pressure wires and using drug-eluting balloons for precision outcomes. So these are my conflicts. The session key learning objectives are that I will show you, hopefully, how coronary physiology can be integrated in bifurcation PCI approaches in high bleeding risk patients using an optowire. Doing then precision PCI, integrating this physiology data and data coming from intravascular imaging and making decision-making in bifurcation PCI, and showing and discussing with you and the panel and the chairpersons to discuss the benefits of DEBs for bifurcation PCI. So this is the history of a patient I met in June this year, a 73-year-old male patient having thyroid carcinoma and myelodysplastic syndrome with low platelets of 31 to 38 per nanoliter. He got hemothyroidectomy, and after surgery he complained about unstable chest pain. When we asked him, he has chest pain CCS class 3 over 6 months. On EKG, had a new diagnosed, had never EKG before, not before the surgery, a left bundle branch block and an LVEF of 33%, so he had HFrEF. He was brought to the cath lab, and this is the anatomy. You can look at it. Everything TIMI3, but if you look at this LAD-D1 bifurcation, there's an intermediate stenosis. There's only one diagonal branch, giving two branches of this D1, and there's an intermediate lesion. The colleagues decided to defer the patient for PCI because of low platelets. He was then on the table, chest pain free, had no elevated troponin, and he was discharged from the colleagues from surgery. After 3 months, he was readmitted to the hospital because he had a resection status of a carcinoma of R1, and the decision was made by the colleagues from surgery of full thyroidectomy. And when we met him, because we knowing he had a lesion in LAD and D1, he complained about more chest pain and his comfort of life was reduced. So we did an informed consent of the patient that we will do a coronary angiogram, and we will do now physiology assessment of this intermediate lesion. And this is how the angiography looks like. It's running a little bit slow. It's not TIMI1 flow, trust me. But you can see here with the guiding catheter inserted that there is still a diffuse lesion before the D1 taking off and after the D1 diffuse lesion. So what we did, when the slides advance, I will show you what we did. Can you go one slide up? It's not advancing. I broke the PowerPoint presentation, sorry for this. So it's about this lesion, and if the technicians can help, then we get the next slide.
Sorry, just a computer problem. We resolved it.
It's
will be
5
soon
gigabytes.
in
No, it's
2
not, but okay. So to sum up, we have an intermediate. Okay, now starting. Okay. What we did a physiology assessment with the optowire by Hemonetics, the newest version, and what we measured is a DPR, a diastolic non-hyperemic index of the D1, and you can see on the left panel the position we started, and we measured the DPR is 0.92, so no, it's over the threshold of 0.89, and we did a pullback. The pullback, there you can see the start of the pullback has even a higher value of 0.94. So, and there was a little bit of a slip coming to 1 before this bifurcation. When we did a physiology assessment of the LAD, we have a pathological value of 0.86 in the distal LAD. It's marked with an A. And in pullback, you can see 2 slight jumps. The biggest jump is B at the level of the bifurcation, and then normalizing up to C in front of this diffuse disease in the mid-LAD. So the precision PCI strategy on the table was to discuss that it's possible to do PCI on the table. We discussed with the surgeons, and they said it's elective. We can wait for another 4 weeks, and we decided to do precision PCI, doing also intracoronary imaging. The plan was to do lesion preparation and then provisional PCI with a DEB strategy of the LAD, and then afterwards we do post-assessment of physiology and, of course, IVUS. I will now show you, you see it, the opto wire. This is the wire we put and measured the pathological value in the LAD. It's quite fine. I will show you on the last slide how it works. It's plug and play. It's like a BMW wire. You can work on it easily. And we put a Xeon Blue in the D1 to save it. And I will now show you the SyncVision pullback coming from the LAD. You see this diffuse lesion, plaque burden. Now it's becoming a little more plaque burden. And here, extensive plaque burden. And you see here calcification. What you can't see on the angiogram, you see it now on IVUS. And you see a very big vessel, LAD, coming back to the left main with a good lumen. So the decision, I show you the landing zones, what was defined as distal landing zone. You can see how severe disease the vessel is distal to the bifurcation. And of course, at the level, you can see at 5 o'clock at the level of the bifurcation where the wire is coming in, you see 270 degrees of calcium. The proximal landing zone has a plaque burden about 40%, so feasible for PCI. So the decision was made on this integration of physiology and image-based imaging to do a one-on-one lesion preparation with an NC balloon at slightly 12 atmospheres, and you can see in the SyncVision that the balloon has good apposition. Also, at the level of the bifurcation, the balloon is well expanding in the angiogram, and you see the results after PTCA with an NC balloon. I go back. It's not running. Can you show the last picture? The last slide, the right one, maybe? Sorry about this. The right one? The video? Yeah. Oh, a lot of lag time. Okay. Okay. The angiographic result was quite reasonable, so the decision was made as planned before to put a DCB. The lesion length was about 38 millimeters in the SyncVision, so the decision was made to go on one-on-one and not to overstretch it with a paclitaxel-eluting drug-coated balloon, Boston Scientific agent, 4.0 by 30 and 4.0 by 12 millimeters. You can see here also well expanding, and this is the final result. You can see there is a little bit of an impingement of the D1, and you can see a dissection if you look that there is a dissection but no flow limiting. The PCI was done with 18 milliliters of contrast, so low contrast because it's image guided, and you have to finish an image guided case with imaging. You can see the proximal landing zone. You don't have dissections there. You have a good luminal gain. The distal landing zone, no distal dissection in this diseased vessel. And at the level of the bifurcation, remember it was 270 degrees of calcium. You have good lumen gain, but you have a little bit of a dissection. You can see it here. It's 45 degrees of a dissection. As Bruno Scheller said, you have to create dissections if you do DCB. So there is a dissection, of course. You can see it in angio, but it was not flow limiting. So what we did it IVUS guided but we have this wire on the shelf, and we did a physiology assessment, and we can see that the physiology assessment that the non-hyperemic index improved from 0.86 to 0.95, and of course, if you have it on the shelf, you also, because now you have a little bit of a pinch D1, the value is quite stable at 0.93. So I can sum up. This is what the OptoWire is about. The key benefit of the OptoWire, in my honest opinion, is that it's fiber optic, that it's stable, has good support, is good talkability, that you have the freedom to plug and play, that you can work on the wire, and it's very accurate. You have little drift or no drift, and you can work on it, and after the PCI you can do the pullback, and you land up at 1.0, and you're done. So I can sum up in my precision PCI summary is that precision PCI, taking into account that you have to go radial, do it low contrast, integrate intravascular imaging and physiology is key to treat our bifurcation patients. So thumbs up for Snuffbox. DEB PCI is feasible option for patients with oncology disease and for people with high bleeding risk. And last not least, physiology assessment pre and post PCI is key for precision outcomes. Thank you.
Thank you very much. Great talk. I was invited last week at the German autumn meeting in Hamburg to give a talk on DCB, and we had also live in the box case on the Novo disease. And we were told that if you see such dissection in a major artery, the guidelines clearly say you have to stand it. What is your answer to this?
So I don't think so that we have to stand. We have data coming from the area from Grünzig, where we had a lot of dissections and dissections heal. And this minor dissection, which is a type B, type 2 dissection, with no flow limitation, doesn't push me to put a stent inside, because the main approach of me was not to put a stent in these patients, because after 2 weeks on dual antiplatelet therapy, he's able to get surgery after getting rid of the clopidogrel. So I follow your approach. I know your approach on this. If you have no major dissection, not medial dissection, then you can leave it as it is.
Okay. Further questions? No more questions from the
So
audience?
Star Wars is kicking me out.
With the patient, it's very good case, very good presentation of physiology and imaging, and also very tricky to treatment the patient with a low level of platelets. But it's a cancer patient, and what's going on? Patient is waiting for surgery.
Yeah, patient is getting surgery on Monday, and I can report maybe next year on social media how it worked. So, so the patient, this case is 2.5 weeks ago. The patient get rid of clopidogrel for 5 to 7 days, and then is getting surgery. He had stable platelets. But we know cardio-oncologist patients are worse treated, like females are undertreated, and patients with carcinoma and are undertreated everywhere around the world. So this is what the decision was made in the first index procedure 3 months before, to do nothing, leave nothing behind, but you could at least say do physiology and see if patient needs treatment, or you can put in on medical optimal medical therapy, which he was on. He had HFrEF, he was on bisoprolol 10 milligrams and all other things, Magic 4, and still having chest pain.
One short question from the audience.
Yeah, that's really the general question. How did you decide on 2 weeks of antiplatelet therapy with that dissection?
I think there's data on it for DCBs to do it for 2 weeks. The general recommendation is for cardiologists, oncologists, patients coming from SKY, which is from 2016, to put a BMS and put the patient on DAPT for 4 weeks. I haven't used a BMS since 9 years. So it's a little bit, it's not evidence-based medicine, to let you know. It's eminence-based, but I think it's feasible to do it to give time to the lesion to heal, and I think 2 weeks are enough.
Okay, and I have a question, and I think in your case, then you are lucky because then you choose the very big size free balloon, so 4.0 millimeters. So in the era of balloon angioplasty, and usually the balloon to vessel size is over 1.3 ratio, and it can be easily developed severe dissection.
Yeah.
And flow limiting dissection, I mean. So I'd like to know what is your Vera stenting rate in your...
The reference diameter distal in the LAD was 4.3, and proximal to the bifurcation was about 5. So the DCB just touched, but the aim was to treat the lesion at the level of the bifurcation, distal to the bifurcation. You can see, you can use the smaller DCB and touch nothing, but my decision making on having an IVUS eye, maybe on angiography, is choosing for a little bit undersized, not 1-on-1, but it's 1.9 maybe. Yeah, but the risk of dissection is even greater when you use big balloons and NC balloons.
Great. Thank you so much.
Thank you.
We are a little bit running out of time. Now comes the long-awaited final talk by David on the planned new trial.
All right. This is tricky. It says looking for sources. That's not very encouraging, is it? Here we go. Okay. Excellent. Thank you. Right, EBC DCB. I managed to say it without tripping up. That's good. Briefly, the background to this. Okay, so nearly all my career I've spent trying to work out how you should stent the LAD diagonal territory, because it's always LAD diagonal. That's at least 80% of the cases. That's where all the interest in bifurcations came from, right from the Nordic 1 trial. And actually, let's put it a different way to how I've written here. If somebody now came to you with a thing and said, "Oh, we got this great new technology for coronary arteries called a stent. We're going to apply it to bifurcations," you think, "Oh, that's not very good, is it? So it's a single cylindrical metal tube that you put down. Well, you only do one limb or the other. So then what do you do?" And you go, yeah. What you do then is you mangle it, and you expand it, and then you cross it with the wire, balloon the side, malapose it, and then push it back together. And you think, no, it's all right. I'm going to stick with my balloon therapy, if you don't mind. So, that's the other way round of looking at this, is that, we have spent ages and ages trying to refine how we should do this, with, how we approach the procedure. And actually, it's still slightly messy, because, as we have increasingly been discussing over the last few years, there are nagging doubts about this. One is the clinical experience of it. We continue to see drip, drip, drip of late acute or acute on chronic stent occlusions, which we were not expecting. We originally thought, it was all Taxus with that horrible polymer, and it's all the fault of that, and it doesn't apply to modern stents. It doesn't apply now we do imaging and stuff like that. But I don't really buy that. The attrition, show me a study where we haven't got that kind of 1 to 2% annual attrition rate with stenting. And that's related to, lots of different factors, but it can make further treatment very difficult. You can't take that stent out once it's in there. Permanent metal implant, it's an inflammatory nidus, however you look at it. It has some disadvantages and permanent antiplatelet issues. So, against that backdrop, and against, I'm rather delighted to say, some ab-reaction from colleagues across the large pond who've taken shock that this has been suggested as a trial. We're all going to do a randomized trial of stepwise provisional stenting versus drug-coated balloon therapy for non-left main stem true coronary bifurcation studies. And hats off actually to Medtronic for deciding after, ordinary preamble to back the format of this study, which was very much not, let's just do the side branch and see if it's okay. No, we're going to do the whole thing with drug-coated balloons. So it's got all the governance that you'd expect of a big study. CERC will be the research organisation, have steering committee, DSMB, CEC, all of that kind of stuff, a core lab. It'll be a 750 patient study, 1-to-1 randomization of DCB against DES. It'll be the Medtronic platforms. There'll be 6 to 8 countries. Now, here comes the fun bit, 20 sites. So, countries that are already in the bag, because they've paid me lots of money, are the UK, Germany, Italy and France. Now, if you are from a different country and you'd like to be in this study, I will be available in the foyer afterwards. Okay, so the hypothesis of the study is that drug-coated balloon therapy is non-inferior to provisional drug-eluting stent implantation for non-left main stem true bifurcation lesions, and the objective is similar to look at the stepwise drug-coated balloon strategy versus the stepwise provisional drug-eluting stent strategy. How's this going to be done? Okay, so I'll come to some of the inclusion criteria in a minute, but it's going to be 1-to-1 randomization with the primary endpoint of a 1 year. It's a bit of a mouthful, this bifurcation-orientated composite endpoint of cardiovascular death, target bifurcation-related MI, and target revascularization. Okay, so not much argument probably around that. We'll have secondary endpoints, and very deliberately it's out to a long time scale because, it may be that it takes a little while for the benefits really to become apparent, and that's why I think it's taken us, I should say me, but it's taken us so long, I think, to realise what the disadvantages of stenting are. So it'll have out to 8 years endpoints. These are all the secondary endpoints. You don't really want to hear about those at this stage. So inclusion criteria. This is a little bit indigestible, I'm afraid, but bear with me. True non-left main stem bifurcation disease. Medina categories as you would expect. Bifurcation lesion being responsible, so that you must meet both these criteria. Responsible for an acute or chronic coronary syndrome with at least one of the following. The print starts to get a bit smaller, I'm afraid. Greater than 70% angiographic main or side branch diameter stenosis. Either positive non-invasive testing for ischemia or positive coronary physiology or imaging for ischemia. And then a significant side branch diameter stenosis, and building on the work of Bon Kon-Ku, who I hope is here, maybe not. Side branch length 73 millimeters. Side branch diameter greater than 2.5 with no more than one other side branch. So this is the kind of single diagonal phenomenon. Or similarly, a largish diagonal that has nothing further downstream of it, or one that has a non-dominant circumflex artery. So I'm sorry, it's a little bit complicated, but it basically means anything that you look at that thinks, that's an important side branch, probably will fit in the study criteria. The exclusions are the standard stuff about STEMI and cardiogenic shock and really, really terrible left ventricular function. You can do other lesions, of course. It's not that common to find an isolated bifurcation lesion. We can't do more than 2 others because otherwise we'll get too much noise, and those should be treated with the same technology. Here's just the list of the exclusions that we're expecting. Here is the trial schema. It's a little small on this page, so I've cut it into 2 bits. And as was discussed earlier, the randomization is going to be upfront to avoid people perhaps doing timid predilatation and then allowing the patient into the study. So the randomization is completely upfront. The stepwise strategy, I think we're all pretty familiar with, so we won't go through that too much.
The drug-coated balloon strategy we will go through a little bit in a second. I'll skip this because I'm going to talk about it in this little bit and we're short of time. So the important concepts, I think, for this study are, okay, provisional stenting, straightforward. We've all been talking about it for years. We know the drill. It's exactly as written on the tin. For the drug-coated balloon strategy, and it's taken us a while to learn from all the people on the panel here who've been doing this for years. The basic strategy is wire both vessels, one-to-one pre-dilatation and preparation of the main vessel first, and that will probably mean more liberal use of cutting balloons, scoring balloons, things like that, than previously we've been used to with just stenting. Then, if acceptable, and I'm going to come back to what that word means, then one-to-one pre-dilatation and preparation of the side vessel, DCB to side vessel, DCB to main vessel. So it's main, side, side, main. What is the meaning of acceptable? And this is where people will develop their own expertise over time, but for the protocol, acceptable in terms of pre-dilatation and preparation means that you shouldn't have more than 30% recoil of your lesion post-preparation. That either means that it's too fibrotic and you're not going to get good dilatation of it, or that you probably, in 90% of cases, actually need to do some more to make sure that you get to fully expand it before you consider putting a drug on the wall. TIMI3 flow, obviously very important. You're not going to end up leaving something that has less than TIMI3 flow. And then in terms of the dissection, I think it takes a while for people to learn what is acceptable to leave, what is not. So and the exact wording is still being negotiated, but no dye hold-up at and around the treated lesion. So the old category, the sort of type A to type H, nobody can remember what those categories are. And so we all sort of say, well, if we say B or C, that sounds about right. But nobody remembers what they are. So let's forget that. Say no dye hold up at and around the treated lesion. No dissection that's actually propagating beyond the treated territory. Because that means, okay, it can keep going, but you need to secure it with a stent. Sorry, I'll just go back to that. So those are probably, at this stage at least, and the guys will be able to tell us, is this what they see as the correct definitions? And then all follow-up after that is clinical. It's outcomes based on numbers, really. So do the patients do well? Do they get any recurrent angina? Do they come back with hard clinical events? And the follow-up strategy, sorry, this is a repeated slide. The follow-up strategy basically is clinical from interviews at 6 months, 12 months, 3 years, 5 years, 8 years. So with that study, we should ideally, I think, have a really large group of patients that we can work out over time. Do we get at least non-inferiority using drug-coated balloons compared to stents? Because from my point of view, if we get non-inferiority, then the drug-coated balloon is by miles the winner because it has lots of ancillary benefits to not having that permanent metal implant in your arteries. Okay, that's the end of my presentation. Open for discussion. Thank you.
Great. I think very provocative this design, but we are happy to do this. So I think we have many questions from the audience.
Sorry, I didn't get it. In the provisional stenting, you stent the main branch and you go through all the steps. In the side branch, is it just a normal balloon or do you put a DEB in the side branch?
No, normal.
Okay. But if the trend nowadays is going towards DEB, should we not be putting a DEB? Because you're almost setting yourself up for another study, because if the restenosis is in the side branch, we're going to say, well, a DEB would do better.
No, other people could do that study. I mean, we've done loads of studies. We've done loads of studies with kissing balloons into the origin of the side branch, and the noise rate is surprisingly low.
Patrick?
David.
Yes.
Here,
David. Here,
yes,
here.
Patrick.
No, I think that it's very ambitious, and it's good to be ambitious. And the long-term follow-up, that's what I've learned, is the most important things. At the end of the days, we are planning now something again with the surgeon. It's the qualities which is important. I'm alive, and I'm happy.
Yes.
And I can play golf or whatever. That's what is important. So that you go 1 or 2 times on the table because you have to redo that DCB, it's a good thing. We should forget this revascularization as a definitive, dramatic event. No, you can work on the coronary for a long time. So I like that very much, the long term. I like also very much all the pragmatic aspect. I think at some point you will be able to quantify one technique of the others, the myocardium at risk, and not go for the things which is pitiful and small and not useful for the patient, not useful for the prognostic. There is one thing I disagree, is the use of the word provisional. I'll tell you a story. I introduced that word in 1989.
Yes.
And initially in my abstract it was conditional stenting. And I didn't like the word conditional. So I went to the Webster and I found the word provisional.
Yes.
It sounds good. It sounds British. Okay?
Yes.
So I use the word provisional. But it's not the stent which is provisional. It's the drug-coating balloon which is provisional.
Yes.
Because if you go to the Webster, a provisional government is something which is not stable and will disappear. So all these years, I introduced the wrong word for provisional stenting.
No,
stenting is definitive, as you said, is a piece of metal who would stay forever. What is provisional, transient, is the attempt of the drug-coating balloon. And recently, we were again not correct, because I correct in advance, by the Lancet, who said that word should not be used as provisional stenting.
Yes.
It's definitive stenting and provisional drug-coating balloon.
Yes, I completely agree with you, actually. But when it first came out, I was much too junior to raise my head and say that's the wrong word. I completely agree. I assumed it was Thierry Lefebvre, but now I know it's you. I can argue with you later.
Yeah, I mean, I'm not British, so you have to excuse me that I use that word that I found on the Webster, but I used in the wrong way.
We'll look for a new
For
word.
35 years.
Yeah. David, great design.
Sorry.
A great design. I have 2 questions for you. One is, why do you go for the non-inferior design and not a superior design? Yes. Because you say there are a lot of auxiliary things or advantages of using DCB.
So I think it satisfies both, I hope. Yes, question, sorry. Yeah, I think that muddies the water. You know, I mean, we've seen from some of the studies from Xiaoliang Chen's group that sometimes when you have angiographic follow-up, you then have event rates based on the oculostenotic reflex. DK Crush 2 and 5 both suffered from that. So we really wanted to say, no, let's do a trial which is sufficient numbers that the clinical endpoints as they come along will define the result of the trial.
What about lesion length on side branch? I mean, is it unlimited or?
Okay. So we haven't put an exclusion in there, and it depends a bit. I mean, maybe some people, when faced with a 20 millimeter lesion in the side branch, will sort of think, oh, I don't want to put that one in the study because it maybe needs a stent. But by the same token, they're going to be treating a long lesion in the LAD and using drug-coated balloons. So we've deliberately excluded that as an exclusion, if you see what I mean, and left it up to people's discretion.
That might be a big difference between short and long lesion anyway on the side branch.
I'm not sure, actually. I mean, if the DCB actually proves to be effective after predilatation, then there's no reason why, just because it's the ostium and origin of a side branch, would be any different to the main vessel. So I think we'll wait and see with that, but we deliberately left it out because of that.
Second point is about kissing balloon in provisional stenting.
Yes.
It is mandatory, or?
It is mandatory simply because we wanted things to be equal between the two groups. In the DCB group, you're definitely treating the side branch. So in the main vessel group, we have to have equipoise, and it's a 1-1-1 lesion, so it's perfectly reasonable, although not obviously advantageous, to have a kissing inflation.
Yeah, but this might induce some some deformation of the stent caused by wrong crossing of the stent. And I think if you do not have need for crossing the stent, I think it's better not to cross the stent.
Sure. I mean, and that's a separate argument. But in the study, what we need to have is two groups that are comparable. What we didn't want to do is have diagonal branches that are so small that basically this was just a study of drug-eluting balloons versus stents in a main vessel, that happened to have a rather small bifurcation. It has to be important enough that it could have event rates on its own right.
So sizing mandated by intravascular imaging?
No.
Okay,
No.
and then do you have a sense of how much crossover you may have?
10%. It's a bit of a guess, but the guys will be able to say.
I think this is one of the challenges to have the crossover rate to stenting in the DCB group under control. I think that this needs maybe some training of unexperienced sites and clear rules in the protocol as discussed. I think.
What about the APT? Because one of the benefits of DCB is to make the patient less dependent on the APT.
Yes.
Is a part of the benefit of the strategy. There is a difference in the documentation.
There is. So there's mandated or stipulated DAPT requirements in the stable and in the acute setting for both the stent group and the DCB group. And obviously it's a bit less for the DCB group. Yeah.
Calcium modification?
Sorry. Yeah, we got it.
Okay. I think we have to close. Great session. Thank you very much.
No problem. No problem.
Okay, so I think that we can start this session. So please take a seat. This is going to be a woman has one session, and so this is a joint session by European Bifurcation Club and Women as One to the My Best Bifurcation Dilemma. This is a case-based session, and it's a pleasure for me to chair this session with Tom Johnson. Joanna, I don't think she's here. I think that, as you know, there were problems in airport with the flight cancellation. And then we have as a panel Sandra Zengenbil. Hopefully it's correct. Then we have Stefan Harp. Then we have Sasho Nikolov. It's okay. It's correctly pronounced. So the first case is going to be planned two-stent technique after STEMI with a difficult side branch access, when, which, and how, and is going to be presented by Ivana Ivelic.
Thank you for the invitation. It's a really honor to talk here at the EBC. And now, after all these DCBs, we will talk about something different and get back a little bit in the past. Okay, my patient is a male. He has 59-year-old. He had inferior STEMI with the chest pain 3 hours before admission. Upon arrival, he was in cardiogenic shock. He was pale. He had shortness of breath. His BP was 80/60, and from his risk factors, he had hypertension, smoking, and obesity. His lifestyle was active, in a good condition, and his ECG showed ST elevation in inferior leads. So, this is the angio. As you can see here, we have an acute occlusion of the prox to mid RCA, and this is after primary PCI of the RCA with the 3.5 the DES stent. Okay, on the left side, we have a significant stenosis of the proximal and mid LAD with a Medina 111. That is a plaque that is going all the way from the proximal to the mid LAD and into the diagonal. And this, sorry, can you please give back the video from the? I cannot give back. Can you play the video? Sorry. On the video, you can see it maybe more clear where the stenosis were. So, what to do now with the bifurcation? When to do the PCI of the bifurcation? We know that if there is a true bifurcation in cardiogenic shock, all those trials showed us that we should not do the PCI of the bifurcation at the same time when we do a STEMI. Because this intervention, we thought it would be difficult and probably will take more time. It won't be just an easy one single stent. So we decided, according to the new guidelines for the acute coronary syndrome, to do the complete revascularization, which is recommended now, either during the index PCI or within the 45 days. But because the patient was in the cardiogenic shock, we decided to do the stage complete revascularization. And the decision was to do it 1 month after the STEMI. And what to do with the technique? Which technique? It is a Medina 111, so shall we do provisional or planned two-stent technique? Is this diagonal an important side branch? Is it larger than 2.0 millimeters? Yes, it is. Is it a difficult approach to the side branch? Yes. And it is a significant osteal disease of the large side branch, and we do not want to lose it. So we decided in advance to do a planned two-stent technique. So which technique? The angle was less than 70%. And on this algorithm by the EBC, we decided to do an inverted kilo technique. So this is how it went. It was a 7 French radial approach slender, wiring first the most difficult branch, which was a side branch. Here you see this angle again, and we tried to shape the wire for the side branch approach, and it was extremely difficult access because it was an osteal disease, the side branch was angled, and it was calcified lesions. So all of these techniques that you can see here in these pictures did not work. Single band, double band, progressive curve, and it really took some time. So for this kind of extremely angled ostium of the side branch, a hairpin bend-shaped wire at about 5 centimeters from the wire tip is a good way to bend the wire and enter the side branch. Of course, if you had a microcatheter, would be extremely helpful, but we haven't. So this is how it went. Shaped wire is advanced in the distal main branch. Wire then is pulled back, and hook-like band of the distal tip engaged the side branch. And after engaging, the wire was advanced in side branch, turning counterclockwise. First, after wiring the side branch and then main branch, we did a predilatation of the side branch with the SC balloon 2.5. This was the angio after the predilatation. After that, we did a PCI of the side branch with a 3.0 stent. And with the stent in the side branch, this is at least 6 to 8 millimeters. So POET after PCI of the side branch with the NC 3.5, and the distant balloon marker was at the carina, and we did a high pressure inflation at 24 atmospheres. After that, we did a rewire kiss with 2 short NC balloons and simultaneously deflate. The second pot after kissing with the NC 3.5. Then the PCI of the main branch with the 3.5 stent. After that pot with 4.0. And after rewire through the distal stent shot in side branch, 2-step kiss. First NC 3.0 in the diagonal with high pressure. And then second step, NC 3.5 in LAD. And NC 3.0 in D1, both on 12 atmospheres, so lower atmospheres, simultaneously deflate. And this is a final pot with the 4.0 balloon. After that, we did a PCI to the proximal LAD, then stenosis that was proximal, with the 4.0 stent. So this is, as you can see here, the final result. And some take-home messages. The timing of the revascularization of the non-IRA vessel after STEMI during index hospitalization or within 45 days depends on the individual approach for each patient. In most cases of bifurcation, provisional approach is preferable. Case, keep it simple and safe. Disease of the main branch and large and completely ill side branch that we do not want to lose and which supplies a very decent myocardial muscle with blood often leads to 2-stent technique. narrow bifurcation angle, ostial disease of the side branch that can mean difficult wire access and concern of the side branch occlusion, no large mismatch between proximal main branch and side branch has led us to choose inverted DK culotte technique. Pot and final kiss is mandatory in 2 stent strategies, and double kiss after first stent and after second stent at technical complexity, but resulting has the potential for very good stent configuration. Thank you.
Okay, so this is clearly open to discussion. I didn't mention, I'm sorry, this is a case competition. So we will have to vote for each case, and then at the end there will be the best case of the session. So there is a question coming from the audience.
Well, so the difficulty actually wiring the diagonal really suggests that you have an angle that's a lot larger than 70 degrees. So I would probably not have used a culotte in this case, but rather a T-stent or a tap or something like that.
Yeah.
Would have been my suggestion, because actually you might have even more than 90 degrees, because it kind of looks like it goes a little bit upwards.
And then downwards.
And
Yes,
then
we were
downwards.
thinking about that. Thank you for that question. Yeah. And also, we were thinking about maybe DCB in that side branch. But because of that difficult wiring and everything, we decided for the 2 stent technique.
The lower angle you have, the easier it will be to wire the diagonal, obviously.
Obviously, yes. Thank you.
It was perfect solution to start with the diagonal branch first stenting, because afterwards, if you put on the main branch, you probably would have lost the side branch, and you will never
Go back in.
Yes. Yeah, it's either it's culotte or something else. Maybe the preferred technique.
Yeah.
It's maybe in this case
The most familiar with
yes,
this
most
technique,
familiar.
yes, it's vascular.
One question, what about imaging? Because now, you know, we have guidelines, and this is 1A recommendation. It's a true bifurcation lesion. So which is your practice with the intracoronary imaging? You have a limitation to this use, or intentionally you did not use it? Intracoronary imaging.
Unfortunately, I'm working in Bosnia and Herzegovina, and we do not have imaging yet. So that is the reason why I haven't used it, yes.
So you saw before there was a QR code. So if we can have the slides, so you can vote using this QR code for each individual presentation, and at the end we will have the case with more votes. Okay. Any other question?
Yeah. We've just heard a lot about drug-eluting balloon. We have also heard the possibility that we don't decide up front which strategy we want to go for. What do you think about, like in your case, would it have been possible to postpone the decision what to stent and how to stent for after lesion preparation?
Yes, at first that was the plan, but I don't have any more time to talk about it in the presentation. But after maybe it took me half an hour to put that wire in the side branch. And that is why I was returning to my first plan to do a 2-stent technique.
Excuse me. What wire did you use?
Sorry?
Which wire did you use?
I used BMW, then Fielder, then Pilot, and then with the Whisper it was done.
So to wire these lesions, you need a little better tip load.
Yeah.
Plus you need a little better body in the wire. That is how it helps to hook and push.
And as you mentioned, also the use of maybe a dual lumen catheter or microcatheter may have been an
but
alternative approach. No, I know you've achieved a fantastic result.
Thank you.
Truly.
But even sometimes, if you don't have the microcatheter, you can use the balloon as a guidance to near the lesion, and after it you can better control the wire inside.
Yes, but the angle was really difficult. I
But
tried with the small balloon, yes.
Yeah, the balloon
yes.
You see the marker, and after the marker you can...
And then tried to put it there, but it was really difficult.
Great. Well, thank you. Lovely presentation. I think we'll keep to time. So it's a great pleasure to invite Jolanta Slamatje from Austria to present on the sex and gender differences in peri-PCI antithrombotic treatment, a left main bifurcation case. Yolanda.
So thank you very much. Good afternoon. I'm absolutely delighted to share with you a case which I performed at midnight. So it's a lady. She's 76 years of age, and she's presenting to the hospital with shortness of breath. And she has a known atrial fibrillation. At that point, she's in tachycardia. She is treated with NOACs. And of course, the TNT is elevated, and you can't see actually nothing special in the ECG. It's atrial fibrillation, but on the day 3, the troponin are rising. And also the CK, and she has a positive D-dimer, although she is anticoagulated, so there is a CT scan done. There's no PE, and she received a TAVI 2021. In this case, I've done 2023. So she also has a heart failure with mid-range ejection fraction, renal failure. She's obese, has osteoporosis and renal anemia. And there is a coronary angiography done 2021 before the TAVI, and there's just a CT of a small RCA, which is codominant, and I will show you. This is the angiogram 2021. So actually, at the beginning, we also, or the colleagues who were, on call, reviewed this angiogram, and nobody was actually thinking about any new event. So, but a very actually a young doctor called me. It was really midnight, so we're all really tired. That he does not believe it's only atrial fibrillation. So I say, we should do another angio. So let's see. And after I engaged the guiding catheter, which was really not easy with this accurate neo prosthesis, the patient became, of course, hemodynamically unstable, and you can see it must be a plaque rupture, because I can't believe that during 2 years there is such a disease progression. There was a 30% ostial LAD stenosis during the first angio, but this is a really very big circumflex. So what I did, of course, it was not easy to put the guiding catheter into the ostium, so I used very fast the guiding wire, because I was afraid I will lose, I will disengage, and the patient was treated with edoxaban, so she received the morning dose, and she also received from me after the radial puncture, also heparin, and at this time point also aspirin. And I decided very fastly, so what should we do? Because this is actually an acute coronary syndrome. She's unstable. It's a midnight. How should I treat this bifurcation lesion? It's not an elective case. So I decided, the first most important thing for me was to, because it's a huge thrombus burden, you can see this, to have a very potent platelet inhibition. So I started the congrural bolus, and I disengaged the guiding catheter, and after 5 minutes, actually, according to the position paper of the European Society of Cardiology, what to do with anticoagulation in unstable patients and patients with cardiogenic shock, because, of course, at that time point, she has developed a lactate of more than 5, to give a very fast intravenous antiplatelet agents. And indeed, there is a data for Cangrelor that it improves the reperfusion and also the rate of the open vessel. And you might ask me why I did not use GP2B3 inhibitors, and the reason is that there is a sex difference in the bleeding risk for those agents. So as you can see that we, in all studies, women received excess doses of GP2-3B inhibitors, especially those who have a renal failure and older patients. And we know that if a woman is over-anticoagulated, and this patient received edoxaban and heparin, and she's older, and she received a TAVI, then if a man is over-anticoagulated, the risk of bleeding is not so high as compared to women who are over-anticoagulated in the cath lab. And it also was for me a decision to use a cangrelor, which is independent from the renal function and also does not increase the bleeding risk in the cath lab. And this is the first shot after the cangrelor bolus. You can see here, like from the movement, of the muscle, that at that time point the patient was hemodynamically stable. She, of course, received one bolus of noradrenaline at the very beginning when the vessel was closed. So now I had a stable condition. So now I could decide on the bifurcation strategy, and because here in this case, it's a left main vessel. It's like it's actually a codominant circumflex. I decided for double kiss crash because I had a very large vessels, plaque rupture. And I did it because it's a technique I use most, and I'm experiencing this technique just in 15 minutes with these classical steps and for 0 balloons, I was done, and 5.5 port and kissing and re-kissing and double kissing and so on. So this was the final result. I was really happy with that. But this is not like over. I think we should not think about, treating lesions in such situations, but we have to have a plan. So I always calculate for my patients, before giving a final recipe how to anticoagulate and how to do the antiplatelet agents, because normally I would go for the one stent strategy, but not in such a case, with a huge thrombus burden and plaque rupture. And using this very useful tool, this is the Academic Research Consortium High Bleeding Risk Score, when you can weight the the risk of bleeding against the risk of having an ischemic event. So both were high, but the patient was in this yellow area, which means that her risk of bleeding during the next month was much higher than the risk of ischemic or thrombotic events. That's why I decided for this strategy, just although it was a bifurcation, just going for 1 week of triple antithrombotic therapy. At my institution, I do always test for clopidogrel responsiveness. If I'm going for clopidogrel monotherapy, she was responsive. Just the next 6 months of clopidogrel and edoxaban, I invited her to our outpatient clinic 2 times, and so after 6 months, she said she's having epistaxis, so it was just not a really huge bleedings, and then I decided to just go for edoxaban monotherapy, and I saw her recently after 1.5 years, and she's really doing great, and yes, I was really very lucky to have those tools. So this really matters. What I'm really trying to give you the take-home messages, that in such acute cases, it's a holistic approach. It's not only about stents, but before deciding about bifurcation strategy, it's really important to stabilize the patient, choose the really fast-acting antiplatelet agents, take care to not over-anticoagulate patients, especially ladies in the cath lab, because this is associated with a higher bleeding risk. Femoral access in women is an independent risk factor of mortality because of major bleeding events. We know that in such occasions, aggressive treatment in the acute phase is important, but then step down according to the bleeding risk really improves outcome. If we would use those tools and those calculators on a daily basis, we know that 50% of women are at very high bleeding risk, and 30% of men. So there's a sex difference which matters. So thank you very much, and I'm happy to answer any questions you might have.
So thank you. Wonderful presentation and a horribly complicated patient. You've only left us 3 minutes, and I've got loads of questions, but I don't know if there are questions in the audience. If I could explore, so the excess dosing of GPIs in women, what's the driver for that? Bad guesstimating weight, age?
Both.
What are we doing
And
wrong?
we know that women we are treating in the cath lab completely differ from men we are treating in the cath lab. So women are on average 7 years older. They are diabetics more frequently, and because of that, and because of not treated hypertension, they are having renal failure. And because of the differences in the weight and creatinine clearance, we tend to absolutely overdose them. Even those data I've shown are coming from the randomized trials, actually, in which doctors actually should, use those drugs according to the protocol, but we do not.
So my question is, regarding then hemodynamic stabilization, maybe, I don't know, the case is done when? It's from when, this case?
It's one and a half year ago, yes.
1 year ago.
Yeah.
So, we could have discussed about stabilizing hemodynamically the patient with devices, with MCS, and that's one question. And the second is, what about imaging?
Absolutely.
What about
Thank you.
imaging
Yeah.
guidance? Because we know, there are countries where, that's why I ask, there are countries where you don't have access to these technologies, but Austria, I think there is access to the technology. Then I don't know if you have coding, reimbursing, but this is a left main, big left main, you implanted 2 stents, now you have a class 1 recommendation, class 1A recommendation, and we had already data that actually showed the benefit.
Thank you so much, Alaida. Really important questions. So actually, if 5 minutes after I gave the patient the bolus of cangrelor and I had a wire into the circumflex and I disengaged the guiding catheter because this was probably also the angle, the Stavi device, patients became stable. It was like a wonder. If this would not occur, of course, I would go to the impeller. We have this. But I also had have taken it into account the patients was actually really anticoagulated at this point. Edoxaban plus heparin 5,000. She had an ACT of 390. She was obese. Even with ultrasound guidance, the risk, of bleeding complication due to puncture and impeller is really high. So I had to wait once again in other. And about imaging is I used really maybe 80% imaging, but it was really during the night. And my point was to do it really very quickly. And if this would be elective case, I would use imaging.
I had a question in my country 1 month ago about which is more incident in myocardial infarction in men or women. And I said up to the climacterium of the women, the higher stage of infarction it has the man. But after the climacterium or in the period where the estrogens go down, we have the higher incidence in women. So the estrogen hormone probably should be considered about the anticoagulation, antiplatelet therapy, and of course, much importance about the antihypertension therapy. So we have to, as a gynecologist, work with the cardiologist.
Absolutely, I can only agree.
We're going to have to move on, I think. I'm sorry. Aleida is doing the work in terms of saying how about imaging with case 1 and case 2, so Fizzer, watch out. But imaging works at night. But actually it's incredibly stressful to consider doing it at midnight. But in a patient with high bleeding risk, where the concerns in terms of the antithrombotic therapy, DK crush in the left main, she could always be brought back in daytime for optimization. That would just be a final comment in terms of the nighttime imaging. But Jolanta, thank you so much.
So we are going to the next case, that in this is a case of acute thrombosis of the left main with ECPR, and the case is going to be presented from Fizza Chaudhry. Yeah. I hope it's correct.
Oh, good. Okay. So thank you for giving me the opportunity to present at EBC. And my name is Suza Chowdhury. I'm a consultant in intervention at Bart's Heart Centre in London. And my case is a acute thrombotic left main stem PCI with extracorporeal CPR. So it's a 42-year-old gentleman. He had a strong family history of premature coronary disease and all the risk factors for coronary disease. He's a smoker, hypertensive, he's hyperlipidemic. He'd been getting on and off chest pain for about 2 weeks, and then ongoing chest pain, which made him present to the local district hospital, got ongoing for about 4 hours. His ECG showed left bundle branch block and some anterior ST elevation, and he had a troponin of 2000. His bedside echo, which I hope you can see, but there is a severe LV systolic dysfunction. Because of ongoing chest pain, he was then transferred, I can see it over here, he was then transferred to the Heart Attack Centre, and on arrival, he was self-ventilating. He appeared slightly pale and mottled. His heart rate was about 100, and his blood pressure was sort of teetering on the edge at about 100/60, and he had ongoing chest pain. So in terms of the Sky shock stage, he was about an A to B, but potentially going at risk of going into further shock. These were his diagnostic pictures. So he has quite diffuse, probably significant coronary disease in the right, but he has this very tight distal left main stem and likely to be thrombotic with the ongoing chest pain, and may well have transiently occluded that at some point. He's got severe LAD disease, long length as well. So essentially, this is a 42-year-old male who's got an acute thrombotic left main. He's hemodynamically stable at the moment, but at risk of going into shock, and he has ongoing chest pain. So at the time, we had the revascularization options of either emergency PCI or emergency bypass, and it was about 9:30 in the evening. I got a surgeon into the room who had a discussion, and invariably they always say, well, just get on and go for PCI, given he's got ongoing chest pain and is unstable. So that's exactly what we ended up doing. In terms of the PCI strategy, we've talked about provisional, that lovely word, whether we go for a 2-stent strategy or whether we go for complete revasc, and somebody's already shown these. We went for provisional. The reason for that is because of, as we know, culprit shock. We know that patients who are in shock and who have multi-vessel PCI don't do any better, and in fact may actually be detrimental going forward. And then of course the EBC main 3-year outcome data to show that in fact patients who have provisional have less incidence of TLR. So we went for a provisional strategy, and of course then you need to think about vascular access. I already had a right radial lit 6 French sheath in, but the other option was to upgrade that sheath to a 7 French sheath, or to go femoral 6, 7 or 8 French. Of course, at the time, I think the oculostenotic reflex thinks, I'm just going to open this vessel, and actually, let's just get on and do it. I've already got access. So, rightly or wrongly, I carried on with my 6 French right radial approach. And what about LV support? The options, I guess, are no LV support, carry on. Intra-aortic balloon pump, and we know the data is not strong for that. Impeller, we didn't have access to impeller at the time for acute cases, and then the other option is VA ECMO. And of course, for the same reasons that I didn't change my vascular access, I decided to go for no LV support and just get on and see if I can quickly get in and out and open that vessel and get better blood flow. But of course, we should be thinking about LV support, particularly in left main cases, because of the high myocardial jeopardy, because of the LV systolic function when you was down, and of course the ischemia time of putting balloons up in an acute case. And so this was the PCI. So initially I was unable to wire the circumflex, so I put a wire down the LAD and used a small semi-compliant balloon to just get some better flow into the LAD and circumflex, which you can see the flow has improved. And I was then able to wire the circumflex vessel. And there was some imaging. It's not the best trace assists there, but you can see in the LAD, the LAD was about a 3 to 3.5 vessel, and the left main was about a 5.0. Unfortunately, at that point, after I'd taken my lovely intravascular images, he started coughing, had agitation, went into pulmonary edema, and a cardiac arrest call was put out. He went into PEA arrest during the intubation and had 2 cycles of CPR. Fortunately, he got ROSC for me to continue, but his blood pressure was very low and required adrenaline boluses, and of course his pH and lactate were markedly abnormal. In that time, though, it gave me a bit of time to fully dilate the left main, gets a bit of better blood flow, and then put a stent in. But unfortunately, at that point, as you can see, there's no flow in the LAD, there's no flow in the circumflex. He had an arrest at that point and had a cycle of CPR. Got Ross back again in time, giving me enough time to put a stent in the LAD, but still he doesn't have flow in the circumflex. Recrossed without potting, unfortunately, because of time and just wanted to get some flow down into the circumflex vessel, and managed to use a balloon to open up the stent struts. He did get better flow, which is great, but he had some perfusion VT and then went into PEA and ongoing CPR. So he had about 10 to 12 cycles of CPR, and this was a mechanical device, and of course I couldn't see anything. At that point, we put out a shock call, and that is what we know in the guidelines. We should be able to call in experts at that time to decide what is the best way to go forward. So our shock call at Bart's Heart Centre is in interventional cardiologists, intensivists. We have heart failure and transplant specialists on the call as well, and an ECMO consultant. And the decision at that time was to the patient was in refractory arrest despite the external compression device, and to proceed to VA ECMO or extracorporeal CPR. And actually this was done very swiftly. We had an ECMO consultant on site who came down and they put in an arterial access with 17 French, a venous access 25 French, and antegrade cannula into the right femoral artery to ensure blood flow into the leg. And an intra-aortic balloon pump, one-to-one augmentation, to ensure that we were able to unload the LV and to improve coronary flow. And in fact, it was so swift, it was completed in 20 minutes. And often we say we don't like to do this because sometimes it can hold up the heart attack centre service and the primary PCI service. But in fact, it was done so swiftly, which was excellent. And it allowed me the opportunity to then have another look at the coronaries and see if we can optimise the left main. And these were the pictures just after we'd got the patient back onto extracorporeal support, and managed to complete the procedure with a kissing balloon inflation 4.0 and a 3.0, in fact a 3.0 drug-coated balloon in the circumflex, which initially I inflated sequentially and then did the kissing balloon inflation. This is the pot, 5.0 pot, and then this is the final result. And there is a bit of imaging here as well to hopefully make sure everyone is happy with the final result. So this is the LAD with which is well opposed and well expanded stent, and the same in the left main. So it was a good result for this patient. So essentially this is a case of a STEMI with left main thrombus, pulmonary edema, cardiogenic shock and refractory arrest. And I hope I've shown you that a rapid initiation of periprocedural eCPR can allow for you to complete a successful left main PCI. In this case, it's provisional. We did use an intra-aortic balloon pump to improve blood flow, coronary flow as well, and to unload the ventricle. He did reasonably well post-procedure. Of course, there are often issues with patients on ECMO. He had a post-procedural hemothorax. He went on to hemofiltration, but he was decannulated off VA ECMO at day 10, and he had a 1-month stay in ITU. And in fact, on discharge, which was quite we were very happy with the result, though he was even discharged. He got to discharge. He had a repeat TTE. His ejection fraction was 35%. He's had a primary prevention ICD put in. He's had a successful outcome, and the plan was for symptom-guided management of the right coronary artery, which he has never had symptoms again. And in fact, he came to the heart failure clinic about 3 weeks ago. He's chest pain-free for the last 2 years. This case was done 2 years ago, and And his ejection fraction is about 20-25% at the moment. He's doing reasonably well. So that's my case.
A couple of questions in the audience. Lovely case, Fizza. Thank you. We'll just wait for the microphones. I mean, you pay. It's always very sterile, these presentations, but that is a hideously stressful procedure for everyone involved, presumably.
Yes.
So what was your anticoagulation strategy, and why do you think you had no reflow after your first balloon inflation? Do you think you embolized downstream and shut the vessel off? So very important if you had potent anticoagulation, that first thing. And secondly, 3 ECMO trials have shown really no benefit in AMI shock, and really Impella is the way to go. And certainly there was a dysfunction of the left ventricle. I don't know what the EDP was, but that would have given a good direction as to, before inflating the balloon even, to do something in mechanical support before you went in. Because if the EDP was high and you have a thrombotic left main, you're going to get in trouble just inflating the balloon. So anticoagulation strategy, and think of a different device, because 3 ECMO trials have shown no benefit. The only benefit is danger shock.
Great questions. The answer to the first question is that we gave ticagrelor up front. That's our usual anticoagulation. Well, it was our usual anticoagulation. Now we generally tend to give prasugrel, but at that time we were giving loading of ticagrelor. He was awake, so he could take it, and he had aspirin. When we got him on the table, I did give him integralin, which is our 2B3A of choice in our centre. So we had all of those things on board, and I completely take your point about upfront support in terms of the case, and I think that would have been beneficial. And I think at the time I was very keen to just get something in and open up the arteries, but I think that may have been helpful. Unfortunately, you're limited as to what you can offer in your centre, so a balloon pump, I don't think, could have provided some support, but the evidence for intra-aortic balloon pump is not great either. So I think Impella would have been ideal. If we could have used that, we couldn't, because we didn't have access to it. There is some data for it. I mean, this is not even VA ECMO. This is extracorporeal CPR. This is somebody who's in refractory arrest. So there is even less data for that. There is some data within hospital, though. So if patients go on to extracorporeal ECPR in hospital arrest, not in out of hospital arrest, there is some benefit in terms of neurological outcomes. So there is some data. I agree with you that it's not amazing.
I'll just come to your rescue here,
Sorry.
Being a danger investigator, that all of the Holger-Thiele trials included patients with cardiac arrest, which leaves quite a lot of space for a type 2 area that is seeing not seeing a biological difference that is there because of mixing of patients with very, very high mortality. So that's one point. The other point I just want to make is that in those cases that you've shown here, we always take the patients back a number of days after to do another angio, because it's very, very difficult to appreciate the stent size in the acute settings. And as a matter of fact, I'm impressed that you got so big stents in the arteries, because you put in a 3-0 stent in the left main, and it looks like enormous when you do that.
Yeah.
So we always take patients back.
So the issue is your patient develops some compromise after the imaging. So why do you think so?
I think there was a lot of thrombus probably. That I
Yeah, so
hadn't
we've
appreciated.
encountered often, and we found that the heparin given is less. So when you do imaging, we possibly need a little more heparin.
Okay.
So, number 2, as he mentioned, your stent in the left main looks pretty large, though it's just a 3 mm stent. Possibly your vessels are very badly diseased. So did you stent at high pressures? Because the entire system looks like into spasm. Did you stent at high pressures?
Well, I think he's in shock, and often you do see that those patients have very
No. When you stented the left
vasoconstricted.
main to LAD,
Yes.
did you stent at high pressures? What was your pressure? Because your entire system looks into like as if it's a spasm.
Well, I
He's
sent it to the nominal.
because the patient is in cardiogenic shock. That's normal that there is spasm. There's no flow.
I think the stent was well sized because I actually did do an IVUS.
No, the
Whether I should have done an IVUS at that point, I'm not sure because he clearly didn't tolerate it. But I think it was well sized and it went up. I went up to normal
when you
pressure.
have a patient cardiogenic shock. I mean, you can do diagnosis from the angio that is not A and B. From it was C from the beginning, most probably, no? Because when you have 100 of heart rate, it's a shock patient, and clearly you don't have access. Mostly, if I have this patient, before even doing the angiography, I put an impella on. It's a really young patient, large ST elevation MI, I put impella, and then I study the patient, because then you don't have the issue, you are radial, you don't have the femoral, but they don't have it, so, I mean, and by the way, regarding SLS shock, actually, this is a subgroup of patients. This is a patient in refractory cardiac arrest. I mean, it's a young patient. You have to invest in this patient. Otherwise, and by the way, the patient was discharged. Yeah. So you saved a life, apart from randomized clinical trial. I think that it's a very great case, and any cardiogenic shock case, I would say. But for sake of time, we have to move on. I think so. Thanks to have shared this case. Okay, so, maybe this is a recorded case they sent me. It's by Judith Andreka, and the case is of a decade crash in cardiogenic shock.
So welcome everybody, my name is Judith. I'm an interventional cardiologist fellow from Graz, Austria, and it's a really pleasure to be invited at EBC, and I'm really sorry that I cannot right now attend it personally, but I stuck at Istanbul airport, so that's why I decided to record our case presentation and share it with you, which is about decay crash in cardiogenic shock. So our patient is an 81-year-old male who has hypertension, hyperlipidemia, and chronic kidney disease. He underwent PCI once in 2011. That time the right coronary artery was stented, and then later on in 2020 when the proximal LAD was stented. The current presentation was due to severe chest pain, for which he was admitted to the local emergency care department, where our colleague realized that he has an anterior STEMI. But upon evaluation, he went to cardiac arrest, so that's why our colleagues started to resuscitate him. And they managed to brought him back within 10 minutes, but he was on high dosages of catecholamines and on respirator, but stable enough for the transport to our cath lab, where upon arrival, he crashed again. So we started to resuscitate him for the second time. His echo showed severely reduced left ventricular ejection fraction with some apical and septal akinesia without any wall abnormalities or mechanical complications. The blood gas was quite acceptable. And here I wanted to show you our flow chart regarding patients with cardiogenic shock or even CPR. How do we decide, usually in our everyday practice, whether to put mechanical circulatory support or not in the patient? As you can see, this patient had an observed cardiac arrest, and everything except his age was fit into the system. So since he was biologically rather in a good position, we decided to move forward with the ECMO implantation. And afterwards, his circulatory problem got a bit more stable, so we could proceed with the diagnostic angiogram, which showed this LAD thrombotic occlusion. And the thrombus was partially protruding towards the left main as well. So according to that, because the right coronary artery was not shown any disease, we proceeded with the PCI of the left system. We put a safety wire towards the circuit. It was a workhorse wire. And then we tried to wire our LAD. But that one seemed to be rather hard, and later on we realized why was it that? Because with the help of the stent enhancement techniques, we realized that not only the thrombus itself was protruding towards the left main, but these undersized, underexpanded stent as well, which was put in the LAD, in the proximal LAD, with that mindset, let's nail the ostium. But once again, here is the good example. Why is it not a good idea? So this one caused us a real problem, and after several attempts with different wires, and I can tell you it was at least 20 minutes when we managed to get this pilot 50 wire through more or less in a good position. And what did cause us to believe that it's more or less in a good position, that as you can see here, a small balloon could follow the wire path. Afterwards, we really wanted to see with intravascular imaging as well whether our wire position is good or not, and what can be the cause of this very late stent thrombosis. But unfortunately, the IVUS probe could not follow the wire route, so we decided to upscale our balloon. It's arguable whether it was a good decision or not, but afterwards, we saw that with this 2O balloon, we could really restore the flow in the LAD, which was a good point. But at the same time, the patient started to deteriorate, and we saw what was the cause. We managed to dislocate the thrombus in the left main towards the circ, which caused there a TIMI2 flow. So we really needed to act fast. We needed to increase the catecholamine levels, and then we needed to think what strategy would be acceptable in this situation where the wiring of the main vessel, the LAD, was so hard, and then there is a rather large side branch at jeopardy. So that we had several options. First, to do the TAP technique, which would mean that first we need to optimize the previously implanted LAD stent with a kissing, which would cause more embolization towards the circ. But afterwards, putting the second stent, a good carina coverage and good center position would be achieved. What if our wire is not in a good position? What if the wire is under partially the struts? Then in that case, the coverage of the carina would not be complete because we would have crushed the already implanted LAD stent with our first kissing. So apart from these reasons, there is also the fact that for the final kissing, we need to rewire the LAD, no matter how the stent struts are standing there, but I think it would be a hard job as well. So that's why the TAP is not the ideal option here, at least in our opinion. The second option was to do a clot, but to that we would need to rewire the circ towards the first struts of this protruding implanted LAD stent, which also, I must tell, rather a hard job and can cause also a lot of embolism towards the circ. And afterwards, even we do this, we could not entirely be sure that the first wire is in a good position. But if it is, then we could manage to have a good coverage of the carina and saving the circ with the second stent as well. But also, if the first wire into the LAD is not in a good position and partially under the struts, we are facing with the same problem as by the top, that the carina would not be covered entirely. And also, there is the fact that for the final kissing, the LAD should be rewired again. So the third option was the DK crash. DK crash, okay, when everybody heard DK crash, okay, it's so much steps, it's so complicated, but in this case, actually, it seemed to be rather appealing. Why? Because we do not need to rewire the main branch at all. It doesn't matter whether we are in a good position with the first wire or not towards the LAD, because even if we are crushing the LAD stent, the third stent, after the circ stenting would cover the whole carina. So with one step, we could save the circ, and at the end, we could also optimize the LAD as well by having a full coverage of the neocarina and without losing the wire position in the LAD. So that's why our answer to this question was the DK crush. So we implanted a 3.5 stent towards the circ. We did a sequential kissing, and after the circ rewiring and the first kissing, we did an NGO which showed that the circ was saved, the wire position maintained in the LAD, so we could proceed with the LAD stenting, which was also a 3.5 stent. And afterwards, with a fourth rewiring and final kissing, this was our final result. So in conclusion, we can say that mechanical circulator support in cardiogenic shock patients is still a controversial topic, but I do believe that in selected cases, it could be beneficial. And the use of DK crush in these situations where the main branch wiring was rather hard, and at the meantime, also a large side branch is at jeopardy, could be a viable option to save this situation. Thank you for your attention. And again, I'm really sorry that I cannot be there, and probably I won't be available neither online because I will be on the flight towards Frankfurt, but I'm really glad that you listened to my presentation, and I hope that still you can have a great discussion. Thank you.
So I think there is no discussion because we cannot pose questions. If we can have the QR code again, because we will announce the winner at the end of the session. So please vote in the meantime for the prior speakers.
If it's possible, we have 2 minutes about small discussion about the case. It's interesting because we can often find a thrombus in this bifurcation, CXLAD. What about the thromboaspiration in this case only? I mean, not only start with the thromboaspiration, and after it you can see.
Yeah, I mean, as I understand it, the protrusion of the stent back into the left main meant that instrumentation was very difficult. So, I mean, the key point there, which I fully support Judith with, was a small balloon passed, and often many people would interpret that as the wire being in the right position. Whereas actually, importantly, they recognised that there still was an opportunity that the wire would be abluminal. Yeah, so you can't tell, and you can't tell regardless of stent boost or what have you. You know, imaging is going to be the only way that you're going to gain clarity in terms of the wire position.
But with the thromboaspiration catheter, you have 3 millimeters that's a rapid that goes on the wire, and after it there's the aspirating part. So you can go further with the aspirating part, and probably you can catch the thrombus in this case. Yeah. And you can, after it, you can stabilize the situation.
It depends on the catheter, because the problem is that they had 2 wires. Not all the thrombus aspirators can leave the wire there, so it depends on the system you have available, most probably. No?
We just have another comment.
I just want to agree with you first, because I think the simple method would be not taking some device, but just pushing in the guide and sucking. If it's a soft thrombus, you get it. If it's tough, you cannot get it. It would have been worth a try, I agree.
Just one remark regarding this presentation, that I think it's, we all know now that there are 3 or 4 papers that you cannot nail the LAD ostium. And now this is where the patient got in trouble, because the initial PCI was not well constructed, and there was probably no imaging, and that's why there was some more protrusion into the left main that caused the problem. And also there was probably an undersized stent. So I think there's two more problems to tackle for this particular patient, and I think the patient's case was solved quite well. because it was very difficult to wire the LAD. Maybe there were some struts that were maybe it was the wire, the initial pilot wire was probably crossing somewhere, which we don't know. So in that particular case, we all know that Judith showed that maybe the only option would be DK culotte or DK crash, so 2 more stents. So I think for this particular patient, having some circulatory support, going with DK crash, probably was probably the best option. After the initial PCI problems that caused the main problems for this particular patient. That's what I think anyway.
Thank you. Great. Well, certainly some stimulating debate. So I think we have one. I'm conscious of the fact, having just logged on to the QR code, that you can only vote for the best. So without causing an unfair disadvantage to Risha Sharma, I think it's important that that case is presented so that we can then vote for the best of all 5 cases. So triple vessel calcific left main 3-vessel disease in a septuagenarian, tackling the chip. Is this another recorded case or? Okay.
Good morning all. Dear Chairman, thank you for the invitation to present at EBC 2024 meeting, and hereby I am presenting a case of triple vessel calcific left main TVD in a septuagenarian, tackling the chip, how I went ahead. So this was a diabetic 73-year-old gentleman who presented to the OPD with complaints of NYHA class 3 angina since past few months, and had a recent episode of unstable angina for which he was also admitted somewhere outside. Patient was a known case of CAD, had a history of old ACS 9 years back, and at that time his angiogram was done and he was advised CABG, but he refused for the same. 9 years back he was implanted a dual chamber AICD as well. His echo was suggestive of ischemic cardiomyopathy with an EF of 36% and mild MR. The LA and LV both were dilated. Patient was having a history of orthopnea and PND both. Again, we took the patient for an angiogram because he had an episode of unstable angina. And here we could see that patient had left main disease, a critical left main disease. LAD from ostial proximal to distal was critically diseased. Even the diagonal was having mild disease, but it was a huge diagonal down there. The major diagonal was a big one. Patient circumflex was critical disease. It was a non-dominant vessel with almost 95% ostial proximal disease. OM was normal, and circumflex was having some slow flow because of the criticality of the ostial proximal disease. RCA, we can see that it was mid-RCA was 100% CTO, and grade 2 collaterals were there from LAD to RCA. Patient's index score was more than 33, and he was again advised for CABG, but he categorically refused for the same. So now, in view of his symptoms of orthopnea, PND, failure, unstable angina again and again, we had to do something for this, and we thought that we will deal with the left main bifurcation in this case. Our plan was to go for rotablation of the LAD and LCX and do a dedicated bifurcation technique in this as per definition criteria. It was a huge circumflex. We cannot leave it just like that. So right femoral axis was taken and a 7 French EBO guide was taken. Both LAD was wired with cyan glue. We tried to cross the IVUS catheter, but it couldn't cross beyond the mid-LAD portion where it was the tightest lesion. So took a microcatheter and parked it in mid-LAD, and cyan was exchanged with the rotawire. Since our IVUS catheter was not also crossing, we took a 1.25 millimeter burr at 180 RPMs and started rotablating the vessel with the same. We did differential cutting as well by rotating the EBO guide. Thereafter, again, rewired the LAD with cyan, and check shot was taken, and there was no dissections or slow flow noted, no perforation was there. We wired circumflex with feeder and exchanged with rotawire over a microcatheter. Again, the same burr of 1.25 millimeter was taken, and in the second shot, we can see that our burr got actually stuck probably because of the tortuosity and very critical lesion and calcific lesion. So at this point, we gently pulled out the assembly, and the burr also got stuck, burr also came out. So by proper hooking of the EBO guide, we again took the same burr and started our rotablation with 1.25 mm. L6 was at 180,000 RPMs. There were no dissections or perforations noted in the circumflex, and flow actually got improved after doing the rotablation of both LED and L6, and we can see in this view. Also in the distal circumflex, flow greatly improved. We took an IVUS run before that, and here we can see that the distal LED, we could see a concentric 360-degree calcium without any fractures. Coming proximally, there were calcium fractures seen in various planes, multiple fractures. In mid part of the LED, we can see that again the calcium was pretty not breakable, no fracture seen here. And osteoproximal part, it was more than 270 degree almost. Coming to left main, there were we can see that the area is good in the left main. In the mid part shaft of the left main, it was critical diseased. So now, in view of this, we thought that we will do, again, we will upgrade our burr to 1.5 mm and again do a rotablation and rewired the LED with rotawire again and ablated it with a 1.5 mm rotaburr. And we can see that in the osteoproximal part, our burr was getting slow also. There was change of sound as well at this point. But ultimately, with the few motions, we could get past across this lesion. And also we did this 1.5 burr at the mid part of the LED at the tightest point. So this was adequately burred. After this, this was the IVUS run, and we could see that the distal part of the LED, it also got fractured. The calcium fracture was seen here. Reverberations were seen here. And then coming proximally, we can see there were multiple fractures in the whole of the LED. In the ostial part also, fracture was seen now. But still, this portion was not very good. So I thought now I'll have to do a balloon dilatation, balloon bed preparation with a balloon in this portion. This was the left main, which was again showing few fractures and reverberations both. So after this, the rewiring with cyan blue was done in LED and feeder FC in LCX, and bed preparation was done with a 2.5 mm balloon in mid LED, 3.5 mm proximal ostial proximal LED, and circumflex was pre-dilated with a 2.75 NC. All were NC balloons. High pressure dilatation was done in all the vessels. After this, it was a dedicated bifurcation stenting with a TK crush. That is my default strategy that I do in left main bifurcation. So keeping a 3.5 mm NC balloon in LED, took a 2.75 into 24 mm disc into circumflex, keeping minimal struts into left main. LC stent was crushed with the same 3.5 mm balloon at 14 atmospheres. After this, the circumflex was rewired, probably through the distal stent struts. Didn't check it on IVUS, and we did our first kissing balloon inflation with a 3.5 NC in LED and 2.5 NC in circumflex at 12 to 14 atmosphere. So this was followed by stenting of the LED, a 2.5 into 28 mm disc in mid to distal LED, and 3.5 into 30 mm disc from LMCA to LED was deployed. Diagonal was, we had our diagonal flowing, the huge diagonal, it was flowing pretty well, so we didn't touch that diagonal, and we didn't plan for it also because probably we thought that the ostia was good. There is some pinching, but we didn't do anything for that. We just did a pot later on. So after this, LED stent was post-dilated, and a pot was also done with the same 2.75 NC balloon display, and coming proximally with the 3.5 balloon, mm balloon with 18 to 22 atmosphere. This was the result that we can see. Circumflex was rewired. First, we did a pot with 4 into 10 mm balloon, and then circumflex was rewired through the LMCA stent struts. So first, we did we opened the struts with a 2 mm balloon, and this was followed by a second kissing balloon inflation with a 2.75 NC into circumflex and 3.5 NC into LED. This was followed by, we can see that the LED ostial proximal was still underdilated, and it was the most difficult part that we saw in the IVUS as well. Here we used, I had to post-dilate this portion, otherwise the patient would come with the stent thrombosis or ISR again, and the whole procedure would be of no use. So took an OPN NC here and dilated of 3.5 mm size and dilated at 36 atmosphere. This was followed by a final pot with a 4 into 10 mm NC at 20 atmospheres. This was the final result, in which we can see that all the diagonals were flowing pretty good, and LED, ostial part of the LED, circumflex, left main, they were all dilated. And we did an IVUS run from left main to LED, and we could see that our stents were pretty opposed and expanded all throughout. Patient came to follow up also after that. This case I did almost 3.5 years back. Patient is in follow up and doing well. RCA I didn't touch since patient was asymptomatic. So to conclude, I would just say that a chip case is defined by presence of a few features, which includes the presence of calcium, severe tortuosity, bifurcation lesion, high thrombus content, and lastly, diffuse atherosclerotic burden with variable caliber and absence of plaque-free landing zone to facilitate the stent deployment. And in our case, we all had at least 3 of these features: presence of calcium, bifurcation lesion, both in left main and LAD, there were bifurcation lesions, and it was a diffusely atherosclerotic vessel in our case. So we have to actually, success depends upon the meticulous preparation of these lesions, and then only we can have a reduced incidence of stent thrombosis or ISRs. So just a take-home message is that calcium assessment, doing a proper bed preparation is extremely important for proper passage of balloon and stents, apposition and expansion of stent, and preventing stent failure rates. The art of rotablating the coronaries is a must for all the interventionists to win over these rock boulders. Imaging certainly helps to achieve optimal stent expansion, apposition, and measuring the size of the vessel, seeing the plaque-free zone. Imaging actually helps you sail the path in these such cases. And tools for tackling the calcium, like OPNNC, ROTA, IVL, they should be present in the cath labs, and we should have a know-how of how these and where to choose these particular armamentarium. A point to highlight here is the use of MCS device in these high-risk patients, because anything happening in LAD would have resulted in disaster in my case. Fortunately, there was a dual chamber AICD inside. So even if slow flow would have happened into LAD, which is supplying collaterals to our CA, that bradycardia would have been taken care of, the dual chamber AICD, which was already present. Complex bifurcation, according to definition criteria, that requires an upfront 2-stent strategy. Here we had a difficult, a huge side branch, more than 10 millimeter lesion. So I took a DK crush default strategy in this case. And chip cases, they need perseverance, prompt action, and constant assessment of various strategies together. There is something on calcium. We all know this, that where to use which, according to this algorithm, where to use which device for ablating this calcium. Or thank you.
Great. Do we have Dr. Sharma online?
Yes.
Yes.
Hi.
Can you hear us?
Yeah, I can.
Oh, perfect. And we can hear you too. Thank you. I mean, congratulations on a great case. Certainly perseverance. You say that the menace of calcium and perseverance were the 2 key messages I got there. But your use of imaging to define the modification, I thought, was impressive. Obviously, once you deployed the stent, you then had an ongoing issue with stent under expansion. Did you? I missed. Did you use intravascular lithotripsy? Was shockwave a device used at the time of the procedure?
Sir, IVL was not used here because of the cost constraint. Already we had used balloon and IVUS and the 2 rotablation catheters, 1.25 and 1.5. So in this part, we have that limitation of, that's why IVL I couldn't use.
Because I would wonder, so certainly from our experience, the rotor shock combination of rotablation and shockwave is very effective in that concentric calcification. So you did a fantastic job in the absence of that. I congratulate you. Any other questions or comments? No? So thank you.
Thank you very much.
Really great presentation. We're running slightly over time, so we will use this opportunity, maybe just have the QR code up on one further occasion for voting, and then we can give the result. If you just stay online with us, it'd be great. I mean, we've had 5 fantastic cases, and with an array of complexity. I mean, all have had complexity either procedurally or in relationship to the patient presentation with comorbidity and high bleeding risk. I think what's been demonstrated is taking a stepwise approach and a safe approach to the treatment of these highly challenging bifurcation cases. Are you going to show up the final result? Great. So, Fizza, congratulations. I'm afraid that it's a warm feeling inside rather than a physical prize, but I hope you enjoy it. Congratulations. Very nice case.
Okay, so I think the microphone is working. So welcome everybody to this symposium organized by Terumo. It's my pleasure and honor to co-chair this session with Professor Mamas, that everybody knows, and also Professor Stankovic, founder of the EBC. Today, we are going to talk about the Ultimaster Nagomi multi-center registry. It is we are all here in the steering committee of this multi-center registry, which intend to include 3,000 patients with highly complex PCI, and including also bifurcation stenting and complex lesions. There will be a 2 years follow-up, and today Professor Stankovic will tell us about some preliminary data about bifurcation lesion from this large multi-center registry. So go on, please.
Yeah, thank you. Thank you, Adele. Good afternoon, everyone. It's a long day, but I think presenting data from complex patient and lesion subset is always exciting. We are always looking forward and continuously trying to check the change in practice. And you will see we are doing better. This is the talk about bifurcation subset from the Nagomi complex. And as Adele said, Nagomi complex post-market clinical follow-up study will enroll 3,000 patients who will be followed for 2 years at least. These are complex characteristics, long lesions, left main, every left main, severe calcification, multi-vessel disease, 2 or more vessels, 3 or more lesions, complex bifurcations, chronic total occlusion since entry stenosis. In addition to primary endpoint, that will be 1 year rate of target lesion failure, which is cardiac death, target lesion related myocardial infarction, or clinically driven target lesion revascularization. We will also have patient-reported outcomes, quality of life and angina status, and there are 2 predefined dedicated subsets that we especially expect new data that may help us change the practice. High bleeding risk patients and bifurcation lesions with independent core lab. Currently, there is more than 1,500 patients included in the registry, and at the time when we did this analysis, it was mid-2024. Total population that was extracted at that moment in June was 1,078 patients. We split the total population in no bifurcation lesion or bifurcation lesion at the index procedure. So 188 patients had bifurcation lesion treated at the index procedure, and there is small difference, 142 patients for whom either bifurcation lesions that were treated did not meet criteria for complexity, or QCA data is still not finalized. So please take all this as a very preliminary, but I think very important and very interesting data set. We had 43% of patients older than 75 and 53% of patients meeting high bleeding risk criteria. When we speak about clinical indication, 3/4 had chronic coronary syndrome and 1/4 acute coronary syndrome. And if you see the division, it was mainly 73% non-STEMI, 20% angina, unstable angina, and only 6% STEMI patients. These are the data on lesion and procedural characteristics. Radial access, 90%, that is really current practice. Number of lesions, 1.8. Number of stents per subject, 1.9. Per lesion imaging, whether it's IVUS or OFDI, 44.4%, so we can do better. Especially this is left main and this is complex bifurcations, but this was, I think, slightly better, 10% more than EBC main and DK Crash 5. So we are improving, but slowly. Post-dilatation, which means optimization of stent expansion, 94%, And we are happy to have 37% left main bifurcation treated. And in that subset of left main, mean syntax score was 26.5. If we look the distribution of lesion location, LAD was the most common bifurcation, 47.5. As I said, left main 37%, circumflex 12%, and right coronary only 4%. And very importantly, complex lesions type B2 or C were present in 80% of those lesions. We are happy that 345 Nagomi stents that were implanted in bifurcations during this index procedure were successfully implanted in 99% of cases. And as I said, in 198 bifurcations, 44.4% imaging is better than before, but we can still do better. Importantly, 2/3 of the lesions were complex through bifurcations. 111, 46.5%, 13% 011, and 1015%. Among non-true bifurcations, 110 was the most prevalent with 22%. And I think this is the key, how we changed the practice from previous platforms in the Ultimaster registry now to Nobori complex. First, you remember we published from the Ultimaster registry 33% rate of POT, and that translated in clinical benefit in population who actually had proximal optimization. Now we double that rate. It's 70% of patients with POT, which is, I think, significantly better. So our club meetings, consensus documents, and discussions at every meeting resulted in really improvement in the current practice. Final kissing balloon, this is polluted, single stent and 2 stents, 57% final kissing balloon inflation. Single stent, 55%, 2 stents, 45%. Imaging, as I said, per patient, 46 versus 54, no imaging. But if we split this in a single stent versus 2 stents, we see really that POT is stable, 70% in both, re-POT 30%, and kissing balloon in provisional expected 26%. I don't expect higher rate because there is also many non-left main bifurcations. If we speak about 2 stents, then POT again 72%, and kissing 91%. This was confusing in report of EBC main, so in 2 stent strategy we really routinely perform kissing. It's better to be higher, but 91% is again better than it was before. If we go to the technique that is used, you can see down that culotte again and T-stenting are the most frequently utilized, which also reflects Rolex registry as well as EBC main crash in 16% of cases. And clinical outcome, we have so far only 1 month follow-up data. In green, it's bifurcation. The rest is in orange. So numerically, definitely higher event rate for bifurcations, including patient or clinical endpoint, 4.3, 2.8%, target lesion failure 3.2, double compared to non-bifurcations. But in general, there is no significance, mainly because these are small numbers and this is still preliminary analysis. And if we split again in single stent versus 2 stents, we see the same. In red, it's single stent, really almost half of the events compared to 2 stent strategy in every category. So definitely single stent replicates data from Rolex and EBC main, and really shows significantly lower rate of clinical events. So this is also far from the preliminary presentation, and I'll be happy to answer any question that you may have.
Thank you very much. Thank you very much, Goran, for this very nice overview of this preliminary data. So almost more than 30% of bifurcation without a POT, so still EBC has a lot of task to do in the future, because it's still amazing that cannot imagine a left main or a complex bifurcation without pot, so it's amazing. Not even a single pot, registered in this. So let's see what will. So this reflect real world practice, and as you said, in Ultimaster it was only 30%.
Only 30%, and that translated in clinical benefit if you do pot. So I think now we have convincing evidence that doing pot is really helpful for major clinical outcome data. And this, to be honest, I was very happy when I saw 70% because I remember 33% and now we are at 70. Next one, I don't know when you are planning the next platform, I expect 91, so I think then we'll be happy.
Thank you very much. Maybe without delay, maybe we can move directly to the case presentation from Professor Mamas, who is going to show a nice case that we can discuss all together, and if I'm not wrong, was included in the registry, Professor Mamas, yeah, sure.
I think it was before we were allowed to include STEMI cases into the registry. So if we can, great. So over the next 10 minutes or so, we'll have the case presentation. So this is quite a complex case in terms of decision making. And it was really a man in his late 60s, and this is a guy who came in with VF requiring 3 shocks in the ED department. He had transient ST elevation. We got him into the cath lab, then had further VF arrests, and again, several shocks. Now, he was complex in terms of his comorbidities in that he was known to have Behçet's disease, but also had rheumatoid arthritis with significant vasculitic involvement. So he had peripheral vascular disease and also biopsy documented vasculitis, and also required anticoagulation on the basis of his atrial fibrillation. So this is a guy who clinically is complex, but is also high bleeding risk because we know atrial fibrillation and rheumatoid arthritis are high bleeding risk states. And if we can play... No, wait a minute, just go back. Can we play the video, please? Play the video. Play the video. Okay, if you play the video before. So I wired both vessels. You can see that he had an ostial lesion in his LAD. This, I think, is after I pre-dilated the lesion. I think the first lesion you'll see was a pin-tight lesion. Just go back to the very first, go back, okay, there, play the video. Okay, so I used the balloon, pre-dilated, play the video. This is after pre-dilation, great. So this is what we've got. And then I IVUS, so if you play the IVUS, click the play button. There you go. So you can see the IVUS here. So you can see this is in the LAD going backwards, some calcification. This is after pre-dilation. It's a large vessel. You can now see the ostium of the LAD. And you can see now going into left main. And you can see from the IVUS catheter that there's really quite significant disease in the left main. So even though on the angiogram it looks like the disease is mainly limited in the ostium of the LAD, you can see from the IVUS exam that you've got quite significant plaque burden in the left main. Now, the other complex aspect of this is the diameter of the left main. So this is one measurement, it's 6.6 millimeters, but even further down it was around 6.2 millimeters. So this is a big left main. Oops. And so I guess my first question is, what's the strategy here? We've stabilized the situation, we've pre-dilated, we've had an IVUS. The IVUS shows significant disease in the ostium, extending into left main. We've got a big left main, 6 millimeters. Adele, what do we think?
The very, very interesting learning from this case. So first of all, we have left main, which is probably can be labeled as not super complex. Because, for example, on the side branch there is some lesion on the circumflex which is not extending a lot towards the proximal circumflex. So my first question to the audience will be, who would go here for a provisional strategy here? Who in the audience will go for provisional in this case? Raise your hand. Okay. Who would go for two-stent technique? Who? Almost no one. Okay,
who would nail the ostium? Because you've got a massive left main here. So who would try to position the stent into the ostium of the LAD?
I think no one. Okay.
No one.
The second important question. So who will do this case without imaging? So raise your hand. Who will do actually imaging in this case? I think we have seen in the previous presentation, for example, for calcified lesion, what we can get, what you can extract from intravascular imaging, like, for example, the amount of calcium and so on. But I think for left main, one of the most important aspects of imaging is the sizing. The sizing. Angiographically, you cannot expect, for example, that you have 6 mm, 5 mm or less. So it's super important that when you do a left main, you do a perfect job, that you oppose the stent proximally in the right way and so on. And probably that's what you have done here. The second thing is the platform. Which one? So that you are going to develop, Manas?
Well, I guess that's obvious. It's a Terumo Symposium, so I'm not going to show a Boston platform. But I guess, this was... this was up front. So, in my lab, we have many platforms, but my decision making for using the Ultimaster platform for this case is, first and foremost, there was a significant size mismatch between the LAD and the left main. And really, when you're looking at platforms that can expand beyond 6 millimeters, there's only, effectively the Ultimaster and the Giant Sierra that go above 6 millimeters platform. So I opted to go for the Ultimaster. The reason I opted to go for the Ultimaster is a high bleeding risk patients. We've got data from MasterDapt for high bleeding risk patients and complex PCI. That data's been published. And also the 10 crown design. And I think that's really good for left mains in that you get much better apposition, much better coverage, much better drug delivery. We know that patients with left main are high bleeding risk. This is data from Mount Sinai. I understand Elaine Kieffer is also currently preparing and presenting some work around her registry. But over half of patients undergoing PCI for left main are high bleeding risk, as was my case. So play the videos, please. So I deployed the Nagomi 4x21 millimeter stent. And then next, let's have a look. Okay, and then I potted with a 6 by 8 millimeter balloon. What do you think happened? Well, you can see what happened. So you can see that I potted with the 6 millimeter balloon, inflated at high pressure. Just play that second video again, please, on the right-hand side. Yep. So you can see I've now compromised the circumflex ostium. So what do we do? I mean, we've now got a situation where we've done something that we think is going to be straightforward and we've compromised the ostium. So why do we think it's happened and what do we do about it?
So I think first of all, the angle is extremely a narrow angle that probably favors the carina shift towards the circumflex and worsen actually the lesion at the ostium of the circumflex. The second thing is the balloon that you have used. We have seen in the EBC consensus document the positioning of the balloon when you do the pot at the level of the carina is extremely important. I think your markers are at the right spot. Probably you're a little bit too distal, but also the shoulder of the balloon are looking a little bit too large. So probably that also favor the shift of the carina towards the circ in this case. So that I think that can happen. But I think the angle was also something that favored the carina shift here, I think, towards the circumflex.
I mean, I think the main problem here, if you look at the inflated balloon, look where the markers are and look where the balloon is. I mean, it's really interesting that, I mean, it looks as though it's an 8 millimeter balloon, but the balloon's extending at least another 8 millimeters further ahead. And so I think, in these very short, large balloons, you really have a big problem with that. And I think, the pot balloon that Brosmed are releasing overcomes this problem in that the expansion is very near the markers and you don't have this huge balloon extending way beyond the markers. And I think that's really one of the problems in this case that we had. So I then rewired and used a 4x15 Trek final kissing balloon in both the LAD and the circumflex. Kissed, and you can see that there, positioning the balloons, do the kiss, and looks okay-ish. and then I again do the pot, but this time be slightly more careful and bring it slightly further back from where the markers suggest that you should be going, given my experience already. And this is the final result. So you can see this is a huge left main, and the circumflex looks reasonable. It's not compromised. And this is the IVUS. Again, you shouldn't be doing these cases without IVUS imaging. You can see in the LAD going back, you can start seeing the stent. It's well opposed in the LAD. It's a 4mm platform, and you can see that it's now gone into the left main. It's well opposed, and I think it's a reasonable result, so good expansion in the left main. What antithrombotic regime are people going to use? Maybe, I mean, you've seen the case, I'm not going to ask you. Maybe I can ask people of the audience. I mean, you know, you've got a left main, a big left main. You've got someone who's anticoagulated. You've got someone with an ACS who's had an out-of-hospital arrest, who's got rheumatoid arthritis with Behçet's disease and biopsy-proven vasculitic process. What regime are you going to use? How long for? I mean, he's got AF as well. Are you going to use an anticoagulant? How long?
Hello. Yeah, so I think you've got to monitor. The bleeding is going to come from your non-steroidals. They're going to erode the stomach. They're going to start the bleeding, and then obviously your anticoagulants are going to then make the bleeding not stop. So if you can eliminate the Disprin, you'll give them Plavix, and whichever NOAC you want to give him for the
how long atrial fib. And so you've got a complex left. Well, I mean, you've got a left main. How long are you going to give the Plavix for?
At least 6 months, but I would try and stretch it even longer, 9 months.
How about everybody else? Anybody go shorter than 6 months? Anyone giving 12
Let's
months?
ask the others. Who will give to this patient 6 months of clopidogrel? 6 months, only 6 months. Okay, me also. Who will go for 1 year? Okay, so still not clear. But the high bleeding risk patient, I think the stent is well opposed, so probably no risk of at least restenosis, thrombosis, probably with the new platform. And also you will show data also that we have with this platform.
3 months also. I think about 3 months.
Yeah.
How about 1 month?
Oops.
1 month. 1 month of combination only, yeah, okay.
So I guess one of the things that we have data is we have data from the MASTERDAPT trial. So this was patients treated with the Ultimaster platform. Patients, there was an OAC arm and a non-OAC arm, and patients with high bleeding risk were randomized to abbreviated versus standard approach. You can see that in the complex versus non-complex PCI group, there was no interaction. So irrespective of complexity, short DAPT in these patients. The music's playing, so that means I'm overrunning. It's great Star Wars music. And what do the guidelines say? So the guidelines say, up to 6 months if it's high bleeding risk. I think in this case, I did use 6 months of dual antithrombotic, but I agree. I think in retrospect, I probably could have gone down to 3 months. I think that's reasonably safe. Particularly if you've used IVUS imaging, and particularly given this was a big stent that was well opposed. I mean, this is 6 millimeters in the left main, 4 millimeters in the LAD. And so I think when you're doing these sorts of cases, to me, you've got to think about the expansion properties of the stent. And I think in this sort of case, there's very few platforms that could go comfortably above 6 millimeters. I think the fact that it was a high bleeding risk case, again, I think there's very few platforms that have data in this subgroup, or only one platform for abbreviated DAPT in high bleeding risk for complex PCI. I think if you're going to do these cases, you shouldn't be doing them without intracoronary imaging. And I think, short DAPT with NOAC monotherapy after 6 months, I think is a reasonable approach, but I probably would agree that you can probably shorten it down to 3 months, and I don't think it would have made much difference here. So, hand back to you.
So, thank you very much, Dr. Mamas. It was a very nice demonstration of a complex combination of a complex setting, anatomical setting, and high bleeding risk patient. I think we still lack a trial with patients with high bleeding risk randomized, because the master adapt was a sub-study of the whole population. So we still need one randomized comparison of patients when we do a complex PCI who are high bleeding risk, when you can go for abbreviated therapy as compared to a standard therapy. We still need this trial to upgrade the guidelines for showing the safety of an abbreviated therapy. Also interesting to acknowledge that in Master DAP, the single antiplatelet therapy in the abbreviated group was mostly clopidogrel. So I don't know if people will go for only aspirin after a short trial of DAPT. So I think also those stents are becoming safer and safer. And see, as our colleagues said, we can go for 3 months, 1 month sometimes if we have to stop the treatment for any reason, for surgery. We feel more and more confident with those platforms, especially if you have done a good job, good apposition, good treatment at the index procedure. That's also very important to allow to shorten the DAPT or the antitraumatic regimen. So thank you very much to all, and Professor Mamas and Goran for this nice session.
So we have a panel. Brilliant. So I'm conscious of the fact we're kind of moving towards evening and music is playing fairly frequently. It's a great pleasure to be here chairing this session sponsored kindly by Boston Scientific. And actually, you'll be relieved, this is really fairly data-free. This is conceptual, philosophical, and we have a great panel in order to provide maybe some thought and discussion, we hope, amongst you all. If I just have my couple of slides up, I probably don't need them, to be honest, but the intention is that we're going to cover 3 different aspects of this challenge of being the educators for left main management, left main treatment, particularly with regards the role potentially of intracoronary imaging. And so we have a new guideline recommendation, Class 1A, but honestly, I'm not sure that's going to make any difference to our patients anytime soon, because we need colleagues to adapt and adopt the technology and, most importantly, understand it and move forwards with it. And so the challenge for the next 30 minutes is really to think about how we in this room have a responsibility to educate our colleagues, to educate our teams, and try and work through how best to do that. So the role of intravascular imaging in bifurcation, particularly left main, the concepts around how to teach bifurcation strategies, and then maybe to think about the responsibilities in terms of mentorship for young physicians. So in order to get things moving as quickly as possible, I invite Jakob up for the first of those 3 considerations.
Thank you. So the need for education in IVUS and best practices. So what about unrevealing the truth of PCI? So the outcome is at risk every day when we do left main PCI, since it supplies more than 75% of the heart. And we have already good evidence that intravascular imaging reduces MACE. But still, we have gaps in adoption to guidelines. The recent guidelines give us a 1A indication for using imaging in left main, true bifurcations, and long lesions. And to the right, you see the data from last year from Sweden, the Swedheart registry. At the bottom, you see the usage of imaging in left main. So it ranges from 20% to 100%. In the median is around 70%. So there is room for improvement. The upper panel there, you can see the overall usage in all PCI in Sweden among different centers, ranging from 2% to almost 30%. So there are centers out there that could adopt and do better. So you have to educate for a better outcome in every PCI. So to sort out this and to get straightforward, we have some good tools, algorithms, for example, the IVUS 1, 2, 3, to simplify the structure, how you do your PCI, your imaging, by measuring length, morphology, and diameter, and also evaluating the edges, the apposition, and the expansion. So doing a case like this is, of course, guided by imaging, in this case IVUS, heavily calcified, large vessel, difficult to size by angio, using the proper devices to be aware, to be confident, to have a good outcome. But you should also be aware of the wire, also, even so in a simple provisional. That's not that simple, actually. So looking for your exit of your wires before kissing, before parting is crucial. And this we learned from the October trial, where unintended problems can, okay. So it's important to know this before potting and kissing. See if we can go around this. So you go to the next slide, sorry for this. So uncorrected stents in the left main will produce severe MACE. So just go to the next slide, please.
Just while we wait for the slides to come back up, Jacob,
You can just take the last 2 slides so you can sum up.
Whilst we wait for those slides, just to expand on, so we're talking about best practice, and you've indicated the Swedheart data. Could you expand on that a little? So there's a quality metric now of 60% imaging for intravascular, for imaging of left main,
yeah,
but you're saying it varies from 20 to 100%.
That's correct. So for the last 5 years or something, it has been 60%. I think this should actually now be higher, but it's where it is right now.
Is there a penalty for not reaching that target?
Yeah, you count scores on this registry, and if you are not fulfilling all the criteria, you have a lower score, and this is public scores.
So I mean, it's a very good idea to start naming and shaming, but where do you think then the resistance still? Why is there still a resistance to meet that metric?
I think you have just to start using imaging. Get used to it on the everyday practice. I think this is actually my last slide to how can we adapt to the guidelines. The best practice is start using intravascular imaging, get familiar to it, and use simple algorithms like the 1, 2, 3, and it will become like putting a balloon back and forth in the vessel. It's very, very simple, but not taking it out when you have a complex patient, but in almost every patient, every day. So you should invest in training to adopt to the best practice and to improve your outcome. So this is my last slide. So this is a continuous learning. So you are moving from old school angiographic PCI to intravascular imaging, and we will also adopt CT imaging. So this is a continuous learning, learning from best practice from case studies, but also the most important, the hands-on in your own cath lab, supported by people that know these things.
We have some questions in the audience. If you take a microphone, Jakob.
I think it's very easy to say adopt it in 100% of your cases and do it in normal cases. But I think what we're forgetting is the cost. And, you know, maybe it's fully funded in your country, but I know in South Africa, where I come from, we have fight with funders to even do it in left main or difficult cases. So, you know, we really need to have a look at the cost, and unless the cost comes down, it is available to everyone, you then limit it, and you only use it in cases that really need it.
That is well taken, of course. So you should use it wisely if you cannot afford it, at least in left mains, where it's so critical to get it right.
So, any further questions? Yeah.
Yeah, no, just a comment. I mean, about cost. You know, I think, you know, we looked at our data, you know, in terms of cost effectiveness of IVUS, and you use larger stents, longer stents, and in our data we look less stents, and less guide extenders, less of those things in the complex PCI. So I think IVUS use across the board, you know, decreases your cost. I think that's one thing. Reimbursement is another issue. You know, I'll tell you, you know, when in the US they approved IVUS use in the peripheral arteries, none of the peripheral operators used to use IVUS, but every single one of them used IVUS because they got money. Some of them just put the IVUS and didn't know what they were looking at and just to get money. So I think reimbursement, I think our societies, especially the amount, you see 30, 40% benefit, right? We made all this adoption with radials and stuff. I know bleeding and stuff, but if you look at radial femoral, there's this much difference. How much difference between imaging and non-imaging is there? So I think we really need to, guideline is changing, yes. Reimbursements needs to change. And then education about, you know, all those things that you guys are talking about, the barriers that are there to use imaging. It's, you know, money is a big, big driver of a lot of these things. It really is. So I think we need to do a better job, you know, in terms of society and stuff like that.
Yeah, it's pretty upsetting to hear, I'm sure, for nations that don't have money, that where there is money, it can just be used as a mechanism to make more money. And I think that is one of the greatest concerns that we should have as a community, is that the educational gap or the ignorance and arrogance is potentially going to be the biggest detriment to patients gaining the greatest outcome or the greatest benefit from these tools.
So I think that I'll tell you the story. One of the things that was a positive thing out of COVID was that a lot of cath labs in the States, you know, were closed off. We did only emergencies. But in my hospital, I started a same-day PCI program, even for complex cases, and every case got IVUS, okay? What it did was a person would come early in the morning, get COVID tested, get his case done, leave the same day. I was comfortable and send him home. Out of 300 cases in 1 year, there was zero mortality or bad outcome. So, and the other thing was that if you have a same-day discharge in the US, your hospital actually makes $7,000 extra, okay? And if you keep them overnight, they don't make that money. And my hospital flourished. So there is an incentive that if you do a case properly, you don't have to keep them in the hospital. And almost all my PCI case elective are now all outpatients. I don't keep them in the hospital. They go home very safely, even complex left main disease. Secondly, there was a little bump in the United States for getting extra money if you did imaging. And third, you know, the European guidelines drive US guidelines. And the US guidelines almost biblical because if there's a complication, somebody has abrupt closure of left main and would not do IVUS, the class 1 indications, there will be legal consequences of that. So I think all that will drive it. Fourth thing, you really need to have dedicated, you have fellows who come and go, but dedicated techs are very important. So you don't have to unscrub, rescrub. Dedicated techs will know what you're doing. You know, step 1, 2, 3, 4. Do it same way over and over again. It's very important. And then about 7, 8 years ago, we wrote in our paper for left main bifurcation, we really advocated, particularly from the work with Dr. Hernandez, you must image left mains, you must image left mains, you must image left mains. Thank you.
Thanks for those comments. So I think probably that's a good point to move across to looking at bifurcation techniques, just trying to keep to time. But just before, Chima, you start, while we just get the slides up, Jakob, you mentioned something particularly that caught my attention, which was simple's not necessarily simple. So we say a simple provisional, or we talk about using a stepwise imaging. It's not simple, right? Neither the imaging nor the bifurcation.
Definitely not.
So how
the more you image, the more you realize it's not simple at all.
And so how do you overcome that barrier of education in Sahlgrenska?
Using it every day.
But for the fellows, so we're going to move on to how we educate and mentor
Yes,
our fellows.
and
But in terms of daily practice for colleagues who aren't using it to such a high extent,
in everyday practice, having a fellow and a senior operating together. So it's the way forward, I believe.
So Chima, if we could move from just simply imaging, but imaging in maybe the setting of bifurcation education would be great.
Yeah, as Tom said, we are moving from imaging to... We are talking about left main, and bifurcation strategies is key, for the treatment of these complex and challenging lesions. We are in the 20 years of EBC, and EBC has done a great job in disseminating the good practices. We have many documents in the last 20 years publishing our intervention from EBC, all the consensus, providing step-by-step very nice graphics and drawings like this, how to treat lead main. This is more recent. This is for provisional stenting, with the philosophy of identifying pitfalls, troubleshooting, and how to prevent and solve all these problems. We have these excellent graphics. You can see step by step. This is educational. Yes, it's educational, a lot of educational, but new generations need more than this. We have these 4 to stents techniques. And these are the, decay crash or decay crash, first stent, second stent. But sometimes we need something more visible. And bench models came here to provide not only the testing of platforms for the companies interesting, or for us to invent or to create or test different platforms for different approaches in the bifurcation, to try culotte, to try crash. But these models have been very useful in education. There are many. The companies go to the meetings, they put a table in the stand, in the booth, and you can try to do your techniques with different stents in models like this. And geography is not real, of course, but this simulates the real thing. And also combined with the imaging, we can see what is going on. I call this eyes on because I see what's happening, but also the hands on. You can do the techniques in these models, in these tube plastic models, and also to look with internal cameras or a CT or whatever what is going on. This is please click on the center of the slide with the mouse, and because we're going to see this product. This is a initiative from Boston Scientific, and we're going to wait 4 seconds because we're going to start watching videos in the different categories. We see the provisional one stent technique, how it should be performed. We can see how to move to a second stent if the provision is not adequate, or we have also the description, step by step, very visual, very easy to see how the stents platform and the formatting in these videos. Then this is what adds eyes on, because you are watching the video in your PC, in your smartphone. You can also practice this in the model if you are going to a meeting or the company is providing this maybe to your institution, whatever. Please, next slide, because I need to go out of these videos. It's not automatic. Please go to the next slide because I cannot from here. That's it. Then, of course, this is my institution. We have these models. We developed this. It's easy now. You can do 3D printing with your engineers in the center of simulation. And these are my people. We have an expert operator training a fellow, and they are doing different things, extracting thrombus, or they are doing bifurcations, wherever. But this should be implemented with a new thing, that is to put these bench models in fake CAD labs. What is I say fake? We have a simulation center just close to my hospital, just in the same facility. And simulation model is what we are doing now, not only for bifurcation, also for TAVR, for whatever, but simulation is a new paradigm in education, no? Replicates the fundamental aspects, allows training with our rigs, no patients at risk, adapts to the adult learning mode, experience and reflection, facilitates standardization and promotes interprofessional training. And then we are moving from this, in the left side, when you had the bench models, to do the crash, to do the culotte, whatever, and then we put the same model in the patient. This is a fake patient, but you have the polygraph, you can recreate even hemodynamic complications, perforation, tachycardias, whatever, and then the operator has to do the technique at the same time that is thinking in the clinical scenario. This is not a real patient, this is a mask that is designed to look like a patient, but this is a simulation center, the other people is watching from the other room. This is a simulation cath lab, and this is, I think, the new, the last cutting edge in the education for our techniques, which is to put these bench models in the context of the clinical scenario in these simulation cath labs. Thank you.
So, Chima, I'm jealous. That looks magnificent. So, long gone now then is, in the UK we talk about see one, do one, teach one.
Yeah.
No?
Yeah, exactly. That's the philosophy, no? They see how others guys are doing, then they do it by themselves, and they, like this operator is teaching others, younger than them, to do it. Definitely.
So should anyone do a left main before doing it on a human, before doing it on a simulator?
This we started this program with TAVR. Nobody is starting TAVR without doing the TAVR here. And now the young fellows are doing the left mains here and then go to the reality. And one day they say, okay, this is your first culotte in a human, but not your first culotte in a model that resembles what is the anatomy. Then they say that the feelings, they know the feelings, they know the steps, they know the pitfalls. In a more real way, than just watching the papers and the videos.
Chema, this is great. Congrats. That's I got a lot of things in my head now with my fellows. I'm going to send it to your place for a while. But one of the things that I've learned, I'm working with urologists that are doing a lot of robotic surgery. And one of the challenges that they had at the beginning was that when people were starting doing robotic surgery, prosthetic surgery, they had a lot of complication with the robot. And then people say, they started, stop, I don't want to use the robot anymore. I had a complication. And then Medtronic was panicking because they don't want to use the robot. We want them to use the robot. So what they decided was to engage into a formal program of training. Now that has evolved, the facility that they have for the physicians training is great. And I think the philosophy is exactly yours, is you should not be doing your first left main PCI on a patient. That has to be done here. You need to understand the techniques, the hurdles, where things can go a bit more difficult than what it is. And I think that's the first step. And then after that, I think your next step will be, when are we going to be ready as a community to establish some sort of best educational practices? You know, how many in your model left main PCIs you need to do to go to the first human and so forward. So any thoughts in how these fellows grows in this process?
This is a process, exactly. I show first the papers. I mean, any fellow have to know the consensus from EBC. It's a mandatory thing, it's a Bible. Then one day read this and they know the steps and why these steps make sense, because there is evidence behind that. Then you can show these nice videos, like these videos that Boston is going to release that are fantastic, because you see how the technique is really in motion, not just the drawings or the graphics in the paper, but now in the videos you can see how the wire is crossing. Why should we go distal and not proximally? Because you go proximally and you do the dilatation, you see the deformation of the stent, you see how ugly it is. And then if you are, it's not difficult to have now these bench models. You can just with very simple plastic and 3D printing you can get. They do the procedure in this, and then if you have a simulation center, this is the last step, no? But it's step by step, that you cannot skip. You have to go in this process. And then the humans, of course. Initially, simple bifurcations. The fellow should perform first all the provisional with no very complex bifurcations, and then move forward to more complex scenarios.
Question for John.
I think the point that we also made is that people don't use intravascular imaging is because they cannot interpret the images, right? And so in your 3D models, or can you also at least teach them to recognize certain things about the stents, maybe not plaque characteristics because you can't simulate that, but at least when you get in the distal cell, when you get into the proximal cell, what happens, what is the stent deformation, etc.
Absolutely. We put the IBUS catheters in these models with the fluid, with the saline, and they see the IBUS. Of course, it's easier to watch than an artery because there is no calcium, whatever. But it's very fun because they understand more easily the human imaging when they have seen this experimental imaging we do in the models, because the stents look the same. Of course, more circular, everything is more regular, the shape, but it's a very good point, yeah.
So just maybe one further question to you, but so obviously Boston, you've shown those fantastic videos, which I think Olivier Daramont was involved in the preparation of, and very much adhering to the EBC consensus. Now, clearly those models are probably most useful to the physician undertaking the procedure, but this is a team sport. We work in teams. Are you using your simulation for training of the whole team, or is it very much physician directed?
Nurses
How
as
are
well.
you doing that?
Nurses as well.
Across everything, hands-on
exactly.
as well as everything.
In the pictures, there were nurses behind that they are watching what's going on. They are giving you the different instrumentals, the different devices, and because it's important for them to understand what is going on. When you say, "I'm going to cross this, I'm going to cross the wire for this," the nurse should be engaged in the procedure. That's why we have always nurses in all the simulation courses.
Okay. Tom, one last comment here. Maybe Chairman, you can pitch in. The way that I see this evolving, and I see this in other fields, is that you go to the simulation training, and then you have these cameras looking at all your movements, and these cameras are capturing major and minor mistakes.
Yeah.
And then you get score. Okay. Oh, you did DK crush in the left main, one minor mistake. Oh, one minor mistake. You get the 9 points. You get 8 points. Do you think that, and that is all AI based, which is the beauty of this. Do you think that is the future of this type of technology, to be able to certify physicians in the bench before they go in the lab, especially for this type of techniques?
Should be. Certification should be that way, but indeed it's not. No, you see the fellows, how they are training. Every center is different. And in some centers it's very wild. They're just doing all the procedures. They are going to the primary PCI. Then we should be more formal, more serious, and to provide certification. I think the patients deserve to be treated by people that is competent, and not to have them be lucky. And today is Tom doing the procedure, I am very lucky, but tomorrow is a fellow, I am not so lucky. It was a bad day for me. Then the fellow should be certified by Compass Techniques. In coronary, maybe CTO, bifurcation at main. In structural, of course, TAVI, MetroClip. But in coronary as well. Those are right.
Brilliant. Thank you. The music suggests that we have overplayed, but Carlos, you asked the last question, but it's fitting that you can step up with the music. So the final element to this is about mentorship and how we perhaps take the younger physicians forwards on this educational journey. Carlos?
Good. So the question assigned to me by Tom was basically, what is your role as an educator in the left main for treatment of the left main? And I think that there are three main concepts that I think it's very important when you're thinking about young colleagues. Basically, how to transfer the knowledge effectively, how to develop their skills, and I think there is a lot of human factors, especially in left main PCI. I'll try to explore this, started with knowledge transfer, and I think we have discussed that from the first talk. I think all the fellows engaging in treatment of left main should be proficient in intravascular imaging, and they should know pretty well how to interpret angiograms. I think this is something that people don't speak too much, but I think being a good angiographer is quite important. And you need to understand how your devices work. Because when you understand the image and you understand how your device works, you make more wise decisions in order what to treat. And I'm a big advocate of physiology, and I think physiology should be part of every left main PCI, unless it's a very critical left main. So I think what is usually informing us in terms of decisions is basically the clinical presentation and the angiographic picture. But I think when you mentor people, they need to be aware that that is only a part of the disease that they're treating. And if they are not looking at the plaque, and if they're not understanding the flow, they will be doing not the best job. And I think you see these two left main, this comes both from my practice. I will just show you. These two left main have very low FFR, both of them 67 and 60. But the one on the left, it's basically a good case for PCI. This was treated with PCI. There is no pressure drop in that left main. So sometimes we see treatment that should not have been done in the sense that there is no real benefit of doing this type of PCI. And this is, I think, one of the key elements in transferring knowledge. The second one is, of course, how to develop their skills. And here, well, Cem, I'm going to be honest with you. In our hospital is go ahead and do, and I'll give you a couple of times, and then I take it over. But I think that can be improved. And they are trained, of course, how to re-image. They're trained to use all the balloons. They're trained to use hysterectomies, and they're trained to use PCI techniques. We do have a wet model in the cath lab where they train how to do two-stent PCI techniques. I think one of the important challenges in PCI is also how to handle complications. Complications occurs. This is, sorry for the music. This is just a nice video from the hospital quite recently. We couldn't retrieve the balloon after basically post-dilating. And I think I was with the fellow, and we kind of kept calm, called the surgeon, everything will be okay. Everything was broken inside the patient. But I think this is a very important part of training the physicians, of training the fellows on how to deal with this type of complications. And that takes me to the last point, which is the human component. And the human component is basically, in left main, there is a very dynamic PCI. You have to sometimes improvise, you have to change the balloon quickly if you don't cross. So I think that the decision-making process, they need to get used to deal with this scenario, and they need to go through hurdles. Left main PCI, especially calcified left main with two stents, that can be sometimes difficult, and they need to live through that experience to basically learn. And in our hospital, we make a lot of emphasis on trying to develop for those fellows that have an academic pursuit to really encourage them, because we believe that this is the people that will be generating the evidence in the future, without forgetting that this is not just a high-risk PCI and let's do it, but it should be really patient-centered. We also insist a lot about planning. In our cath lab, this is basically what a left main PCI look like. So we are already aware that's going to be a left main coming on the table. And this is, you already know what you're going to do. This is a provisional strategy. The stent, one crossover to the LAD. You have to cover those calcified nodules. You will use IVUS to size the left main. But basically, this is not a surprise. And that really enhances the decision-making process in the cath lab. And again, in my view, this will certainly influence the outcome. So I think, to conclude, Tom, that's my last slide. I think that the next generation of physicians should not only be skilled in treating what they can treat, but also should be trained how to decide well, and again, nurture them from the academic point of view to further advance the field. Thank you.
Fantastic. How many simulations do you have to do before being competent at withdrawing a balloon from the pericardium?
That was a stressful situation. Yeah, but you learn how to snare when the snare fails, then what to do next, and then you are in a mode of, okay, we have a complication. What are we going to do first? What are we going to try second? The surgeon is there, but wait, let's try something first. And I think that management process of complications is extremely important.
So obviously that presentation was focused very much on the training of junior colleagues or young colleagues early in their development. We haven't really touched upon the slightly more intransigent, less willing senior colleagues. Should we be focusing a similar amount of attention on colleagues across all kind of age groups, or is it just that we're going to get the greatest gain from catching them early?
Well, I choose my fights, and I think that is with the fellows is easier. If you seek, for example, the trend of intravascular imaging in my lab, all the young physicians are using a lot of IVUS and OCT. The older physicians are less likely to be using image. So I think that there is a change in the field. You see it, you see the numbers. But again, I think that we should focus on the future, which are basically the young physicians. That's my opinion.
Okay.
I think it's a good comment. I think it's a team effort, as you were alluding to earlier. It's also the nurses, the whole team. So if you give this to the young fellows, to the nurses, also the more senior ones will also adopt, as if the whole environment encourages imaging, CT, whatever. So we will gain all of it.
Eve's got a comment. We just get a microphone. It was interesting. There was some data presented in the very first imaging session this afternoon from a Korean group, demonstrating that actually the senior colleagues were using more imaging than the younger colleagues. So again, regionally, we have very different practices, and so some of it is philosophical and it's cultural belief about where you get the best results. But Yves,
just about the mission we have in EBC. what I heard in this session is something that had been enriched, and why not next year build a way to how to teach, how to train, how to measure the quality of the operators. I think can be a topic for the next the future meetings. So I think this what you have presented has to be. Maybe you have to work together to, and maybe find other people interested in this field. I think this is a major problem to teach our young fellows to help to share with the young operators when we will replace you. It will be very important to. And the idea of certification for me is also something very important.
So congratulations for the presentation and the selection of the topic. It was very, very provocative. And I mean, I don't know why, but I become for EBC co-chair for the committee on education and training standardization. So for each of you, I mean, there is an opportunity to contribute in this. And so, I mean, you know my email, so be in contact because we really need to have motivated people in this regard. Thank you.
So, I mean, even Francesco, thank you for that endorsement. The music is playing. I think, so Anas, go on. One last, but they're going to kill me. One last question, but from a fellow from Graz, very appropriate.
So, exactly. I mean, my question would be, how confident would you be to let a fellow do a complex left main off, or would you allow at all a fellow do a case of left main? And because from a fellow's perspective, I think I would be much more comfortable to be a first operator next to a second operator who is much more experienced than me during a fellowship than to face that later on during the career where nobody would save me.
Well, in the lack of any standardization, Francesco, I'm going to reply what we do, and maybe Tom and Chairman Jacob, you could say your institution. So our fellowship is 2 years. In the first year, the fellows will not do any complex procedure, only very simple PCI. In the second year, we let them do the complex PCI with us next to them. And basically, it's a matter of feeling, and it's very individual because you have fellows that are very skilled, others are less skilled. But when you let them do, and when they start struggling, then you kind of intervene, and that's the way that we handle that.
I think we do pretty much the same, to have somebody next to you and letting the fellows actually perform the PCI with a pair of extra hands. So I think from this you learn the most.
Yes, totally. The first procedures in the lead main on a complex PCI, they are always second operators. They are helping you to do it. And when they have been witnessing maybe 25, 50 lead mains, one day you say, guy, you in this side. And they start to do it always you inside, not just watching ahead. Sometimes the senior watching out from the cat lab, having a good chatting conversation with the nurse, and the fellow doing inside whatever, and then what's going on? And I don't know, ST elevation, whatever. You have to be inside with the scrap, ready to help, and that makes the fellow to feel comfortable into the procedure, and you give an indication, look at this is going this and that. And then at the end of the second year, then they are first operator, and you can be more apart watching how they work and still correcting, because 2 years doesn't turn you an expert. It's just an initial.
Yeah, so I mean, I think this is the perfect point to conclude. We are on a journey of continuous education. So to think that you learn everything in 2 years of fellowship is fantasy. But the reality is you're in the most protected position as a fellow, where you're not, there is always someone there to guide and help you. It becomes very lonely as a boss, and potentially quite isolating in terms of understanding how to develop and evolve your techniques. What I hope that this session has provided, though, is a kind of blueprint for how education should be delivered for fellows, for junior consultants, and for even the more senior consultants, where there is still a need to continue to learn and develop skills. And so we have to thank Boston for the Educare program, as we see a platform from web-based videos to then engagement with models to then hands-on and peer-to-peer engagement for the physicians and for the cath lab teams. And as Francesco has alluded, there's a greater emphasis increasingly on developing those educational programs. And so we'd love to hear from you any thoughts or ideas at how we develop that for the future. So I think we move on to the next session. But thank you, team, for a fantastic debate.
So this is the Bifurcation PCI Complication session, recognition and solution. I'm chairing together with Sonia Salinger and Dr. Dobrin Vasilev. And in the panel there is Shazia Hausain, Luc Maillard, Victor Sasi, Matteo Perfetti, which is in the, and Dr. Juk Dijkstra. So we have 5 cases, 12 minutes. I want to introduce, at the end there is a vote for the best case. What is the best case? How can you judge the best case? So I connect to the previous session about skillness, what is the skillness, what is the technical point that we have to know, and what is competence. So there is difference between skillness and competence. Competence is when an interventional cardiologist knows the topic, knows the tip and tricks, but then he has some experience. So there is the character of the operator combined with the skillness and then the experience. This is the reason why we need some years to become an expert, which is knowledge combined with skillness and practice. So when you have a complication, it can be a preventable complication because you did some wrong things, because we were not a real expert, because you lack some competence. You have not the character. Sometimes the complication is unexpected. What the difference between the two? When you are a real expert and you have a complication, usually in your mind comes some creativity. This is the difference. So I want to judge you because creativity comes from something that an expert, which is dealing with everything, is not. So he has the creativity, and this I think is what we have to judge in this case. What is the best case based on this? So I want to introduce the first case, which is from Dr. Kasturi, presented by Dr. Kasturi. It's a high-risk PCI with Impella.
Dear EBC Chairman, thank you for giving me opportunity to present at EBC 24. My presentation is high-risk PCI of calcific LM bifurcation IVL modification with impeller support. This patient came to us with a cardiogenic shock, acute pulmonary edema. And when he came to hospital, he was in a gasping status. Immediately we intubated, and there's a markedly elevated lactate levels. Because of the desaturation, intubation was done. Next day, patient became conscious and he self-extubated. So if you see the angiogram, then we did angio shows severely calcified left main disease and extending into the LAD and L6 with diminished flow, right coronary, PDA at the origin about 50 to 60% narrowing. So because the angiographic calcification, what we thought we'll go with bifurcation stenting, whether to go with provisional or left main to do the IVS evaluation. Always see the extent of the plaque, severity of the plaque, is it extend to the main vessel or the main branch, side branch, and accordingly you can take the decisions. So always use the intravascular imaging while doing the left main bifurcation, and preferable to go ahead with the provisional stenting because the MACE rate is much lower with provisional stenting compared to two stents. But if there is significant side branch disease, long segment disease is there, large side branch is there, definitely we should go with the two stent technique. So before doing procedure, because the patient came with acute antival MI, we assess the cath. So right ventricular pressures are normal. There is markedly elevated LV, and we classified it as a LV dominant shock. So initially IABP support was given, then subsequently we exchange it to impeller. So impeller always when you give a protected when you give MCS support, identify but classify the sky stage. Is it a DR? It comes at a DRE. And at the same time, early MCS support you give. And at the same time, if patient is having biventricular support, go with even RV. If patient is having associated RV, go with early right ventricular support also. And RSC is the key factor to decide what type of MCM support a patient is going to require. And give the inotropes very short period and minimize the duration, and the number of inotrops are also reduced once you start the MCH. So this is IABP and the temporal pacemaker balloon tip, and you see the very significant reduction in LAD and L6 flow, initially pre-dilated at 1.5 and 2.5 balloons. So after that, again, we did with the 2.5 balloon dilatations, that is LM, LAD, and LCX. So then we thought that there is significant lesion. We were feeling grating sensation. Then we used IVL, 30 pulses were delivered to LM and 50 pulses to LAD, that is 3.5 into 12 balloon. Subsequently, again, we used the angiosculpt to modify it further. IVL is useful in superficial, deep, eccentric calcium and even calcium nodules. So, and associated with very low complications. Dissection is low, slow flow, no flow is very, very low. And cutting balloon and angiosculpt definitely advantageous. The intramural hematoma, less chances, the melanocele effect will not be there. And controlled dissection, so less inflammation and more luminal gain. We were negotiating the stent. We were unable to place the stent. Again, dilate with 3 balloon, further modification. Again, retried but could not. Then we used guideliner with inchworm technique, and mid LAD was stented with 2.75 into 38 and proximal LM to LAD 3.5 into 48 So after stenting, LSE got occluded. So when sudden occlusion is there, always assess the side branch and predict the side branch closure. If the long carina is there and at the same time plaque burden is more, the chance of closure is more likely. And always keep the jailed side branch and jailed balloon. You should be familiar with the techniques like a jailed balloon technique, modified jail. There are various techniques. So operators should be familiar with the various techniques, how to prevent the side branch occlusion. And then we did the LM part. So when you do the LM part, if the part balloon is beyond the carina, it can compress the carina, it can lead to side branch occlusion. If you extend to proximal, it can cause the proximal dissection. That is also associated with increased MACE rate. We used a supercross to place the wire into the L6 and dilate is 1.5. Now you got the flow Again, we thought of opening the side branch with a 2.5 balloon, but we were unable to place. And then we used the, see the guide liner, inchworm technique, we placed in the proximal LCS, mainly to place the stent. And the stent was placed with the guide liner help into the LCX. And see the kissing balloon using the same stent balloon pulled down, and then 3.5 balloon in the LAD. Then we performed the repart. So repart again, it has to be done once you complete the final kissing. Still, we used NC again to do further kissings. And you should be familiar with the stent expansion capacity and avoid under expansion. LSX is more prone for under expansion. And if under expansion in two stenting has to be with a very high restenosis rate. So avoid the under expansion as much as possible. That is 24% versus 5.4. And this is the post dilatation with 3 mm balloon. And we use the OPNNC dilatation further to modify it further. You should know the technique of the kissing balloon, and both balloons should be deflated simultaneously. That is a very crucial point one should remember. And we used 2.5 mm NC and 3.5 balloon. So this is a final angiogram view. You can see nicely flowing vessels, LAD forward TIMI grade 3 flow without any dissection. L6 is flowing very well. So careful analysis of the bifurcation with angio and intravascular imaging for plaque modification, morphology and distribution. And severely calcific lesions require adequate plaque modification prior to stenting, and spade side branch occlusion and prevent the steps to side branch occlusion. Once occlusion takes place, you should open it and provide the antegrade flow. Use a guide extension catheter to expedite the procedure, and always assess for the MLD max. That is very important. Perform right heart study to decide the how is the RV pressure, LV pressure, what is the what type of shock is there, RV dominant, LV dominant, biventricular dominant. Based upon that, you can choose the MCH, and early escalation and de-escalation strategies required to reduce the MCH related complication. I thank once again from the bottom of the heart to Chairman, EBC, and all other executive members for giving me this wonderful opportunity. Thank you, one and all.
In this case, we have in the last consensus paper we have all the technique that he used to protect the side branch from occlusion. We start from the jail wire. When you have a jail wire and you occlude the circuit, you can go below the strut of the stent. If the balloon doesn't cross, you can use a balloon in the stented to like an anchor balloon and go below the strut of the stent to reopen. You can use a microcatheter, a Corsair has been described to go in this case. Sometimes when you have difficult anatomy like this, the jail balloon is, there are different from Buzzotta presented the first case many years ago of jailing balloon. There are modified inflated balloon. There are some techniques that can use in this high-risk patient because it was put in Pella. So if you have a closure of the circuit, you should be pay attention to all this. I think that in this case, my opinion is that circuit should have been more protected than it was, and then the operator was able to reopen the circuit. But I don't see that a wire in the circuit when the circuit was occluded. So there was some strange, something happened and the wire was removed, or I didn't put a protection wire. So other comments?
I think it's a very nice case and very well demonstrates that left main are probably different than regular coronary bifurcations. Now, what Remo said was quite important, and congratulations for the case that they were able to reopen the circumflex. But if the patient is in cardiogenic shock, I must agree with Remo that it's most important to at least keep it open all the time. I mean, the circumflex is a huge territory. The patient is already in cardiogenic shock. So at least to consider an upfront modified GL balloon, because the plaque moves there where there is some space. And there was no more space other than the circumflex. So I think this is what we do in our daily routine for left main PCIs in acute coronary syndromes, and there is basically no occlusion of the circumflex because we leave some space with the jade balloon, which is undersized. It's about the balloon to vessel ratio 0.8, and that's the reason that we can still, if there's some problem with the opening of the left main LAD crossover stent, we can still some crush or inverted crush we can do. So I think it's at the end it's congratulations because it's a very nice case, but demonstrates the importance of the left main LAD circumflex triangle.
Thanks. The only comment I had was that I didn't follow all the steps, and I was unsure whether or not there was any intravascular imaging to guide this case at the beginning. It seemed that, I mean, the operator's not here, I don't think, to answer the questions, but it seemed we went straight on to shockwave, but we don't really know what the ostium of the circumflex, what the plaque composition was there, whether or not that was calcified, and whether or not there would have been any benefit in shockwaving that as well, because we know that's the area that restenoses in left main bifurcation stenting, and whether or not there'd been some modification beforehand would have reduced the risk of the circumflex going down.
Okay, we can move to the next case. The title is Ho-Ho, Have Got a Crush on You, and the presenter is Dr. Shin Karyol.
So, dear members of the chair and panel, dear audience, my patient was an 81-year-old lady with some cardiovascular risk factors who presented to our institution to undergo coronary angiography due to a stable angina from CCS class 2 and exertional dyspnea. Her ECG showing sinus rhythm without signs of ischemia, and the echocardiography showing a preserved left ventricular ejection fraction without wall motion abnormalities. This was the index angiography showing a fairly diseased LAD with a severe stenosis in the proximal part and the Medina 111 bifurcation lesion of the LAD and first diagonal branch. The circumflex artery, as well as the right coronary artery, showed some disease but no relevant stenosis. So we decided to treat the LAD. We wired both main vessel and side branch with 2 workhorse wires and then performed balloon dilatation of the main vessel with a 2.5 millimeter NC balloon. Dilatation of the side branch with a 2.5 NC balloon followed. This was the angiography after lesion preparation, which shows a dissection involving mostly the proximal and distal main vessel as well as the side branch to some extent. So according to the bifurcation treatment algorithm, we opted for a 2-stent strategy and choose culotte technique for our case. We implanted a 2.5 drug-eluting stent in the side branch. This was the angiography after stent implantation into the side branch. After rewiring of the main vessel, we performed balloon dilatation in order to open struts towards the distal LAD, and then implanted a 2.5 millimeter drug-eluting stent in a culotte fashion. The runoff after the second stent implantation showed some underexpanded stent in the LAD, so we performed additional balloon dilation there. And after rewiring the side branch, we went for kissing balloon inflation. The angiography after kissing balloon inflation maneuver, though, showed a new onset filling defect within the previously implanted part of the stent of the proximal side branch. This was confirmed in an orthogonal projection. We tried intracoronary bolus of tirofiban. The situation didn't change. We then went for stenting of the proximal LAD, and we tried some multiple balloon dilatation of the filling defect within the stent in the proximal side branch. And even after aspirational thrombectomy, there was an unchanged situation of this filling defect. With the patient being hemodynamically stable and asymptomatic, we transferred her to the IMC under a drip of unfractioned heparin and tirofiban, and we got her back 48 hours later for follow-up angiography. As you can appreciate from the follow-up angiography, there was basically an unchanged situation here as well. So at this time, we decided to use intravascular imaging, and we performed an OCT pullback from the first diagonal branch into the proximal LAD, which is displaced here. And as you can see, there is a distal stent edge dissection, which is very extensive and extended in the subintima. Right now, you can appreciate some backscattering in the false lumen, which has also his correlation at the longitudinal frame of the pullback. And basically, what we were dealing there was a partially crushed D1 stent within the subintimal space. Now we are in the proximal main vessel. There is some tissue prolapse at 4 o'clock, and the more we go proximal, you can appreciate throughout the whole proximal part of the stent that there is malapposition and underexpansion of the stent. So, with the aid of a 3D software reconstruction system, this was the OCT Plus software from Pulse Medical, Shanghai, China. You can appreciate the moving image, so that's the right part of the screen. It is a longitudinal 3D reconstruction of the problem we were facing with. The lower part of the reconstruction is displaying the crushed stent within the side branch, whereas the upper part of the reconstruction is the part of the stent in the proximal main vessel with the open struts towards the distal main vessel, which is not reconstructed in this frame. We therefore wired the side branch and implanted a 2.5 millimeter stent in order to exclude the dissection and in order to connect the true lumen of the proximal vessel with the true lumen of the side branch. This was confirmed then on another pullback, OCT pullback from the first diagonal to the LAD. You can see that the section has been excluded, and there is apposition of the struts in the side branch. We are now entering the main branch. There is better apposition and better expansion of the stent right now in the proximal part of the stent. I didn't show it for the sake of time, but we performed some balloon dilatation and optimization of the proximal part of the stent as well before running this OCT pullback. This is the 3D reconstruction of the situation after the second stent was implanted into the side branch, and you can now see both the distal part of the side branch as well as the proximal vessel were expanded. At the final runoff, there was basically no filling defect anymore. We were able to discharge the patient 48 hours later from our institution, and we got her back at 4 weeks for a follow-up. These are both cranial projection showing T3 flow and no signs of filling defect anymore, as well as a good expanded stance in this bifurcation lesion. So my conclusion on this case: bifurcation PCI requires time and a steady mind. Skipping steps often has negative consequences. Should complication occur, early performance of intravascular imaging is paramount to better understand the underlying pathology. Last but not least, thorough understanding and meticulous execution of all bifurcation PCI steps should always be performed to avoid problems and achieve the best result possible. And as Admiral Hopper said, there is nothing to prolong your procedure more than a shortcut. Thank you for your attention.
So you say you avoided a step. Which is the step that you avoided? Maybe the pot?
We skip pot. Exactly.
Yeah. So when you have abdominal rewiring, probably you have an abdominal rewiring. Inadequate pot is one of the reasons. You can have you not go to the proximal part with the pot. You skip pot completely, which is something. Then you possibly my explanation, you could have been subintimal from the beginning. So you crash the proximal part of the stent that you implanted in the. This is one possibility. So when you implanted the stent in the LAD, you already crashed part of the stent coming from the diagonal in the proximal LAD. Okay. Then when you try to go with intended culotte to the distal, the crash stent directed the wire subintimally. So you crash completely also the other. The second explanation is that not doing pot, or maybe you were in the correct lumen, but when you rewired, okay, the diagonal, you went distally. We went distally, but the stent were subintimal, so you crashed completely with the kissing balloon, the stent. So probably, yes, pot should have been done, but even if you do pot, sometimes if you have a stent there and you go distally, but the stent is not opposed, you can still have this problem with culotte. Culotte is you have many steps in culotte, and so is a double provisional. So if you have a proximal wiring of the two, you have many layers, and then if you are subintimal, you can crash the stent, the first stent implanted. Other comment?
Thank you for your comment.
Congratulations for the nice imaging. Remo is absolutely right that pot is mandatory, whatever you do for bifurcation. I think you skipped also one other thing that you have to keep in mind, that double kiss, even if you do culotte, should be mandatory. And also pot, because you see that double kiss crash has very good results because of the double kiss. Now, there are some cases and there are some reports that double kiss culotte is probably also could be competent, at least, or competitive with double kiss crash. And if you do that, you could avoid at least less subintimal passage if you didn't do pot. So if you do double kiss and you do pot, this would not have happened. But congratulations for the excellent images and the way you solved it.
Okay. Thank you.
I think that sometimes we can use only just a stent boost or stent enhancement before imaging, just to help to recognize some complication that can going on. Is the first, and the second, we should keep in mind and pot and dot also, and that an all patient, and we have keep in mind that there is all calcification in his intima. And then when we are looking for coronary artery and stenting, we should keep in mind that we can go on with some complication. And just to look at the stent boost, and after that, if you don't have an imaging at that point, we can stop a procedure, not to move on for complication.
Thank you.
I think the key here was that you should really have done the imaging when you saw the issue, because it's not clear whether that was thrombus. We just assumed that it was. I think there's a question in the audience.
Yep. Just a comment. I think sometimes we start a case and we sort of make a plan, but you should be able to divert and change your plan according to what happens in the case. Now, in that case, correctly, I would have started off going for culotte, but once there was quite a lot of dissection in the LAD, with a culotte, you have to rewire the LAD, you lose your wire. So I would have converted it to a DK crush, because then your main branch wire never moves, your LAD would have been secured, and I think it would have also made it safer. You know, you were lucky enough that you crossed into the true lumen, but you could have gone into the dissection plane, and it would have been a disaster. So always be prepared to change.
Okay, thank you.
So we can move to the next case, which is stent elongation and fracture, presented by Dr. Narayanan.
Dear Chairman, thank you for the invitation to present at the EBC 2024 meeting. The title of my presentation is Stent Elongation and Fracture. A 67-year-old gentleman presented with progressive effort angina since 2 months. His exercise stress test was positive at low workloads. Since there was no response to multiple anti-angiogenic medications, he underwent invasive coronary angiographic evaluation. Angiogram showed there was a diffuse lesion extending from proximal LAD, extending to distal portion of left anterior coronary artery. There was a medium-sized diagonal that is arising from the diseased LAD segment. Obtuse marginal had an irregular 60 to 70% stenosis in the osteoproximal part. Right coronary artery was diffusely diseased from the proximal portion and was totally occluded after large acute margin. The mid and distal RC was filling from homocollaterals. So in the initial setting, we revascularized the RCA-CTO with a hybrid revascularization strategy with a drug-coated balloon from mid to distal RCA and a drug-eluting stent from proximal to distal RCA, followed by pot with appropriately sized balloons. Angiogram showed good results in RC. On day 3, he underwent evaluation and management of left-sided lesion. We started off with the OCT pullback from distal obtuse marginal, which showed that there was a lipid-rich plaque in the osteoproximal portion with the critical MLA being 2.17 millimeters square. So the lesion was pre-dilated and stented from ostium with a 2.75 mm drug-eluting stent, followed by post-dilatation with a 2.75 mm non-compliant balloon at 14 points. OCT pullback confirmed that the stent is well expanded with good MSAs at all sites. A pullback from the distal LAD showed there was a lipid-rich plaque extending from distal LAD with a critical narrowing at proximal to the septal origin, where the lesion MLA was 2.06 millimeters square. The distal reference vessel diameter was close to 2.4 millimeter and proximal reference was 3.2 millimeter. The osteoproximal LAD and the left main were free of luminal narrow. So with this data, we pre-dilated with a 2.5 mm non-compliant balloon. I sized the stent according to distal reference and placed a 2.5 to 34 mm drug-eluting stent from ostium of LAD, followed by pot proximal to septal origin with a 3.5 mm non-compliant balloon at 18 atmospheres. The angiogram after stent deployment showed a critical discrete narrowing distal to the stent, and the OCT confirmed that this was a stented dissection just extending to media an axial length of more than 2 millimeters. So that area was covered with a 2.5 mm drug-eluting stent, followed by post-dilatation 18 atmospheres. The repeat OCT showed well-expanded stents in the mid and distal LAD, but to our surprise, the osteoproximal portion of the LAD had shown absent stent struts from 2 to 8 o'clock position, and stent appears to be elongated, and there was a deformed crimped stent in the mid to distal left. So at this time, we rewired the circumflex and pre-dilated from left main to LAD with a 2 mm balloon, but our attempt to negotiate a 2 mm balloon from left main to circumflex was not successful. So then we again pre-dilated from left main to LAD with a 2.5 mm 3 mm balloons, and then we were able to take a 2.5 mm balloon into the circumflex and approximated the crimped stent completely in the left main wall. Then we placed a 3.5 to 18 mm drug-eluting stent from proximal left main to LAD, followed by pot with a 4 mm non-compliant balloon. Circumflex was re-accessed, followed by kissing balloon with 2.75 mm and 3.5 in LCX and LAD respectively, followed by repot with a 4 mm non-compliant balloon at 18 atmospheres. Angiogram showed very good results, and OCT confirmed that there is no floating struts in the mid to distal left main, and the crimped struts has been opposed to the cell. So the new generation drug-eluting stents have strut thickness ranging from 60 to 80 microns, and this reduction in the strut thickness is primarily done to improve the deliverability to the distal tortuous lesions. But in the main process, it has compromised the resistance to radial and longitudinal deforming forces. Bench-side testing have shown mean absolute stent elongation by as much as 2.2 millimeter and relative stent elongation by as much as 9.5% when you overexpand with a pot pen. And the degree of overexpansion increases with each 0.5 millimeter increment in the size of pot pen. In the bifurcation lesions, we usually size the stent according to distal reference. So the stent is likely to be underexpanded and malapose in the proximal portion. So when we place the pot balloon exactly at the carina, the balloon may slip back and can drag the malapose stent struts and lead to stent elongation. When we are too fast in withdrawing a deflated stent balloon, then it can interact with the potentially underexpanded stent in the proximal vessel and then can lead to stent elongation. Recent series have shown that the underlying plaque morphology has a role in facilitating this complication. Lipid-rich plaque, as in our case, reported to have associated with higher degree of stent elongation by as much as 6.4% when compared to fibrous and fibrocalcific lesions. So in short, stent elongation has to be considered while performing pot. Lesions which need precise placement of stents like aorta vessel ostium and across near the major branch vessel ostia the possibility of stent elongation has to be kept in mind while deploying the device. And pot balloon need to be allowed to fully deflate before withdrawing into the guide. And imaging helps to detect lesion morphologies, which will alert us to be expect or to anticipate this complication. And finally, the order of performing pot, by performing a proximal to distal pot as opposed to distal to proximal, which you usually perform, may minimize the degree of stent elongation as reported in some studies. Thank you for the patient hearing. I'd be happy. Any questions regarding this topic?
I think you answer all the question that because we know from the TOT paper in 2022 that this is the elongation, and the elongation is 2 millimeter every 0.5 millimeter of pot. But probably a contribution was the deflation time and the balloon that you use for pot. So the wings of the pot balloon, if you don't wait after deflation of the balloon, the wings of the balloon can be trap the ostium, and when you remove the balloon too quickly, you elongate the stent. And I have a case of a stent extraction. I extracted the stent completely after I did the casing. After I did the pot, I did the casing, the pot, and then because I was used to remove the two balloons together. From my many years, in all left main, you remove together. Probably the balloon was twisted, and there were 4.0 balloon and 3.5 balloon. Probably the two twisted balloon with the wings, they catch the stent. It was a provisional, and I discovered that there was something in the tunnibus, and it was the stent attached to the two balloons. And so the stent was not anymore in the left main, but was with the two wires inside. So you can, with the balloon, you can even extract the stent. So you put a lot of attention. This elongation is favored by balloon, deflation time. You have to, and also the type of the balloon. This is the mechanism in this case. So TOT proposed to, when you have this ostial lesion implanting, to don't go exactly at the ostium, but leave 2 or 3 millimeters if the ostium is not diseased inside the LAD. So if you have elongation, we will stay in the LAD.
Dr. Narayan, congratulations for the very nice case. But subsequently, you answered all the questions that were maybe probably from the audience and from us. Now, I think what was the very good point, though, that maybe we should consider proximal pot first to secure a stent placement and stent, not to have elongation of the stent, and I think then do distal pot. So I think that would be quite a good idea, and maybe there would be some studies that we should conduct just to prove that point, because that would be an excellent idea not to have stent elongation and do pot first and the proximal part.
Maybe to add that sometimes we should avoid of overexpansion of proximal part of stent, and to avoid to make some bottleneck of proximal part of stent.
It's also depend on the quality of the platform, Not all stents are equal for bifurcation, unfortunately.
This complication is described more with stent with 2 links compared with stent with 3 links, because with the 2 links you have more deformation when you remove the balloon. So when you use 2 link stents, you should pay more attention to this complication, to this elongation. No, you have to use, because sometimes you have to use, and you are, but you should know the tip and tricks using they are more flexible. In bifurcation, sometimes they are useful because you open the strut better, but they are more prone to elongation.
I do wonder also, you had a 2.5 stent, if I remember correctly, and then dilated it with a 3.5, which to me, I don't know which platform you used, but that seems a bit excessive in terms of post-dilatation in a 2.5.
Actually, the packet insert permitted the dilatation up to 3.5. for this particular stent. This was a 2.7 stent, and the packet insert permitted flaring up to 3.7 millimeter.
Just one question. The stent length and the deformation was measured by OCT?
Yes. This was actually we recognized that stent elongated, and it was in the left main from the OCT pullback only. Nothing was visible on the stent boost images and the stent enhancement.
Yeah, then you have to be careful because you had a cardiac motion artifact, and it was very clearly seen in the longitudinal view that you showed. So partially your stent elongation might be due to this cardiac motion artifact. So maybe we could reinterpret the case.
So if there are no other questions, we can go on with the next case, which is the Engi stent, reverse culotte, save the day, and Dr. Richa Sharma will present. Please go on.
A very good morning, dear Chairman. Thank you for the invitation to present at EBC 2024 meeting. The title of my presentation is The Hanging Stent, Reverse Culotte, Save the Day. So this is a 65-year-old gentleman who was a known case of hypertension, and he presented to us with acute onset chest pain. Diagnosis was non-STEMI, in which we can see ST coving with T inversions in anterior leads. Patient's echo was suggestive of an ejection fraction of 42% with LED territory hypokinetic, and he was hemodynamically stable. The patient was explained for angiography and was taken under informed consent for the same. This was his angiogram, which showed that L6 was normal. His RC was also normal, while LED D1 bifurcation was seen, where 111 classification, wherein the austere proximal diagonal was critically diseased. And in this particular view, we cannot actually see the size of assess the complete size of the diagonal. So now the plan was to go with a provisional single stent strategy as per EBC recommendations, or a bailout of T and protrusion if required. I knew that the ostia of the side branch was highly diseased, and if I just go with the direct stenting into LED, the vessel might cut off. So the plan was to just do just pre-dilatation of the diagonal as well. So we took a right radial axis and a 6 French EBU guide, parked two wires run through in LED and whisper in diagonal. And to secure this diagonal, D1 was dilated with a 2 into 10 millimeter balloon, semi-confined balloon at 6 atmosphere, kept there for almost 20 to 30 seconds, so that it will create just a space. And adequate TIMI 3 flow was achieved in the diagonal after this. Mid LED was also pre-dilated. And thereafter, we took a 3.48 millimeter DES, checked in multiple views in LED and deployed the same. There was no distal dissection seen in LED. Diagonal was flowing, but I was not very happy. I just saw that the branch is quite huge and not a smaller one. Ostia is severely pinched, and maybe some micro-dissections have happened at osteodiagonal. So we plan to go ahead with our technique, with our initial plan, bailout plan of T and protrusion technique. First, we did a pot with a 3.75 into 10 NC balloon in the proximal part of the LED stent. And then whisper was recrossed into diagonal, keeping this 3.5 balloon in LED. And I took a stent of 2. First, I dilated the diagonal stent struts with a 2O balloon, and then took a stent of 2.5 into 28 millimeter into the diagonal. At this stage, nightmare actually happened while pulling and pushing the D1 stent to position it very precisely into the keeping minimal strut into the LED. The shaft of the stent actually broke from soft part of the balloon within the tight catheter. Stent, along with its balloon and its softer part, was lying hanging uninflated in the diagonal. So what next? Either I could snare the broken stent, but it was the radiolucent part, and from where actually it broke down, I didn't know that. Or I may balloon trap the whole system, because I already had a balloon in my LED, and remove the whole, pull back the whole assembly. I can also do twisting of wires and maybe create that much of weight, that would create that much of weight, which will pull the whole stuck-up system. or maybe crushing of the stent. But in our case, crushing of stent was out of question as softer part was still there inside. So I immediately took the LED balloon of 3.5 millimeter, which was there inside the LED, back into the guide, dilated it at 4 atmosphere, and retracted the whole assembly. Whole assembly was pulled out. Unfortunately, because I already had a LED stent inside, the uninflated D1 stent, it got stuck within the LED stent struts, while the balloon with a bit of soft part and both the wires, they just came out. Diagonal stent, it got crumpled into the LED stent strut, and a part of it was stretched into diagonal, uninflated. This was a nightmare for me. Now what to do? So the options to salvage the situation, first aim was to save my LED by rewiring the LED, and maybe after that the diagonal needs to be taken care of. Fortunately, my luck was there, and patient was hemodynamically stable. That gave me time to actually fight with this situation. So now I tried to cross the wire into LED, but did multiple maneuvers. Wire couldn't cross the LED because of the crumpled stent of D1 and LED both. And but fortunately my whisper wire, it was again and again, it was easily getting crossed into the uninflated D1 stent. And so we parked one whisper into the diagonals, the uninflated diagonal stent. And with further maneuvering, again and again, we tried to cross the LED wire that maybe at some point of time it may cross not behind the stent strut, but through the stent strut into main true lumen. So we parked that LED wire. We didn't know whether it was through the true lumen or not. We tried to cross with a very small balloon, even the smallest 0.8 Nic nano. We tried to cross it, but the balloon couldn't cross into the LED. So that showed that our LED wire was behind the stent struts. So now I plan to dilate the diagonal stent struts. D1 was first dilated with a 1.5 into 10 mm balloon. Again, I tried that because this 1.5 mm might have created some space. I tried to cross the balloon in LED, but it didn't cross. So the plan was to dilate the D1 stent completely, initially with this 1.5 followed by 2 and 2.5 mm NC at higher pressures of 26 atmosphere. This was followed by the dilatation of the diagonal stent, which was hanging in the LED with a 3.5 mm balloon at 24 atmospheres. Now our diagonal stent was fully dilated. We tried to cross 1 mm semi-compliant balloon through the LED stent struts, but to no avail. So LED wire was removed so that we can recross again. But it was a difficult wiring into LED, and it was not crossing, the wire was not going into the LED through the true stent struts. It was always going behind that crumpled portion. Now what we did was that we parked the LED wire into the diagonal as well, and our balloon was crossing on that. 1 mm, 1.5 mm balloon was easily crossing into that LED wire. That means that LED wire was, that wire was in the true lumen in the diagonals. So after passing that LED wire into diagonal, kept the wire there and took out our whisper wire, which was already in diagonal, and through the stent strut, we went into LED. So now LED stent struts were dilated with a 1.0 and 2.5 mm NC balloon at higher pressures of 18 atmospheres. This was followed by, we first actually put the stent from ostial to proximal LED at 3.5 into 12 mm disc because many dissections and distortions were happening over there. So after that, we took 3.5 mm NC in LED, stent was post-dilated hole, and we also took a 2.5 mm balloon into diagonal, and the final kissing balloon inflation was done with the same. Thereafter, pot was done with 3.75 mm balloon. This was the final result, which showed TIMI3 flow, and all the diagonals and branches, they were flowing pretty well. Patient was hemodynamically stable. Patient was discharged on equestrian and ticagrelor after 3 days. So the incidence of stent dislodgement, it ranges from 0.3 to 8%, and dislodgement of stent can be secondary to extreme coronary angulation, highly calcific coronary artery, inadequate bed preparation, direct stenting, or interference by previously deployed stent. In our cases, 2 things happen: breakage of the stent shaft and dislodgement of stent due to interference with previously deployed stent at proximal to mid-LED. We can do percutaneous stent retrieval by small balloon technique or a double wire technique or loop snare. If stent retrieval is not possible, we can take a new stent and it can push the previous stent against the vascular wall. But in our case, this step was not possible. And also because of the previously placed stent in proximal to mid-LAD, the snare was also not possible in our case because of the presence of that previous stent, the whole of the diagonal stent got crumpled and elongated. Patient was hemodynamically stable, so it gave us time to intervene by recrossing the wires and performing modified reverse culotte. And thus, all these strategies of bifurcations, they should be known to interventional cardiologists because whatever may come handy at what time, we never know. Thank you.
So thanks for presenting this case. And do you have an explanation why the shaft? You torque the catheter too much. Probably you give a rotation to the catheter, not only pushing and pulling, but.
First of all, a very good evening from India, and thank you for letting me present here. So actually, while going inside the catheter, while I was taking the stent inside, I was feeling some kind of roughness, and I said to my technician as well that whether stents are also being made ET or something like that, I said to them. I was not feeling very happy while taking the stent inside. I don't know that particular batch was defaulty or what. That was one thing. The second thing was that I had a 6 French guide. I didn't have a 7 French guide. Tap can be done in that, but maybe that small luminal diameter of the guide can be issue that while I was pulling and pushing and positioning this stent, this might have caused a problem that it got broke up from the softer part. So these were the 2 reasons, because once I crossed the wire through the stent strut of LAD, I pre-dilated with a 2/10 balloon, which could easily get past, and dilatation was done already in the diagonal.
Yes, this is then you solve with this, when you remove you have no other choice than removing together everything with the trapping balloon in the guiding catheter, and you lose the position of the LED, and then another solution was just the velocity. When you see that the stent doesn't come back, maybe you can, I don't know, because you have to remove everything, and this is the solution.
Was actually hanging. Otherwise, snare could have been used, but because that's the radiolucent part, we didn't know where actually it was there and how much it is left inside the guide. Once it got removed, we could see it. I didn't have that. I don't have that picture of that because that was a panicky situation for me. I just knew that this nightmare has been created and patient will develop stent thrombosis if nothing is done.
Yeah, we are lucky to be able to go inside the stent with the wire. This was really almost unbelievable to go inside and then convert in a culotte in inverted culotte. At the end, you were able to go, and then the solution was creative to just invert to create this. Yeah, you were lucky.
Dr. Sharma, congratulations for the nice solution for this particular case. And just one remark that we are coming back to the original question that should we put 2 stents in such a place. So I think that's why probably provisional stenting that has less problems. And even though we don't see, if you don't have imaging for doing such a bifurcation, even as a LED diagonal, you don't see the protruding struts. How does it look inside, even the LED? So, and one other remark is that in our experience with younger fellows, we had a lot of problems, such cases, that losing stents. But if it's too far, we were always unable to have it retrieved, even with the snare, coronary snare, or whatever. So I think in that particular case, you have to settle for crushing that particular stent, wherever it is, and do the bifurcation once again. And one more remark is that with the whisper wires, we are always afraid of. And I always have our fellows and younger colleagues saying that I think that particular wire is not such a clever wire. So it was very lucky to recross with that, because that goes just everywhere. But congratulations for the nice case. These are just remarks that maybe we should keep in mind, that maybe just putting one stent and keep it open strategy would quite be helpful, and maybe have the patient 2 months, 3 months back on the table and see how the diagnosis is doing.
Yeah, just, I mean, it was a great case. Just one comment. When you were struggling to go down into the LAD, you had already dilated the diagonal. I think rather than pulling back and trying to then, you know, you said they were both in the diagonal, so you pulled your diagonal wire and you lost the diagonal, and thank God you got into the LAD. But I think that would be an ideal case for you to use a dual lumen catheter. You keep your wire in the diagonal, come out the side and wire the LAD.
So, sir, what I did was, once this all happened and I dilated completely the diagonal, I kept the diagonal wire there itself, was trying LED to go into the LED, but it was not going. So took that LED wire in the diagonal, confirmed with the 1.5 balloon whether it was crossing or not. It was going through. So kept that LED wire into diagonal and brought back the diagonal wire back into LED with that reverse loop kind of a technique, so that this may fall into the now true LED through the true stent struts and not behind. Because coming proximally, it was always going behind the strut. So coming from diagonal, it may hit somewhere through the strut and go into the diagonal. And then with the 1.0 balloon, we could cross with the 2 followed by 2.5.
Thank you. We go on with the last cases, and then we vote at the end which is the best. So the last case is uncovering the unseen. It's Dr. Proti is presenting.
Thank you. If I can have the slides up. Thank you very much for hosting me today. My name is Maj Proti. I come from Southeast Wales. I've put a dot on the map there for you. It's a hospital called the Grange University Hospital, where I did my 1-year fellowship last year. I also realised that I'm the only thing standing between you and dinner, so I'll try and keep this short. So it was an 81-year-old gentleman who presented with symptoms of angina on a background of previous left main stem PCI, which was a DK crush done by a seasoned operator with a good 5.0 pot under Ivor's guidance. And that was 18 months prior. His symptoms resolved after that procedure until 2023 December, when he had recurrence of his symptoms. He was seen in clinic and then eventually filtered through to the cath lab for a procedure. Angiography plus or minus proceed. He had a past medical history of hypertension, hypercholesterolemia, and being an ex-smoker, in addition to his previous instrumentation. I must say I didn't include on here that his echocardiogram showed a normal ejection fraction. He had a right coronary artery that was very small and vestigial. He's a left-sided dominant circulation. So knowing this and knowing his previous stenting procedure, I went up front with a 7 French sheath in the radial artery and a 7 French EBU35 guide. And I took the first picture, and this is what it showed. You have this critical ISR and the circumflex stent. So I wired it, and I thought I'll just advance a 2.0 semi-compliant balloon, but it was not going. The guide was backing out. I thought maybe it's some support issues. So I thought that's fine. I'll just take a microcatheter and change my wire to a slightly more supportive wire and see whether the microcatheter will cross and create a channel. But as you can see, the microcatheter was taking a funny course, going up and then back down. So I wasn't sure what's going on in here. And I didn't want to lose the progress that I already had done. So what I did is I pinged another wire down the stent, I brought a small balloon, and I stent boosted. And as you can see, the microcatheter is going behind the nicely done 18-month-old 5.0 potted left main stent. So the position is abluminal. So the positive about this picture is that I know that I have a wire that appears to be in the true lumen, endoluminal, down the LAD with a balloon on it. So what I did is I retracted my microcatheter and the wire back into the guide. And there were many options presented to me, but there was a split-second decision. I was feeling optimistic, I suppose. I did this. I took the wire back into the microcatheter. I made my guide as coaxial as possible, and I pushed the microcatheter forward without a balloon leading it on. The rationale I thought at the time was that it's bulky enough to hopefully not go behind the stent struts and follow a wire. And I stent boosted, and it was the right thing. Maybe I got lucky. Maybe it's a new technique that I need to patent. But sure enough, now I've got a microcatheter in the LAD. I advanced the wire, of course, and pushed it up and down the LAD to make sure it's free, and stent boosted here to confirm that it's there. And that rescued the situation, and now is now endoluminal. So I was able to wire the circumflex, balloon it with a 1.0 and a 2.0, and then IVUS. And you can see the stent in the circumflex is nicely opposed, but then you get to this area and the proximal circumflex, which is coming up now, and you can see there is a lot of calcium, aggressive neoatherosclerosis within that stent. A nice figure of 8 at the confluence, and a nice stent in the left main. So this is the still that shows the problem, the calcified neoatheroma. So serial dilation, cutting balloons, and IVL, and then decided to follow a TAP strategy by deploying a new stent in the circumflex, and we can discuss whether there's multiple options that we could have done here, but we were not very sure as to whether there's tissue protrusion leading to this aggressive ISR, whether there's a lack of coverage of that area, or whether there's a mechanical problem. So we deployed another stent of a different manufacturer with a different polymer and a different drug, and we tapped it. And then we brought the balloons back so we can center the metallic neocarina and use this opportunity to go to high pressures to try and push that left main stent as far as possible against the wall. And this was our final result. And we're very happy with this. So the learnings that I made from this case is that abluminal wiring is a risk even after 18 months of the original osteal left main stent, which was done under IVUS guidance with a good high volume operator. But stent boost was really useful here, and I think it was mentioned earlier when we were talking about abluminal positions. Stent boost is a very cheap way to help you detect abluminal versus endoluminal positions. And there's no added expense to it. Most devices, Philips or Siemens, will have a technology that allows for the stent enhancements. And as one of my trainers would say, it is the poor man's IVUS. So we should use it more often if we are in doubt. Thank you very much, and I'll be happy to take any questions.
There are. Yes, go.
So in the index procedure, was there a calcified nodule in the circumflex? Because eruptive nodules can grow like that through a very well stented segment. So in the index procedure, do you know?
No, I looked at the images before because I wanted to see what I understand. And it was definitely calcified and was IVUS, and there was a nodule.
Sorry, okay.
And they modified it as much as possible, but it's very likely, as you said, it's eruptive, so it's bioactive and probably protruded through and developed more.
Thanks. That was a great case. I don't know if you did do any imaging during your one, which wasn't shown, but also you went behind the stent originally, which means that stent is not well deployed. I know you did a KISS, but did you do a pot at the end, and did you get it up the right size? Because you haven't shown that.
No, I did not do a pot. We debated it, but we were worried about disrupting the metallic carina. So we tried to bring the balloons back as far as possible into the left main and go high pressures to abut it. And then the IVUS that I showed after showed that the stents were opposed. But maybe you're right. Maybe the 5.0 wasn't enough. Maybe I needed a 5.5 here. But we made that balance in an 81-year-old gentleman who's been on the table for quite some time.
Thank you very much for the case. Sometimes even if the stent is well deployed, well opposed, you have some struts that prolapse in the aorta, and you may go through these struts in the left main.
I think this is exactly what's happened here.
I think
and on the IVUS, you can see the strut sticking back.
Yeah.
And we do this frequently. Even if you are nailing the top shelf of the left main ostium, the bottom shelf will always have stents hanging out, and we intentionally leave 1 or 2 struts out. And I suppose when your guide comes to engage, it's never really coaxial inside the stent, and wherever your wire goes, you will take it. And on this occasion, they went behind the stent.
Exactly. Yeah.
Thanks, Majid. That was a great case. Just a quick question. You were talking about stent boost being the poor man's IVUS. Do you think the course, you could only see it on the stent boost because you had the Corsair following it? would you have been able to see 2 wires and been confident that one of the wires was abluminal just on a stent boost?
So we need 2 dots to be able to see the stent boost, of course. So I needed a second wire with a balloon in situ. Of course, the second wire could have also been behind stent, but I'm seeing it in a 2D image there. But I think stent boost here was very helpful because I didn't want to instrument this any further, particularly as I didn't know where my second wire was either. So when I passed my balloon and it went in, I was able to stent boost. So that's why I did it.
And congratulations for the treatment of this potentially tricky case. And but just wondering, did you do a final IVUS since it was on the table after everything? Because I'm not sure. Did we see those
no,
pictures?
we didn't.
Because I saw only the angiography.
Yeah.
But you see, it is quite debatable if you don't do POT. Since 2 years ago, there was probably an insufficient POT before, since you could cross the corsair quite easily towards the circumflex. And if you don't do imaging, you don't do measurements, and then maybe 2 years' time, half year, 6 months' time, you could experience the same. So I think it's, and we see that POT is probably the most important step finalizing a bifurcation PCI.
I think
so
that's a very reasonable
that's
point.
some criticism just because since IVUS is on the table, doesn't make a difference. There's no contrast, so how much the patient is lying. And I think it's a crucial point that maybe for others to at least learn from this, that left main is always different than regular other bifurcations. And since you have, and maybe you are going to have a shape of an 8 or some elliptic shape, and there's going to be neo-Terumo also, maybe 6 months' time, 2 years' time, we don't know. But if the patient is probably going to be staying alive because there's quite a roomy left main, so it's not going to be very fast to have a thrombosis or have some little complications. But that's a little criticism that
it's
final POT and final imaging, that's
I
since
think that
it's
would
on the
definitely,
table.
Yes. Well, at the time, I didn't know I was going to be presenting it here. Otherwise, I would have definitely done the IBIS at the end as well.
That's accepted, okay?
We
Answer
certainly,
accepted.
because we didn't want to pot and interfere with the metallic neocarina, we didn't feel that the IBIS was going to add much. But I think you're right. There's value here in considering a pot, even if it's a shorter balloon, even if it's hanging out away from the metallic neocarina.
Congratulations for your cases. And I would ask you if you were able to feel any tactile feedback with your first guide wire, or if it was polymer jacket. And the second question, according to the previous comment, aren't you afraid that the passage of the microcatheter could deform the stent, could distort the stent, so the need for a new pot?
No, you're right. So the wire was meeting resistance at the nodule, and I couldn't progress it as far as I wanted. I progressed it down the distal vessel, but that's why I felt I needed a more supportive wire when going with microcatheter. And sure enough, towards the end, after serial dilation, you needed a 1.0 to go. It's very tight. And you're right in terms of the corsair deforming it. But then the IVUS that I showed gave us some confidence there. It wasn't deformed and malapposed as much, although the valid point of a report at the end is always something to consider.
Thank you.
Okay. I'm not sure the second stent is the ideal treatment for calcified nodule. I mean, perhaps doing a shock wave there, and then,
which we've done,
and did a DCB or something. But second stent, I'm not sure. Most ideal. Nobody knows what the ideal treatment is.
No, you're right. So we had this discussion. So I had it with one of our senior colleagues as well, and we just weren't sure about the coverage of that area, whether there's any mechanical problems, because the calcium dropout didn't allow us to see the stent struts behind it. We weren't very sure what the mechanical situation is. But of course, this is a common place for stents to fail, despite how well you do, particularly if there's an eruptive nodule.
I will make a short comment. Thank you for your presentation. So don't forget the ostia of left main is very easy to displace, deform, modify with the guiding when you come. So the first lesson is when you cannot cross, there is always a reason. And you've done it very well. Take your time, pull back everything, take the good way, and make a new pot. Most probably the stent is deformed, maybe not enough deployed at the first, or mobilizing with the guiding catheter. And kissing is mandatory with two stents for me. I'm not a full adept of two-stance technique for reconstruction of bifurcation. I prefer a provisional T. And we're working with a new technique, how to set the stent without crush, no gap, no overlap, to obtain the best reconstruction bench are running. That will be another study. Thank you for your presentation.
Thank you. Thank you.
So we have to vote. I don't know how to vote. Oh yeah, you have to vote. Use code to assess the vote. Join discussion. Okay, you have to use your iPhone and scan the QR code to assess the vote program. $27 voted. Maybe we are. I think that the Richard Sharma is the winner because it's even if you if you don't. So she is not here. Is here. And there is the prize is on the podium, and congratulations for your skillness and competence in doing this solution of these complications. It was very didactic. Thank you.